What are you doing, Bluetooth?
No, I'm just awkwardly holding my phone.
Oh.
Okay, thank you very much. Good morning, everyone. I think we'll go ahead and get started. Feel free to wander and get coffee and breakfast and register. My name is Seddon Savage. I'm the director of the Dartmouth Center on Addiction Recovery and Education. And on behalf of our tiny staff and Board of Executive Committee, I am pleased to welcome you here. This is the 10th annual Dartmouth Symposium on Substance Use, this year focusing on emerging technologies to advance prevention and treatment of substance disorders. DCARE is a small center at Dartmouth that is devoted to education and to advocacy. We try to bring people together from across the Dartmouth system, from the medical school, the college, engineering and other schools, and from the community, different sectors of the community, to really cross-fertilize ideas and share perspectives on the ubiquitous challenges of substances and addiction in society. To that end, we host a program for students that is to nurture the C. Everett Koop Scholars in Addiction Studies program, which takes students at the college, at the medical school, any of the Dartmouth schools, and really nurtures leadership and a kernel of interest in this field. We meet on a regular basis. We have university seminars that bring together faculty and also with the Koop Scholars. We have faculty presentations and community presentations. We meet over dinner on a monthly basis, again, to cross-fertilize and share ideas. I mention these, I'd just like to say that if anyone has an initiative or research or a clinical program that they'd like to present, we're always looking for speakers who can whet our interest in new areas and help us network with new ideas. And similarly with the Koop Scholars, many of them are looking for mentors and places they can go to learn different approaches to the field. So any of you are interested in serving either as a mentor or doing presentation, we'd love to hear from you. We also have a monthly newsletter. We have, near monthly, I should say, I think we skipped this month preparing for the symposium, and website, with the purpose of sharing resources. We host 2 symposiums in the fall every year. In the fall, we try and focus on topics of interest to general healthcare, to really work towards engaging the general healthcare system in identification, treatment, and intervention in substance use disorders. I think we all know that there's a crying need for that, and we have real opportunities now in the transition of our healthcare system. And at the state level, it is a high priority. So I think we're targeting this fall looking at the science of mind-body interventions for addictions and how to integrate those into care of patients in different settings. In the spring, we try to be a little edgy. We either have a very controversial topic. We've had tobacco harm reduction. Is that an oxymoron? We've talked about lowering the drinking age. We've talked about marijuana as a therapeutic substance. This year, we're being edgy and trying to be very cutting edge and looking at technology. And we are really honored and pleased to be co-sponsoring this with the Center for Technology and Behavioral Health, which is a larger and very prominent center at Dartmouth that I think is leading really cutting-edge interventions to try and expand capacity to treat, to identify, prevent, and treat substance problems. So the day is devoted to that. The Center for Technology and Behavioral Health, you may hear more about from Lisa Marsh, who will be our first speaker, and she's director of that center. My understanding is that from reading a little about it and talking to Lisa, is it really brings together interdisciplinary teams of people with different perspectives, from behavioral health sciences to technology to treatment, health economics, ethics, regulation, public policy, in a goal of really bringing together existing and emerging technologies to develop and deliver evidence-based interventions for substance use and co-occurring disorders. So we're excited to have many of the faculty from that center here with us today, and visiting guests from Yale who I think have interfaced with the center as well. I don't think we could have better partners for today's symposium, and thank you very much, all of you, for working with us on this. Before I introduce our morning moderator, who is Bob Drake, who many of you already know, I'm sure, a little housekeeping. CEUs and CMEs are offered for this. I believe, and I will double check and confirm later, that if you're getting CEUs as addiction professionals, there should be paperwork in your packet for that. The CME seems to be done online, and there should be information on that as well. On breaks and over lunch, I think we're going to have an opportunity to try out some of the technologies that our speakers will be talking about. They may share some web addresses, URLs, or actual hardware, though I actually haven't seen that. So, but hopefully over lunch and breaks we'll be able to do some of that. And then we'll have lunch here. If it becomes a beautiful day, feel free to take it outside. Otherwise, we can hang out in here. It's a lovely space. This is a student center, and hopefully we'll have some students coming in and sharing some of their time with us. So we'll make them feel welcome, should they come. Okay, so on to the morning. It's really a pleasure and honor to introduce Dr. Robert Drake. Bob is a physician and researcher who I'm sure is known to many of you. He's the Andrew Thompson Professor of Psychiatry and Community and Family Medicine at Geisel School of Medicine at Dartmouth. I think those of us who know him or are familiar with his work think of him as really truly visionary in expanding the treatment of people with co-occurring substance use and severe mental illness. He's worked with many teams over many years and pioneered truly the importance of employment and a variety of community-based supports in helping people recover and develop stable and productive lives and experience improved quality of life particularly, again, with respect to severe mental illness and substance use disorders, but across the spectrum of both of these challenges. He's led a number of multi-center studies across the U.S., exploring the relative importance of a variety of these community variables in recovery from co-occurring conditions. In doing so, he's really transform the paradigm with which we treat people and improve quality of life for persons suffering with these dual diagnoses. Bob founded, I think 27 years ago, the then New Hampshire Dartmouth Psychiatric Research Center, now Dartmouth Psychiatric Research Center, and has served as director of the center for many years, stepping down in the past year. But he continues very active in research and working, some focusing now on exploring the use of electronic technology and shared decision-making between patients and providers. So again, applying technology to really advance the field. So I'm really thrilled to ask Bob to moderate this session, and he'll be introducing the speakers this morning and making a few comments. Thanks very much, Bob.
So I don't know what you would have done if I hadn't said to keep it really short. That's okay. Well, it's a pleasure to be here. It looks like one of our Friday morning PRC centers with a few extra people, and we welcome all the extra people, and please join us over at River Mill any other Friday morning that you would like to. You're always welcome. I just want to set the context for this briefly before we move on to today's talks, because the talks are really exciting. I think you all know that the American healthcare system is expensive, ineffective, and inefficient. You know, probably the worst in the world in many ways. Certainly the worst in the wealthy or high-resource countries in the world. And probably nowhere do we do a worse job than in addiction treatment. We are all hopeful that we're on the cusp of a change as far as that goes. I mean, I think that those of you who work in the addiction field are doing a great job and are working overtime, but you probably also know that, you know, 95% or more of people with addictions get no help at all, are not in treatment, and the waiting lists are forever in many places around the country. And we really do a very poor job of conceptualizing this problem, a poor job of public education, a poor job of providing access to people who need treatment, a poor job of following people over time, and on and on. The good news is, you know, on the one hand, the Affordable Care Act pushes us towards integrating addiction treatment and behavioral health treatment with physical health treatment, and may make it easier for many people to get access to treatment. Of course, the downside of that is, what would happen if those 95% showed up tomorrow for treatment? You know, there's no workforce there that could absorb the 95% who are not in treatment. We can't even meet at the door and do a good job with the 5% who come in. But the other hopeful sign, which is what our focus is today, is that we really have the possibility soon to dramatically expand our reach, to dramatically expand our effectiveness, to dramatically expand our options for people, to dramatically expand our ability to help people over the long run and to keep track of their outcomes through using technology tools. You know, there are many, many excellent tools now that are available to help people understand their problems, to help people make decisions about what kind of treatment might work for them, to help people enhance or do their treatment on their own at home, to help people, you know, through mobile apps, to have the supports that are available 24/7, and so on. And this research has been developing over the last 15 years or more now. I think you'll be surprised to hear how extensive the research is. The question for us now really is, how can we embed these things in the real world? In what way are they going to fit into primary care settings, into pediatric settings, into schools, direct to consumer availability, and so on. So I hope you'll be convinced, as I am, that the research is good, and that you'll be interested in helping us think about over the next 5 or 10 years how we transfer all of these technologies to real-world settings. Okay, with that background, I'm very pleased to introduce my colleague and friend Lisa Marsh as the first speaker today. Lisa's an associate professor here in psychiatry. She's the head of the Center for Technology and Behavioral Health, and she's the head of the Dartmouth Psychiatric Research Center. And one of our most fortunate decisions over the last 30 years while I've been here has been to reach out and recruit Lisa to come to Dartmouth. She's really just the kind of leader that we were looking for, and she's been inspirational to all of us in the 3 years that she's been here. So it's my pleasure to introduce Lisa.
Okay, good morning, everyone, and welcome. It's terrific to see everyone here. We're so excited about the day's events and a really great set of speakers and discussion and hopefully engagement with all of you on this topic. Seth and I were just chatting about it would be great to hear who's in the room, and we're wondering how many folks are addiction treatment providers in this space. Great, good to have you here. And what about mental health treatment providers? Okay. Terrific. Researchers? Many familiar faces. Other clinicians that I didn't mention? Okay, welcome. And community members? Any students? Great. Prevention folks. Any prevention folks? Oh, excellent. Well, we have a really nice mix in the audience, and it's great to have you here. I hope we can have really good discussion today as the day progresses. I'd like to thank Stead in particular for inviting me, but also inviting many of the faculty and affiliates of our Center for Technology and Behavioral Health to be involved in this meeting today and to present a lot of the research that's happening in this space and to have a discussion with all of you. And I'm going to kick off the morning with a bit of an overview of the state of the field of applying technology to behavioral health. So thinking about what's the state of the science of applying web and mobile technologies to not only substance use disorders and treatment and prevention around that, but also in the mental health space. So I'm going to give a bit of an overview of what's the sort of promise of this approach in this arena and what are the data generally showing from research in this space and clinical applications of these tools. And then to talk a bit about what opportunities there might be for the future in terms of scaling up the work and the implementation of effective therapeutic tools that are technology-based that target behavioral health. So I'll start with this sort of big picture overview, and then we have a wonderful lineup of speakers today who will cover the full spectrum of development and evaluation and implementation and sort of sustained use of these tools in lots of different contexts. So we have an exciting day ahead of us. So first, I'd like to acknowledge some research support for some of the projects I'll be mentioning, which was largely from the National Institutes of Health, including the center that Seddon mentioned, which is a center grant from the National Institute on Drug Abuse. I'd also like to mention that in addition to my academic affiliation, I have an affiliation with a small business that has been involved in developing some technology-based therapeutic tools. So let's start off by talking about the promise of this approach. Why are we thinking about technology? Why are we thinking about mobile phones in the context of addiction treatment, for example? So when you think about mobile technology and the internet, it's transformed virtually everything about our daily lives, right? So the way we do retail, the way we do travel, the way we do our banking, even the way we meet other people and interact with folks socially, even meet significant others, right? There's all kinds of new models to do this online, remotely, securely, conveniently. And I think that similarly, there's a real opportunity to think about how can we leverage these tools and the ubiquity of these tools in the healthcare space, and particularly in the behavioral health space. And what I'd like to suggest to you today is that the data are increasingly showing with careful scientific research that that technology also offers great promise for really changing service delivery models, healthcare service delivery models, and behavioral health service delivery models, in increasing the quality of care delivered, increasing the reach of care, the personalization of care, and in doing it in a way that can be cost effective. And there are lots of different applications of this. I'll give you some examples as we go along here, but there are lots of applications sort of in terms of clinical populations, right, in terms of folks with problematic substance use, with mental health problems, folks that have other kinds of chronic illnesses that need to be managed. But also there's lots of activity in the space of mobile health focused on wellness promotion. And sort of what some call the quantified self movement, really around tracking data about yourself and your own behavior that can really increase self-knowledge via data. And we'll hear a little bit about that. In fact, one of our next speakers, Andrew Campbell, who's a professor here in computer science, has been doing some really exciting work in that space. So the work is spanning the whole spectrum, from prevention and assessment to treatment and all kinds of sort of interventions focused on behavior change to recovery support. And here are some examples of some of the applications of these approaches. So in the assessment arena, there's a lot of interesting and exciting research focused on using technology, including mobile devices, for data collection. And that offers increased standardization in the way data are collected. There are lots of projects that have shown that it increases accuracy of data collection. And what's pretty exciting about this also is that you can get data continuously or in a wide array of settings and in real time. So it really offers unprecedented levels of access to sort of real-time information about individuals' behavior and symptoms and functioning and on and on. And so there's lots of opportunities to think about how those data can be used in a clinical space. And you'll hear some great examples of that in the presentations today. In the intervention space, there's a lot of exciting work in the prevention space with children, with adolescents, with young adults focused on prevention of risk behavior and using interactive personalizable tools around that. Lots of exciting work in the behavior therapy space, interactive behavior therapies that are designed to help people make changes in self-defeating behaviors that they may wish to make changes in. Self-learning tools, self-management tools, heavy focus on skills training, on initiating and maintaining new patterns of behavior, on setting and tracking progress toward goals. And these aren't just sort of patient or client-facing tools. There are lots of exciting ways you can think about the application of technology to an extended support network. So to parents and family members and clinicians, and thinking about care coordination models and thinking about data sharing and therapeutic support in entirely new ways, which can include decision support tools. It can include new applications of social media, for example. And it really offers an opportunity, I think, for a consumer-centric approach in healthcare delivery that we haven't seen in quite the way that I think we could see with the help of technology in our service delivery models, and really the opportunity to engage consumers and help them be heavily involved in sort of primary drivers in their own health behavior. So here's some potential promises of this approach. One is reach. We know that there are a number of evidence-based interventions and tools that can be helpful to people in treatment and recovery. But there are challenges in access to some of these interventions. And so one of the exciting aspects of technology is the ability to promote widespread dissemination or widespread access to effective therapeutic tools, right? You can centrally deploy these things and promote access in lots of different contexts and settings. And so that is a real strength and relates in part to what Bob was saying earlier about, even though we might have some, terrific treatment models, they're not accessible to everyone who could benefit from them. And so we can really think of creative ways to extend the reach of our care network with technology. There are also opportunities to think about quality of care delivered. We know there's a lot of variability in terms of therapeutic support that's offered in different contexts, and we can be assured that with technology-based tools, they'll work the way that they're designed to work, so we can ensure fidelity in the delivery of the intervention. Really exciting opportunities in the space of personalization. You know, you can develop these tools to be responsive to all kinds of different characteristics of an individual, their needs, their preferences, their level of cognitive functioning, you know, their cultural considerations. You can really have tools that are very adaptable and modifiable for different populations. We've spoken a bit about engagement and really the opportunity to have tools that can engage people in new ways. And as Bob mentioned, this opportunity for sort of on-demand access, you know, 24/7 access to tools that may be helpful. So someone might feel at risk of relapse to drug use at 2 a.m. on a Saturday night, and they may not have access to their clinician at that time, but they might have something available right there online or on a mobile device that could be helpful to them in getting through that. There's also some interesting data that are evolving showing that if you provide tools that provide sort of in-the-moment assessment and then interventions that are responsive to what people's needs are at a given moment in time, you can prevent costly escalation of problems and unnecessary healthcare utilization around that. There's also some interesting work highlighting the opportunity to think about technology and reducing stigma and disparities in healthcare access. There's, perhaps surprisingly, technology is being accessible in many, many populations, but even among the most vulnerable and disadvantaged populations with whom we work, even among homeless populations, even among persons with serious mental illness. And so there's a real opportunity to think about how do we leverage this access to these tools and provide support to these individuals and do it in a way that can help reduce some of the disparities that we see. There are also some opportunities to think about models of service delivery that centrally integrate technology so that you increase service capacity, right? So if you sort of offload some of the service delivery model to a technology-based system, you may be able to see more individuals with the same number of resources, clinician resources, and financial resources. So I think as we look collectively at research in this space, it seems like if these tools are developed well and are studied carefully, there's a real opportunity to think about scaling them up and considering their implementation in a wide array of settings that can really have a population-level impact. So we've spoken about this a bit, but just a few statistics about how prevalent these devices really are. The trends all go in the same direction, increase access all over the world. Globally, about 90% of folks have mobile devices, sometimes more than one mobile device that they're carrying around. And the estimates currently are about 6.8 billion folks globally have mobile phone subscriptions. And many of those are smartphones, and smartphones, as you may know, are different than sort of feature phones or flip phones in that they have really extraordinary computational capacity and allows for all kinds of exciting things in addition to internet access. And the stats are also showing that smartphone access is also growing all over the world. And as I mentioned, this is true, and there are lots of data showing this is true even among the folks with whom we work on a regular basis, persons with behavioral health issues and folks who may be impoverished and in rural settings and lots of vulnerable communities. So this slide summarizes generally what the research field is showing right now in terms of the utility of these tools. And the pattern of results generally shows that if you develop these tools well, and I'll stop there for a second to say that's really important how you develop these tools and how you develop them in a way that they really bring value to the end user and drive engagement and have some utility to the person or persons using them. And I hope that during our discussion today we'll have a chance to talk more about optimal models of development. But if you develop these tools well and in collaboration with your target audience, you can get findings like these. You can get high acceptability, high utility among lots and lots of different populations, from children to adolescents to aging populations to chronic drug users to folks with psychotic illnesses and on and on. We see that you can have a large impact on health behavior and on health outcomes. Some studies that have directly compared technology-based interventions to traditional models of service delivery have shown that you can often get comparable outcomes with technology-based interventions to what you see with clinician-delivered models, and sometimes better outcomes, particularly in settings where you don't see evidence-based practice being provided. You see increased quality, reach, and personalization of care. There is growing literature on underscoring the cost effectiveness of these models. And also some really exciting work around how these tools can be modified over time to really be personalized in a way that they're responsive to individuals' clinical trajectory over time. Lots of exciting work with interdisciplinary teams of computer scientists and engineers and behavioral scientists. So let's just for a second talk a little bit about the prevalence of mental health and substance use disorders. And these stats will not be unfamiliar, I think, to anyone in this room. So we know that these are significant problems. The estimates vary, but generally about 1 to 4 to 1 in 5 folks in the US are said to be diagnosable with a mental health disorder, and about 1 in 10 with a substance use disorder. And we know that this has huge impact on people's lives in terms of their functioning, in terms of their ability to hold jobs, in terms of their social and family relations, and in terms of their cost to the healthcare system. So there are estimates that the annual economic cost of mental health problems is over $300 billion, and this has been increasing in recent years. The World Health Organization estimates that mental illness accounts for more disability in developed countries than other groups of illnesses. This includes even cancer and heart disease. So a really significant set of issues. So not only is mental health a significant issue in its own regard, but mental health problems hugely impact the entire space of health and wellness, including chronic disease management. So we know that behavioral health problems fairly frequently co-occur with other types of more sort of medical conditions. So one example of that is the co-occurrence of diabetes with depression. Persons with diabetes have, the estimates are between 40 to 72% incidence of depression and about 50% incidence of anxiety. So these things cluster together, and when they do, we see worse outcomes. So we know that all chronic physical health conditions require some health behavior change, and we know that the course of the management of these medical conditions is largely impacted by behavioral health problems. And here's some examples of what the research in this space shows. Lower quality of life when you see these co-occurring, poorer response to treatment, worse medical outcomes, worse psychiatric outcomes, higher mortality, and higher cost of care. So just to go back to this example of depression and diabetes, when these things cluster together, we see that healthcare costs increase by 50 to 75%. So as Bob mentioned earlier, we're in this interesting time in healthcare in this country where we're having lots of reform under the Affordable Care Act, and as part of that healthcare change, we've seen that there's, among other considerations, a focus on integrated care. So integrating behavioral health and sort of more traditional medical care. And so as a result of what's happening in terms of healthcare reform, as a result of what we know about the intersection of these phenomena and how they impact each other, it seems like there's a tremendous need, and it's a really interesting time to think about how can we as a healthcare system be responsive to this. And it strikes many of us who work in this space that there's a real opportunity to think about technology as part of the solution. Not only the solution, I don't think it's the solution to all of our healthcare problems, but I think there's a real opportunity to think about how can we use these tools to promote integration of effective care and to do it in a way that can meet the needs in terms of integrated care, to do it in a way that can address some of the challenges we have in insufficient workforce to do this, and to do it in a way that really can provide improved models of care. So I'd like to talk a little bit about ways you could think about applying these tools. I think there are lots of creative ways we could think about accessing these tools as additional tools that are available to us, that we can make available to clients, and to improve service delivery models. And I think that the research community has really only scratched the surface of really what is possible in the application of these tools. But I'll give you some examples of models that have been tested, and then show you just some examples of data highlighting these different models of deployment. So one model that you could consider is you could consider these tools as a supplement to traditional treatment, right? So this is an adjunct to care model. So it's an additional tool in the toolbox of clinicians they can make available to their clients. Their clients can access these tools when they're not with their clinician. So almost sort of like homework or things that they can use in between sessions with a clinician. Some people have been calling this a clinician extender model. So it's sort of extending the reach of clinicians, extending the impact they can have even when they're not working directly with their client. So it can extend the impact of clinician-delivered therapy. It can be used as an adjunct to various types of medication-based treatments as well. Other models have looked at sort of a replacement model or a partial replacement model, where these tools partially replace a portion of traditional care. And so what's the benefit here? Well, some treatment systems have felt that this could be useful in expanding their service capacity, which I mentioned briefly earlier. So if they have, for example, long wait lists and they don't have enough resources to accommodate the need that they've got, perhaps they could see more folks if they had an integrated model where part of the care was delivered by interactive, personalized behavioral interventions delivered via some technology platform and integrated into what the clinicians were doing in that setting. Some other settings have found it helpful to think about this kind of deployment model in that it may free up clinicians to have more time to focus on clients who have greatest need. So clients in crises or clients who really need more time from the clinician, they have incredibly high workloads in some of these treatment settings, and this might free up some more time if they could have this integrated model of care. And then yet another option is just a standalone intervention, right? That maybe these are offered outside of treatment settings. Direct-to-consumer kinds of tools, and this might be particularly relevant in rural settings. It might be relevant to folks for whom access or interest in our treatment models is absent, right? So, Bob spoke earlier about the majority of the folks that have behavioral health problems in this country are not in our treatment systems. There's a tremendous opportunity to think about how do we engage that population. Perhaps we can provide some tools directly online to them. And there's some early stage research showing that in some of these direct-to-consumer models, in some cases that can function as a conduit to treatment entry. So for the first time, people might enter some of our treatment systems after having done some sort of self-management work with some of these tools. Okay, so I thought I'd show you a little bit of data to illustrate some of these deployment models. So this is just one tool of many. There's a lot of exciting research in the space of technology applied to substance use, applied to mental health. You're going to hear about a lot of that today. This is one tool that I mentioned because it's been studied in some of the deployment models that I just mentioned, and I thought I'd illustrate some of these different applications so you can get a sense of how you can deploy these tools and what kinds of outcomes you can see in doing so. This particular tool it's basically an interactive behavior therapy. It's grounded in a certain model of behavior therapy that has been shown to be effective, called the community reinforcement approach. There's a central focus on skills training, lots of different skills listed here as examples. There's a real central focus on initiating and maintaining new patterns of behavior that don't involve problematic substance use. So it's really finding value and meaning in other things in life that don't involve substance use. So it's an interactive system. It has 65 different components to it. It's intended to be used as an ongoing sort of therapeutic support tool. And it's wedded to this model of behavior therapy that has empirical support and then also employs certain informational technologies that have been shown to be important in promoting acquisition and long-term retention of skills. And it's available on many different platforms, desktop computers, Android, iPhones, iPads, etc. So here's some sample screens. I'm not going to go into a lot of detail about the tool. If folks are interested, we can discuss it later. It's more just to highlight an example of an application in this space. Here are some examples of the different sections of the program. Some skills training, some psychoeducational content, some interactive videos, some interactive processes to understand individual risk behavior and such. So here's what the general research shows from work with this system. There have been studies that have looked at this partial replacement model that I described briefly, where part of clinician-delivered therapy has been replaced with this interactive treatment for substance use disorders. And that research has shown that you can see outcomes that are as effective as outcomes delivered by therapists who are highly trained in delivering this behavioral intervention. And the reason that's important is that this is not about replacing those therapists. It's, we don't have enough of those therapists. And so it's really around thinking about, are there active ingredients in this? Can this have an impact? And then to think about how can this be deployed in a way that can help improve people's lives. There's also research that basically has shown that if you partially replace or add it as a supplement to sort of standard community-based treatment, which we see in many community systems around the U.S., we can actually see better treatment outcomes, in some cases high as doubling of rates of abstinence from substance use. And there's also some evidence showing cost effectiveness in different addiction treatment settings. So here are the models of deployment. So here are data that illustrate some of these models that I was describing to you. This study was sort of it's called an efficacy trial, which means that really tight control over sort of manipulating all the different conditions in this study. It's not really done in community systems. It's done in a highly controlled sort of academic setting where you randomly assign people to different study conditions and look at the outcomes. So in this particular trial, there are 135 folks entering outpatient addiction treatment. This one happened to be folks seeking Suboxone treatment for opioid addiction. And there were 3 conditions. Let's see if we've got a pointer here. Yeah. So in the red bar, this was an intervention that was heavily done by this interactive behavioral treatment. The blue bar was comparable effective behavior therapy delivered exclusively by clinicians, the same model of treatment that was done by the computerized system, but done entirely by clinicians. And then the third bar was standard addiction treatment in these types of opioid treatment settings. And these data suggest, and this is just one example, but this is objectively measured urine testing of opioid and cocaine use. And what we saw in that study was that we saw comparable outcomes in terms of abstinence from these substances when you offload a lot of the intervention to a computerized intervention versus when you delivered exclusively by a clinician. And both of these evidence-based practices were better than standard treatment. So now this slide shows a different sort of model of deployment, and this is more of an effectiveness trial, which is really working with the community and thinking about if you change a model of service delivery, what are the outcomes? And so this happened to be in a methadone maintenance treatment program, 160 folks entering treatment there, tracked for 12 months. And there were 2 conditions. You either went into standard methadone maintenance treatment, right? So you go in, you receive methadone medication on a regular basis, you receive some counseling in that context. And the second condition was a modification of that treatment model in that half of your therapy sessions were done with your counselor, but the other half were done on the computer. So you reduced the clinician contact in half and offloaded that to the technology-based intervention. We find that when we reduce treatment as usual in half and replace it with technology, we actually get better abstinence rates. And there are lots of potential reasons for this. Perhaps it's around the personalization of the interaction. And the clinicians, we have lots of data from the clinicians in this and the administrators. And these are treatment settings where clinicians have 50 patients on their caseload. And so if they could have a model where they can get better outcomes and have more time to spend with clients in need, this might bring value in that kind of a treatment system. I'm going to skip over this just in the interest of time. This is an example of a comparative effectiveness trial. Now, this is a different model of deployment, a direct comparison between exclusively technology-based intervention, exclusively clinician-delivered intervention. And this was done in prisons. And in prisons, as you may know, there are very high rates of problematic substance involvement in folks who are incarcerated. They have a long history of that. Among 80% of inmates report problems with substance use prior to incarceration. And yet prisons often have very limited resources to provide even the most basic drug education to folks who are incarcerated. So for this system, there was some value in a design where they could learn, if all we've got is a technology-based intervention that folks can use and we don't have access to clinicians to come in and really meet the need in this context, what do the outcomes look like with that model? And so that's why this comparative effectiveness design was conducted in that context. 10 prisons around the US, and it was a longitudinal study where we looked at we recruited folks while they were incarcerated, and then we looked at outcomes post-prison release, so 3 and 6 months after they got out. What happened after they got out of prison? So this slide shows substance use, high rates in both the computerized in blue and the counselor-delivered models at baseline, and comparable reductions in substance use post-prison release across the two arms. Similar pattern in criminal activity. We also saw similar patterns in things like documented reincarceration rates, et cetera. So this is an illustration of a design where perhaps this could be useful as a standalone intervention when you don't have resources for anything beyond that, and you have a tremendous need for this type of intervention. Okay, one more example of a deployment model that I'll mention, and this illustrates the model where you think about providing these tools as a supplement to care, as an adjunct to care. So it enhances what's already being provided in a treatment setting. This was a small study. We have a larger one running now, but this was 50 folks entering outpatient addiction treatment. And it was random assignment to one of two conditions. So either you went into standard outpatient addiction treatment, this one happened to be methadone maintenance treatment, or when you came in and entered methadone maintenance treatment, you got a cell phone. And on that phone was an interactive, personalized behavior therapy system that can help you sort of, as you move about your daily life in helping you in your treatment and recovery. And so we looked at what happened for the first 3 months of treatment entry. So in general, we saw decent feasibility and acceptability. People used it. We didn't have too many sort of lost phones. We had good data usage rates around it and high levels of reporting of liking and utility. And we had a lot of qualitative data we collected in this that indicated that folks use these tools at times that seem to be clinically meaningful. So this study was done in New York City. As an example, we had a woman who indicated that she has to go to the Bronx every weekend, and said that had historically been a high-risk environment for her. And so she told our research team that every Thursday night before she had to go to this setting, she went through a self-management planning routine on her mobile device to help her remind her of her commitment to treatment and to strategize about how she could be successful in not relapsing when she went to the Bronx. So the qualitative data were promising, and the quantitative data were also quite promising. So this graph shows the percent of participants retained in addiction treatment in that treatment entry phase, the first 3 months of treatment entry, when they do or do not have access to a mobile phone as part of treatment. So when we give them this simple tool when they enter treatment, we saw that it increased retention in treatment quite a bit. 84% in this arm versus 56% who didn't get it. And then we also looked at drug use outcomes with urine testing, and we saw this seem to translate into drug-taking behavior as well, where we saw a trend for greater weeks of abstinence from opioids, the target substance that folks were entering treatment for in methadone maintenance treatment, when you got the mobile tool versus when you did not. So these were very promising data and suggest there might be some utility in thinking about this simple tool as an adjunct to our traditional models of care. Okay, so just a few concluding points here. I think that there's a lot of really exciting work being done in this space of technology and behavioral health. I've tried to review through some of the patterns that we're seeing emerge when you really have science drive the development and the evaluation and the implementation of these tools. But I think there's a lot of really exciting opportunities as we move forward in this field and really thinking about how do we take this science, how do we take what we're learning and really have a public health impact, a population level impact. And I'd like to talk just briefly about some ideas around this in the space of development of these tools, in the space of evaluation of these tools, and in the space of implementation of these tools. And this is really for some of the presenters to think about as well. As you work in this space, there's some really under sort of studied areas that I think there's a real opportunity for us to study more carefully and learn more about as we sort of scale up the science and really think about changing behavioral healthcare systems via technology. So the first one is really ensuring that our clinical considerations and sort of healthcare system considerations drive how we use these tools. You know, I think there are gadgets popping up all the time, new sensors being developed, all kinds of technological advances happening on a daily basis, really, in this space. And I think that I think for us as researchers, it's been really important to think about what are the clinical aims, what are the goals around this, how can technology be a tool to forward those aims, and let the clinical priorities drive the use of the tools. I also think there's a real opportunity for us to think about breaking down some of the silos in what we do, right? We know that, as we spoke about earlier, you know, these problems don't occur in a vacuum, right? Substance use often co-occurs with other mental health issues, which often co-occur with other sort of chronic disease considerations. And some of the aspects of what's effective in promoting behavior change transcend sort of disorder type or population type. And I think technology can really help us break down some of these silos and create, you know, systems and integrated suite of tools that can be responsive to whatever combination of needs and preferences people present with. And so I think we should really think about not just a tool for X or a tool for Y, but really think about the person and the person's needs and priorities, and then what can be offered to them in this model of service delivery. And that relates to the third point here of really having this consumer-centric focus in the development process. The data in the development space have highlighted repeatedly the importance of consumers really defining and shaping all kinds of aspects of the tool, not only its content, but its functionality, the interface, and on and on. And I think that is something that we shouldn't lose sight of as we think about the evolution of research and development in the space. Another point that I think it would be great for us to talk more about today in our discussion time is research focused on better understanding of mechanisms of behavior change. So we've seen some really promising research showing these tools can work, but we don't have a really solid understanding about how do these tools work, how do they best drive change. And I think that it would be really helpful if we had a real focused line of research thinking about what are the mediators of change? What are sort of the target criteria that we need to reach in order for a tool to actually then translate into behavior change outcomes? And I think if we really had a good understanding of those criteria, it would help us understand this broader literature, which sometimes shows effects of these tools and sometimes not. So there might be some criteria there that really are sort of our targeted outcomes in this, and it would be really helpful to know that, as well as do we see differential patterns of mechanisms of behavior change with technology-based tools relative to our traditional models of care. You know, given how accessible they are, how personalizable they are, there may be some differences in the rate and or the nature by which they drive behavior change, and it's an important and understudied area. And then finally, in the space of development, I think it's really exciting a lot of the work that's evolving in computer science and engineering around predictive modeling and really learning about individuals' behavior and changes in individuals' behavior over time. And I think there's some really exciting work that some folks here will talk about. Andrew Campbell from computer science, Rachel Bryan, and Dror Ben-Zev have been doing some exciting work in this space, really trying to understand how can these tools evolve over time with the individual, and how can they change up the offering based on the needs and priorities of the individual at a given moment in time. And I think it's a whole new way of thinking about personalized health care, and thinking about ways we can improve quality of care. So in terms of evaluation, I think there are lots of exciting opportunities as well for us to consider, including the way in which we do our evaluations. We see a lot of randomized controlled trials in this space, which is terrific, but I think there's lots of opportunities to still have experimental rigor, but learn things perhaps more quickly about this type of model of delivery, including some exciting evolutions in measurement, in experimental design, in data analytics, and in data visualization. And this really underscores the importance of an interdisciplinary team in development and in evaluation of these tools. I also think it would be really exciting to see more research in more sort of community implementation models. So really looking at if you integrate these tools into systems of care, not only how do they change service delivery and outcomes, but what are all the cost considerations around that? How does this impact payer systems? How does this impact healthcare spending and perhaps down the line savings in healthcare? And I think we have a real need to do some real careful research around this. Another issue that I think has been understudied, and I would encourage many of you who work in this space to think about it, is what are the important ways in which people might use these tools, right? So I think we often see that tools are offered to some clinical population, and they're told, we suggest that you use this twice a week for 12 weeks, or 3 times a week for 24 weeks, or whatever the model is. And if they don't quite do that, it's considered sort of non-adherent. And I don't know that the data really show that those models of adherence are critical to drive outcomes. In fact, the data that have been published in this space are sort of equivocal. And there's some evidence that might suggest that you don't need to promote use of these tools every day for the rest of your life for every population. It might be that if indeed these tools do what we hope they do, which is help people learn certain skills, help people expand personal and social resources that can promote behavior change, perhaps that becomes part of their behavioral repertoire, and perhaps that becomes part of what they do, and they don't need access continuously to this, but perhaps they might want sort of booster sessions or sort of strategic, episodic use of these after sort of developing that skill set. So I think it's a really important and understudied area of research that we could look at. And then I'll just conclude here in a couple of minutes and just talking about some exciting opportunities, I think, in research and clinical application in the space of deployment and sort of the implementation of these tools. So we've talked about some of the research that's looked at models of deployment, but I think it would be exciting, again, to think about some real-world sort of models that we could test as part of demonstration projects around this, including perhaps a prescription model. So a model where, not unlike a provider providing a prescription for a medication, providing a prescription for access to one of these systems that may be useful for folks in their care. There's also some early stage but interesting work looking at models of care where you sort of promote implementation of these systems in various care settings, but then you have sort of a centralized support team that can support the integration, the adoption, the ongoing use of these tools in that context. So rather than every program having to have in-house someone who understands all of the nuances about implementation, around the infrastructure needed for that, around the privacy, security considerations, et cetera. Perhaps there are models where you can have some centralized resources that can provide support to a broad community around that. We've spoken a bit about the direct-to-consumer model. That's really underdeveloped in terms of sort of scaled-up models in research around this. That I think that there's lots of opportunity for that. This issue of minimally disruptive healthcare is a concept that I first learned of from a colleague at Mayo, Victor Montori. And the idea is this, that when you have a medical condition, when you have mental illness, for example, the illness itself is very burdensome, but the treatment for that illness is also very burdensome, right? So you have to go to lots of appointments, you have specialists involved, you have tests involved, you have a bunch of medications involved, you have to manage that whole spectrum of what often is complex treatment regimen, particularly if you have comorbid, medical conditions on top of the behavioral health problem. And so this concept of minimally disruptive healthcare is really trying to think about how to help folks create a much more manageable treatment regimen. And I think that technology offers a tremendous opportunity to think about that. How can we reduce the burden of treatment with the use of these tools, not only in promoting self-management, but maybe medication taking reminders, maybe care coordination types of tools. I think there's a lot that can be considered around how can we use these tools to help folks not only in recovery, but really doing it in a way that minimizes the burden of some of that. Two final comments. There's a lot of exciting work going on in academia. There's a lot of exciting work going in industry. These things don't always meet. So it's really interesting to think about some new partnerships, right? So academic, industry, commercial, government partnerships, where you have a model where the academics can really drive the science behind the development and the creation of these tools in a way that they're really going to produce the intended outcomes. You have sort of foundation and industry partners that are there and committed to the deployment and the scaling up and sort of the ongoing life of tools that work, right, which the academics often are not able to do with grants, for example. And then the government partners who really can help in a regulatory space and promoting sort of guidelines around best practices based on the science around this. So I think there's some real opportunity to think about new partnerships in this space. And then finally, in the global health space, there's a lot of exciting work as well. I've talked a lot about US-based research thus far, but we talked about some of the stats showing the ubiquity of access to these tools in the US, that there are striking statistics, but they're even more striking when you look at lots of low and middle income countries. So even countries that haven't developed landline infrastructure, they all have mobile phones, and sometimes more than one, and often have, in some of these countries, underdeveloped behavioral health systems. And so there's a real opportunity to think about how can we consider in various cultural contexts, again, harnessing the use and the access to these tools in a way that can help people improve their lives. So I'll stop there. The final slide is our website. Seddon did a beautiful job, thank you, of sort of providing a summary of our research center. We have the privilege to work with a tremendous group of researchers and advisors, many of whom are sitting in this room. It's a great privilege to work with all of you, and we've got a lot of exciting work happening. So check out our website, and I'm looking forward to a great discussion today. Thanks so much.
Okay, thanks, Lisa, for a wonderful overview. That really gets us started. And I want to move along rapidly because our next speaker has limited time before a class on campus. So we're now going to move from overview to some specific areas of research. I'd like to introduce Andrew Campbell, who's a professor of computer science here and the head of the laboratory that looks at smartphone sensing. His work is really innovative and groundbreaking. I think you'll enjoy hearing about it, and I believe he's going to present some data related to students at Dartmouth and how he's improving their functioning, I hope. So please welcome Andrew Campbell.
That'd be great. Cancel that. No, I'm okay with that. Actually, I think. What I want to do is. Okay, thanks. Good morning, everybody. I'm really pleased to be here, and I'd like to thank the organisers for organising a great event and for inviting me. I'm a computer scientist, and it's always fun to come and meet people who work in other disciplines who are motivating a lot of the research that I do. So I'm really happy to be here. I want to talk about the smartphone, and if you actually came to my office in Sudakov, you'd see my cell tower. And this is all the phones that I've been using basically since 2006, when smartphones happened. So it's almost pre-smartphones. And as my kids have got older, when they were young, they come in, they just knock it over. And now undergraduates come in and they sit down and they bump up against my coffee table and knock over my cell tower. If we look a little bit closer at the phones, what really excites me as a computer scientist, technologist, is actually the amazing things that they put in these phones. I mean, the phone today is equivalent to a Mac of 2 years ago. Most phones, without getting too geeky on you, have got 4 computers in them that are just main processors. They're called cores, as well as lots of other chips that do digital signal processing, sort of fantastic, touch-tone screen. But what's really sort of excited me over the last 6-7 years, and I think is enabling technology for your community and many other communities, is the embedded sensors that they put in the phones. And the reason my cell tower keeps growing is because, every 3 months there's a brand new phone with something very cool in it. So if I attempt to do a live demo here, this may be a complete disaster, but let's see how it goes. So this is a Samsung Galaxy S, and I think what you might find cool about it is a new sensor that they've just put in this. First of all, there's a sensor that actually on the back of the phone here, that is a heart rate, measures heart rate, basically. It's a specialized sensor. Previously, you could put your finger over the camera, and it would, guesstimate your heart rate. But now there's actually a sensor that does this, and I just tried it a moment ago. This phone just came on the market about a month ago, and actually I have no heart rate. That might be because of my stress level, because at 10 o'clock I'm teaching Android programming about 10 minutes from here, which I have to run. But let's just try it. I'm supposed to keep still and quiet, so I'm not still and quiet because I can see my sort of hand shaking, and it's probably not going to work. Okay. Oh, okay. Well, the demo didn't work. That's the first part of my demo. But there's a sort of hacky heart rate monitor on the back of the phone. Another piece of software that we've developed. Let's see here. Is the ability for the phone. What I'm showing you is a piece of software that runs in the background of the phone, and it's telling you that I'm in conversation. So if I actually stop speaking, and I probably won't, it'll go to silence. So the phone knows when I'm speaking, of course, and so therefore it can determine how many conversations I'm having a day, the duration and frequency of those, and of course that ties directly into sociability, which is an indicator of many well-being metrics, right? Mental health metrics as well. So, for example, we can easily understand sort of socialization or how much you engage with people in conversation. The accelerometer is saying I'm walking. That's because I'm actually shaking a bit here, because I'm a bit stressed. So if I stand really still, it says I'm stationary. If I walk across, so I'll have to do a mobile demo. If I walk across the room, it says walking. So if I care to run, and I won't run around for you. I have done in the past. If I was cycling or was in a car, My phone knows all of these activities. What else? What other cool sensors can I show you? There's a sensor here, a gesture sensor, that I can do this. And actually, all of the photos I'm scrolling through are the same color, so you don't see the change, right? So this is a gesture sensor. And I can scroll back. And these are just sensors that have just been added. Essentially, the activity sensor is software we put on the phone, but the other sensors are sensors, physical sensors that I've just added to the phone. So it's an amazing time. I believe we're at a fantastic sort of crossroad in this everyday technology that's going to enable many, many new applications, both in healthcare and lots of other domains. So the phone has not only lots of different radios, it probably has 6 radios in the phone. It has, accelerometers, gyroscopes, fingerprint. Actually, this particular phone has a fingerprint sensor. As I get into the phone now, not by locking it with a code, but just putting my finger on the fingerprint sensor, which is right here on this phone. It has a gesture sensor. It has a barometer sensor, so I can know if I'm walking upstairs or downstairs. Has a heart rate sensor. Of course, it has location. It knows what I'm doing. This is getting really scary, isn't it? It has front and back cameras, so the camera can understand my gestures at any one time. Most people, kids particularly, are staring at the phone 90% of the day, right? The phone knows essentially what their physical facial gesture, face recognition, effect can be computed from the phone. The microphone is an amazing, powerful sensor, not only to determine, am I speaking, the duration, but it can actually, in the future, it will be able to find stresses in your voice to determine how stressed you are. So it'll do voice recognition on you against a machine learning algorithm to say, am I stressed? I'm actually quite stressed at this moment because I'm trying to figure out how I'm going to, get over there. Has a light sensor, and it's got this actually has 2 light sensors. It has a normal light sensor, so it dims the screen in different light conditions, but it also detects ambient light as well. It has 2 light sensors. Has a proximity sensor, so if I put the phone to my head, the back screen goes off. Doesn't have an air quality sensor yet, and it doesn't have an emotion sensor yet, but we can clearly infer emotion from this phone. So this is and the reason I say we're at a crossroad, because it's both an exciting time when new technology is put out there, but also a sort of scary time, right, with all the news in the media about eavesdropping, companies collecting all our data. So privacy is a huge concern, and my colleague in computer science, David Coates, is sort of leading the way on trying to keep things private whilst moving forward technologically. We don't want to stop because it's an exciting sort of area. I won't talk about privacy today, but certainly it's a big caveat in this area. Whenever I give talks, I'm always hammered by privacy. So that's my caveat. Well, of course, we can use the simple accelerometer, and you can look at the signals from the accelerometer, and you can see the difference between standing, which is flat, sitting, standing, walking, and running. You can see the sort of gait in the actual signal. So imagine what a computer can do with machine learning algorithms. It can do phenomenally well at finding patterns in all these signals from all these different sensors on the phone to infer physical activity. Likewise, I showed you a demonstration of understanding how much conversation I'm involved in. We'll be able to measure, and we've done some work on this in detecting stresses from voice. And we can also, this particular application that we're using and developed with Dror Ben-Z for one of his projects, unobtrusively measures sleep. So what I mean by unobtrusively is there are many, many apps out there on the market where, when you go to bed, you put some data in, when you get up, you put some data in, or you wear something in bed. I've tried them all out. I remember the first time I used Zio, I got up in the morning with a terrible headache, threw that in the bin. If you just think about it for a moment, your phone actually knows how much sleep you're having without you actually ever saying anything to it. Just think of your own behavior with your phone. When I go in at home at night, I typically I'll plug my phone in to recharge it and leave it by the printer downstairs. I have 2 kids. There's noise around the house until, the house goes quiet and the lights go off. And then in the morning, lights come on, noise starts happening, the phone gets moved. If you take any one of these signals, it's a fairly poor inference on sleep duration. But if you take all of these signals, movement, sound, light, and you feed them into a machine learning algorithm, we can actually infer your sleep with plus or minus 30 minutes without you ever interacting with it. So your phone is learning and potentially personalizing, as what Lisa said, personalizing to your sleep habits wherever you leave the phone in the house. So this is all really exciting. And the question is, what are we going to do with this technology? And lots of folks in this room are very, very interested in well-being, physical well-being as clinicians or clinical psychologists, in mental health. What got me sort of excited recently was I've been at Dartmouth for about 8 years now, and we teach terms here. And previous to that, I was at Columbia University for 10 years where we taught semesters. And it was a real adjustment for me to switch. It was like going from a marathon to a sprint, right? And so looking at the kids that I teach, I could see sort of anxiety levels increase throughout the term, sort of burnout happen. And I decided, well, it'd be nice to actually get under the hood and find a little bit more out about how students do. And of course, I was looking at assessments that were coming back from my class, some of my classes, and I would see comments like this. So fast. I know that's how it has to be, but I'm not going to say it was slow. Or this one. The lab and lectures were great, ridiculously hard and so much work that I really enjoyed them. I can't think of a 10-week period in my life when I have learnt more. I'm rubbing my own ego here. This is my favourite. 10 hours each week coding. This class sucked out my soul. But what I've learned about Dartmouth students, unless you're sucking out the soul, they're not getting value for money, right? So I got sort of interested in this, and some of the driving questions were in this piece of research that I'm going to talk about for the last few minutes. I should watch my time here. Why do some students do better than others? Why do students burn out, drop classes, or even drop college? We know that sort of stress and depression is rife in this community. Of course, there's lots of social issues that have been discussed at Dartmouth, and I won't touch on those. I'm smart enough to do that. What is the impact of stress, mood, workload, sociability, sleep, mental well-being on educational performance? Why do some kids do better and others don't? Why do some kids deal with stress better and deadlines better and others don't? And is there any behavioural pattern, common behavioural pattern, when you look at all the data from all these students? So I had some driving questions, and I'm not a clinical psychologist, so I didn't really have a good hypothesis. Like everything in my life, it's more bottom-up. Well, here's some cool sensors. Let's build some machine learning. How can we apply this technology to get some insights into a problem where there are some hidden states? And that sort of motivated this work. And at the back of my mind from teaching at Dartmouth, I was thinking, I see, over these 10 weeks, I see the stress level rising. I can visibly see it in the class, and I can see the students are getting tired. And, clearly the workload increases as the term progresses, right? And so I asked myself, is there some form of rhythm to this term? So we did a study actually, and we finished it this time last year, and it was in this particular class that I'm teaching now. So there were 75 students in the Android programming class last spring, and we signed 60 students up. 48 ended up completing the study for 10 weeks. Here's a demographic of the students. And so this was 48 students over 10 weeks running an application that we put on their phone, or we gave them a phone to carry. So we had a terrific amount of data. Just let me briefly say what the system was, and I'm not going to get too technical here. But right, okay. So the system over. Let's see if I can do it like this. Okay, so this didn't work. Oh, what have I done then? I think I've gone. That does work, Bob. All right, great. So just quickly here. So this is the phone, of course. We had an application that ran on the phone. This is not a smiling student. This is some GIF that I got off, picture I got off the web. They didn't look anything like that at the end of the class. But so here's the Android phone. So we had a self-report mechanism on this, and it was based on a piece of software called Paco. And there's been a presentation at the centre, Lisa's centre, 2 years ago from the developers Paco. And so we used that for EMA. So we got a lot of self-reports, in situ sort of data. We used SurveyMonkey for pre and posts of a lot of well-being, mental health surveys. The stuff that I developed, my group developed, was a bunch of continuous sensing algorithms that ran in the background of the phone that users never interacted with. It just ran in the background of the phone. And it ran through these machine learning or classification models that determine the activity, standing, walking, running, etc. Conversation, how much conversation I'm involved in per day, the frequency and duration, sleep, how much sleep I'm getting, just the duration, and location, where am I? So this is all continuously kept. The EMAs were for stress, mood, social, exercise, and behavior. And we pushed all this into the cloud, and we did some analysis of mental health, academic performance. We looked at personality. I won't talk about that today. This was on the cloud. So that's the basic system. The students actually, over the course of actually the 10 weeks, we actually got, believe it or not, 32,000 EMA self-reports from these students on various different things. But they loved this one. They really liked this one. So for every, when they're using their phone, a survey popped up. And before a survey popped up, we popped up this thing called PAM. And basically, these pictures here, how am I feeling? So I click on a picture, and then an EMA popped up, like how stressed are you, or what mood are you in? So these are actually correlated with PANAS positive effect, these pictures. And they can select more pictures as well. So this is an example of, the PANAS popped up with these pictures, and then there was always a different sort of survey. So we collected a lot of EMA data as well. The pre and posts were perceived stress, PANAS, UCLA, loneliness scale, PHQ-9, flourishing, and Big Five, and Pittsburgh Sleep Quality Index. The data, just to give you an idea, when we actually looked at the data's actually pretty fascinating, I think. What this plot shows is just some structure in the data. It shows actually all the classes for all the students. So if you think about it, I had 48 students in the study in my class, but they're taking 3 classes, right? We did know what the classes they were taking. So they typically Dartmouth students taking 3 classes. And this is the Dartmouth schedule. So I'm teaching in a 10 o'clock slot, which is coming up quite soon. So what this is for those 48 students, what classes they took throughout the whole term. And the whiter it is the more students are in that class. So, of course, this is my class, right? The only common class for all of these students is my class, right? And that's why I taught on Mondays at 10, Wednesdays at 10, Fridays at 10, and the X hour. And these are all their other classes. So I can see the students' workday starts at 9 and sort of ends at 6, 9 to 6. That's their workday. They go to work to go to school, right? If I looked at all their sleep data across the whole term for all these students, I could see, well, some of them go to bed before 12. Oh, this is all screwed up. This is 12 o'clock. Most of them go to bed between 12 and 4 o'clock. And some go to bed, you can see, like 7 o'clock. So, 12 o'clock they're going to bed. So at 12 o'clock they're going to bed. So from 9 to 6 is their day. From 6 till midnight is what we call the evening epoch. And night is 12 a.m. till 9 a.m. So we actually broke our data up based on this structure and analysed it in these different epochs. So we looked for markers in these specific epochs as well as for the full 24 hours. So there's a natural structure in their day. So just to quickly tell you a little bit about the data set, it's 53 gigabytes of data. There's 32,000 EMAs. There's a lot of pre and posts and interviews. And we have a lot of objective sensor data. This is just data from the phone that nobody's interacting with for activity, sleep, conversational, sociability data. We have the EMAs, and we have also, importantly, I had access to all of their grades for all of their classes. So I know what classes they're taking. I know where their classes are, so I can look at attendance of all those classes, and I know all the grades they're getting, not just my class, but all the other classes they take that spring, as well as we're doing exit and entry surveys. So in the few minutes I've got left, I just want to give you a taste for the results, and I can't go into them in great detail, but things that might be of interest to this community. And one of them is correlations between objective sensing data and PHQ-9. So this is data that nobody ever touches, that comes from the phone, right? That runs through our classifiers, and then we look at, Pearson's correlation function against PHQ-9 depression scale. And so, interestingly enough, in the class of in a study of 48 students, we actually had some students that were severely depressed to moderately severely depressed, etc., right through the whole scale. And we found correlations with PHQ-9 so PHQ-9 negatively correlates with the number of co-locations. What this means is, co-locations means all of your phones are actually giving off Bluetooth signals. And so if I'm with a group of 100 people like this, I know I'm with a group of 100 people. So the less people I'm around, the more I'm depressed, basically. That's that message. The number of the conversation duration and frequency also is negatively correlated with PHQ-9 scale. So, and this is in the literature, of course, but this shows objective sensing data correlates with what is in your community, right? Which is essentially socialized. The less conversation I'm involved in, the less I'm speaking to people or interacting, the more likely that I'm going to be depressed. So duration and frequency strongly correlate with depression. And finally, the less I sleep, the more likely I'm being depressed. So what we see here is for PHQ-9, we're seeing the number of people I'm around, the amount of conversation I'm involved in and its duration, and the duration of my sleep directly correlates with depression scale. Another result on the not on the sort of mental health side, but just to taste the result on the academic performance side is this unobtrusive sensing data also correlates with GPA for the spring term for all their classes. So it negatively correlates with a thing called indoor mobility. What indoor mobility is, we keep information about how much students are moving around outside, and when they go in any of the buildings, we work out how much they're moving around inside. And I won't get into technically how we do that, but we use the Wi-Fi network to do that. And so the less amount of indoor moving I do at night, GPA correlates negatively with the amount of indoor movement I'm doing at night, and also during the day. So moving around, the amount of moving around I do somehow correlates with GPA. We don't know why. Conversation frequency and duration, the more conversation you have, the more frequent conversations you have, the better you're going to do in the class, which is sort of interesting as well. But we don't know why. We don't know the cause and effect. So in the last few minutes, I just want to, so I've shown you some specific sort of correlations to do with particularly PHQ-9 and spring term GPA. Now I want to show you some of the trends over the whole term. So when I started this study, I had a gut feeling that there were these trends in the data, and I want to show you what those trends are. So over the course of so this is the 10 weeks, and this is normalized readings for a bunch of different objective sensor data. So if I look at these, and what I've got here is the amount of activity, the conversation frequency, the conversation duration, and the deadlines. So what's common to all the plots I'm going to show you three, is this red line here is all of their collective deadlines across the term. So take all of their classes, what are their deadlines, and when do their deadlines occur? So you can clearly see the beginning of term, there's few deadlines. They've come back from spring break, right? They're really happy. And then the deadlines build up throughout the term. The deadlines build up throughout the term, they peak, and then they drop off here. And there's a midterm week in here as well. Well, this is actually dying a bit. But over here what we have is activity. So this is activity here. It's pretty high when they arrive and sort of levels off and doesn't rise or fall. This is conversation duration. It sort of starts sort of high, drops off, and then they start speaking again at the end of term. This is conversation frequency, the number of conversations they have, which is sort of low at the beginning, surprisingly, and then drops off. So that's the first plot. The second plot, this is interesting. They come back from, they come back from spring break. They have high positive affect. So this is from the EMAs. And that just, look, plummets through the term. And they're not feeling good about themselves at all here. The stress level, conversely, goes from very low when they come back from spring break to peaks and stays high throughout the term. Their sleep, sort of, when they arrive here, this is really interesting. The first week on term, they're partying like hell. So they're not sleeping at all. Then they get into the rhythm, have a little bit of sleep, and it drops off. This is midterm area. And then they get a little more sleep, and then towards finals, they just drops off again. And the final plot I'll show you, it's a bit, this is a bit complicated. Maybe I'll just pick it. So the deadline is common to all of them. So here is the number of visits to the gym. It just disappears halfway through the term and never recovers. This is really interesting. This is an attendance in class. Starts reasonably high and just levels off all the way through to almost, not quite non-existent at the end of term. This is for all their 3 classes. And I'll leave you with this result. We found there's absolutely no correlation with academic performance and attendance in class. 0. And when I told this to my students, this class that I'm teaching right now, they're like, okay, we're not coming next week. So I don't know why that's the case, but for all of these classes, all these students took, their GPA for those classes, their grades, had no correlation with whether they all attended class at the complete time or whether they're at the bottom end of the percentile. Okay, so that's some results both in sort of a mental health result, a academic performance result, and just some trends, which I call the Dartmouth term life cycle. And the natural question is, where is all this going? I believe that the phone is going to disaggregate, meaning it's going to break down and disappear. So I'll argue that maybe within 10 years for sure, there'll be no such thing as a smartphone. In 10 years, there'll be no such thing as a smartphone. I don't know exactly what it will be, but it's going to break down into sort of wearable devices, right? And of course, in your community, there's a lot of biometrics being collected from wearable devices, but I'm really saying in the commercial space, to communicate and do the things that we do today, we'll not do it through staring at a smartphone. I'm not exactly sure what it is, but there's trends indicate here. Thanks for listening, and there's a number of people that helped here. Thank you.
Thanks very much. You okay?
Oh, yeah. Just going to get a presentation fired up here.
Great. Thanks, Andrew. Now we're going to continue with the theme of innovation and specific research. I'd next like to introduce Lynn Feiling, who's an associate professor at Yale and is doing really tremendously interesting and innovative work thinking about using game theory and other novel approaches to promote health and to protect children from various kinds of health problems. So join me in welcoming Lynn. Yeah.
Yeah, I was going to say it looks daunting. That's okay. Anyone have a password they want to share? So I just want to thank Seddon and Lisa for the invitation to come and speak. I have to say, after that last presentation, I'm really glad I'm not in college anymore. So,
Thank you. Thank you.
thank you. So some of you who may have heard me speak at the Center for Technology and Behavioral Health sometime in the last year. I've lost track of time. Some of this may be familiar to you in terms of one of the main projects that we've been doing, looking at video games as interventions for risk reduction and prevention, specifically in adolescents. But this is also to serve as kind of an update and also an overview for folks who haven't seen the work that we've been doing. So as just some brief background, I'm a general internist at Yale. I also have a clinical practice in HIV, and I also am an addiction medicine doc. So I sort of wear all of those three caps. So, which really begs the question is, how does an adult medicine doc end up developing video games for teenagers? That's another story. But really, basically, I wanted to start looking at primary prevention. And at the time, my husband and I had 5 kids who were all playing video games and were like, you know, just embalmed in video games. That's like all they did was on some device playing a game. And it seemed like it was a pretty compelling way to potentially deliver healthy messages to kids. And so ended up deciding to apply for a grant, which had nothing to do with technology or video games, but I decided that was a grant I was going to write. And be careful what you wish for, you may get it. And which was actually a huge opportunity, and that started this whole adventure, which has continued currently, and is really what I'm going to focus on, is talking about kind of the process that we went through with this one game, and then also kind of the overarching idea of using video games not only for intervention, but also as an assessment tool, which I think is sort of a theme that we've been hearing both from Lisa and with the most recent talk, is really the notion of using technology both as a way of, you know, of intervening and impacting, but also as a very powerful way to collect very real data. So as far as the project that we received funding for, the goals specifically for that project were to develop an interactive mobile video game, mobile meaning we decided to use the iPad, designed to help young teens acquire and practice skills to avoid or reduce behaviors that increase their risk for HIV, as well as to rigorously evaluate its impact using standardized out-of-game assessments, so the paper and pencil assessments we're all used to using, as well as in-game data from the iPad software. I can say, while this RFA was focused on HIV prevention, we really took this opportunity to develop what ended up being an intervention that really covered a whole spectrum of risk behaviors. So there's a lot of content around sexual risk, around drug and alcohol use, and then on to bullying, cheating, unsafe driving. I mean, really decided we could, you know, affect potentially a lot of different risk behaviors in this population. So in line with what Lisa said, as we started developing this project, it became very clear that the need for a highly multidisciplinary team was absolutely key. That was and has continued to be the bottom line, and what I think has probably been most successful about this project. It took about 6 months to really develop that team and figure out who were the moving parts that we needed to have on board. But what you can see is that it is made up of a scientific side, a community side, and a game side. The scientific side is kind of the usual suspects, as you can imagine: pediatricians, behavioral scientists, addiction specialists, HIV specialists. The community side, which has absolutely been fundamental to doing this work, are, in this case, after-school programs and school-based programs in the New Haven area. So program staff, the kids in those programs, some of the parents involved with those programs. And they've been involved with every step of the development of the game, as well as now the clinical trial we've been conducting. So again, to a point that Lisa made, is really involving your target audience. That has been absolutely key. I think what we created came out of the kids, and so it's more likely to really have a positive impact on the kids. And then the game side was really, figuring out who was working in this area of serious games, which, just for definition, is essentially games produced for things besides just entertainment. And then also bring on some commercial game developers to really help us make sure that what we were creating was fun, engaging, and all of these folks have continued to be really important to the whole process and what we created. And actually in the middle is a picture of one of the first after-school program we worked with. We went in and took a bunch of photographs of those kids, which really make up our website. And so what we ended up creating was a game called Play Forward, Elm City Stories. New Haven is the Elm City, so that was a shout out to New Haven. And it was developed over the course of about 2 years. It's 16 hours on the iPad. And we, the whole developmental process, as I mentioned, there was a lot of interface with the community and with our target audience. But there was also a whole process in terms of how to embed health behavior change theory into this vehicle. As I mentioned, we decided to use the iPad because, in part because of the touch screen component. This was actually before the iPad was officially released, but I think given the sensitive nature of what we were trying to do and the notion that, you know, if a child could kind of have this in their hand, close to them, have it be a personal experience, that it may actually have more of an impact than using like a desktop computer or a laptop. It's a role-playing game with an overarching story, recurrent characters that come in and out of the game. And the first step is the player builds what we've coined the aspirational avatar, which helps build me power. And the aspirational avatar really builds on the idea that an avatar is a physical representation of you or your character. The aspirational avatar is the notion of really building beyond that. What are the goals? What are the values? Who does this player see themselves down the road? What's important to them? And the game allows them the capacity at the beginning to build some of that into their character and take that throughout the game with them. So I don't know if anyone ever played the game of life, right? So I remember my favorite thing was having the little car and like putting the twin girls in the car and putting the other things and kind of going through life, and I get my college degree. And that was like my package, right? That's what I took through life with me. And that was important. When they started taking things away, it didn't feel good. So it was that sort of notion of having our player go in with something important to them that they could risk losing if they made bad decisions. Another component of the game are 4 mini games, which really are skill-based games targeting areas that we wanted to see the players practice over and over again in an engaging, somewhat transparent way to teach them these skills. So we have our knowledge game, which is no sense. We have our self-efficacy around refusal game, which is our refusal power game. People sense is essentially helping kids go through a process of learning how to assess people and situations to figure out what's risky and what's not, how to say yes or no, and based on data that you collect about people or situations. And then there's priority sense, which sort of helps kids learn how to balance short and long-term priorities such that they can get a better sense of the decisions I make today can have an either positive or negative impact on my life down the road. So this was sort of what we ended up with, a final kind of plan for the game, and you can sort of see all the moving parts. There's the lifeline, which is really sort of a whole series of what we call challenge stacks, but are sort of narratives that provide sort of a challenge that the player then has to navigate through, making decisions that interface closely. Oops, are we on? We must be on. That interface closely with the mini games so that they build more power or senses through the mini games, which then helps them to navigate through the stories more effectively. And then you can see the aspirational avatar is over here. And then there's also an epilogue, which is essentially, you can always fast forward to the epilogue and see where you are in your game, in your life, how your decisions have impacted on your overall life outcome, and then go back and change that in the game, and then that's reflected in your epilogue. So there's this notion of being able to sort of go back and forth between now and later and see how, you know, your behaviors or decisions can impact your overall outcome. So I'm just going to show you some screenshots. I have my iPad, so if anyone at any point in the day wants to come play, you can find me. This is just an example of the home page when the player starts. At this point, you can essentially choose either a boy or a girl. We allowed kids to choose boys. They could play either as a boy or a girl. The game would be different if you were a boy or a girl, just because characters were different and some of the storylines were different. So I think what we aimed to do was to create a gender sensitive as opposed to necessarily a gender specific game. But, you know, we left it up to the player how they wanted to play. You name the player and you kind of go through the process of, as I mentioned, is developing your aspirational avatar. And you can kind of see that these are the 12 challenge stacks that go from 7th through 12th grade. So it's sort of the life of sort of middle school and high school. And then the mini games, and then the fast forward is where you can fast forward to your epilogue. And this is an example of one of the screens, just sort of showing how we have these tools that the kids can use. This is, again, all touch screen. And if you hit on the purple tool, then your people sense is activated, and you essentially move through each scene, sort of finding key points, which is either informational or they're points where you have to unlock a key point by playing one of the levels of the mini game. So again, it kind of moves the player back and forth between skill building, practicing, and then making decisions within the story. And there you can see down at the bottom here is where they keep tally of their key points. And in this case, once you've gotten 5 key points, you would be able to move on to a different scene. This is another scene. This is one that comes up with this. This is one of the stories that talks about prescription drug use at schools, and sort of this is part of the challenge that you have to work through in terms of how you as a player help negotiate what happens, making certain choices, being able to see what happens if you make the wrong choice or you make the right choice, and what those consequences are. This is one of the Me Power aspirational avatars, sort of as you begin, and you're sort of prompted to go back and forth to the aspirational avatar. This was a concept that we felt was really important and was part of this notion of building future orientation. With this project, we did sort of what I would sort of say is a rudimentary treatment of this. I think it could really be built out. At this point, it really just sort of includes these domains at the bottom, as you can see: who I am, hobbies, stuff, career, my home, people, my health, priorities, and dreams. And the player sort of builds those things. And this is what one of the screens look like. And those things are also reflected in the epilogue, because how you play in the game impacts on things that you've built into your aspirational avatar, and that comes together in the epilogue. This is one of the knowledge game screens. So the knowledge game is really based on imparting knowledge to kids in a way that is hopefully more engaging, is more likely to stick, and you really sort of play in the role of having to debate back and forth about, so information can be presented that's incorrect, and you're given a set of options to come back and say, this is the correct answer. And so it's really that sort of, and it employs sort of an ability to choose from a set of facts, so that you actually not only say, this is the right answer, but this is why it's the right answer, because I have a fact to back it up. This is a screen from our refusal game, and the refusal game really, as all the mini games are based on literature and evidence to support what are really well-established, effective ways for to refuse situations or people that may be risky. So, for instance, to go through a series of steps of refusing, the first one is, what is this person really asking me to do? Like, what are they, what's the message behind what they're asking me to do? The second step is, how can I get myself out of this but still save face? What are some of those strategies? I can make a joke, I can make an excuse, I can just say no. And it goes through those steps. And for instance, with refusal, with all the mini games, there are 10 levels. And so over and over again, the player is really going through the same steps and learning those strategies by doing it interactively with the characters in the game. So with the hope that, again, they just sort of, this kind of becomes embedded into their way of thinking about, in real life, how would I refuse a situation that might be risky to me? This is the People Sense game. The girls in our study tend to love this game because they love to think about their friends and their social network. And essentially, this is what this game is about, is how to build your social network based on information so that people who are safe are closest to you, and people who might be more risky are put on the outskirts of your social circle. So you go through this process where you choose, you highlight each of your friends, and you get information about them, and then you choose where they belong. Are they a best friend because they're really clearly are, a good person who's going to have a positive influence on you, or do they look like they're potentially bad news, in which case you want to put them farther away from you. And once you've placed everyone on your network, you then are invited to do things. You're invited to do something with somebody, with other people potentially along for the ride. So what the player then has to do is think about, okay, who's inviting me? Are they good or bad? Who's going along? Because I think the other skill we really want to teach kids is it's not always the person that you may think, oh, well, he's a good friend, he's okay. But you can be really impacted by the people who are also along there as well. And I think kids tend to lose sense of the fact that, it's the whole circle that can be risky, not just the one person who may be, may have invited you. And then it's taking into account what the situation is and sort of putting those pieces together and deciding whether it's, sounds good and clicking on green, or another time, because this does not sound like a good constellation of either people or situations, and this may have a bad outcome. Priority is one of the other mini games, and again, this is really, trying to balance short-term and long-term gains or losses and priorities and how those can kind of fit together, as well as sort of having, and this is what this is shot. What the wheel represents is that there's also a component of luck in there. I mean, we can sometimes make the best decisions, and yet things aren't necessarily going to work the way we choose them or want them to work because of just chance. So this is sort of the whole kind of landscape of the game. Again, it really pulls the player through the stories, through the decision making, through the mini games, building these powers and senses so that you can then progress through the stories, make the decisions, with the goal being is to have the best outcome, which would be reflected in your epilogue. Just we've had some good responses, both from the serious games field. We were invited to do a Google Tech Talk last summer, so if you also have interest in hearing more about serious games or about this project specifically, you can Google us and find our talk on YouTube. So the next step was really to sort of see, well, now that we've created this thing, and I'm proud to say that we're actually only 3 weeks late in our production, which to me was a major accomplishment, but to kind of figure out what, does this thing work, and how to evaluate that. And I think Lisa raised a good point, made me thinking about different ways of looking at technology, sort of maybe a more outside the box from our conventional, RCT approach and all that. Having said that, we sort of did the conventional RCT, and since that's what I live and breathe, so it seemed like at that point it was a good place to start. So we began this randomized control trial, again, keeping it within the after-school programs. We actually went out to, and actually are finishing going out to 15 after-school programs. We come in with rolly bags and iPads and headphones, and we plug them in, and our goal was 330 teens, ages 11 to 14. We did this throughout the whole year, so included summer programs. And kids were randomly assigned to either play forward or a set of control games on the iPad, and that ranged, and they were given a whole menu of 12 games on their iPad if they were one of the control participants, and that was everything from puzzle games and math games to just fun games like Angry Birds. The design was that they would play twice a week for 6 weeks, or 12 sessions, 15 hours of gameplay. And notably, the iPad, all of it is time-stamped data, which is collected through the game software, and then we also collected web-based assessments at specific intervals to evaluate for knowledge, self-efficacy, intentions, behaviors, and then sort of a whole set of data that we collected at different intervals. And so some of the results to date, so I can say, well, I'll get to that. Part of the other evaluation that we did was qualitative interviews. So we did interviews with, since the gameplay was 6 weeks, we did qualitative interviews with each of the participants at the end of the 6 weeks of gameplay, focusing mostly on the kids who played play forward, since that was, really what we wanted some of the feedback on, although there were questions that we asked all the kids. So as far as the play forward group, the majority described the goal as to make good choices to get a better future. They described it as fun, interesting, cool, and inspiring. 85% reported that they would recommend the game to a friend. And reasons they reported for recommendation included they felt that they had better decision-making skills, better sense of the future, increasing knowledge about sex, drugs, and alcohol. And they also reported that they felt like it was translatable to their real life, which was obviously one of the major goals and challenges, was to make it feel like it was meaningful enough that it would resonate. Anecdotally, a lot of the kids also asked if they could download it from the App Store when they were done. So to me, that was a pretty important, kind of compelling piece of information, that they did want to keep playing. So as I mentioned, we started our trial on February 26, 2013. We've been in 15 programs throughout New Haven. 301 adolescents were randomized as of when I wrote this slide. We're now up to 325, so we have 5 kids left to enroll in this study, which is really exciting. Of those 301 adolescents, 47% were boys. The mean age was 13. 161 had completed 6 weeks of gameplay. About that had completed the 3-month follow-up assessments. And what we were just seeing, again, just preliminary data, was no significant baseline between group differences, which is what we wanted, and comparable net play time was about 10 hours on average. Number of play sessions was about 9, and then playtime per session was about 60 minutes. So that's essentially what we were aiming for, and we saw that actually in both the control group and the experimental group. In sort of the small group that we had 3-month data on, we saw higher knowledge and we saw higher self-efficacy scores. We did not look at any frank behavioral data at this point, but in terms of sort of those behavioral antecedents, we certainly saw some promising effects in our group. I can say the self-efficacy scores that we looked at really were focused primarily on drug use refusal skills. So that was, that was nice to see at this point. Again, very preliminary. And then we also started looking at our log files, which is really just overwhelmingly huge amounts of data. And after listening to Professor Campbell talk about data, it is, this is a major, major challenge of how to look at all this data. I mean, it's great to see it come in, but it's a real challenge on how to look at it in a meaningful way. So we started to design some systems of how to look at this log file data. And one of the things that we found was that, again, just to try to start developing preliminary systems, was that we could document that looking at the log files that were generated by the iPad software, that there was a positive correlation between knowledge gains measured at 3 months on our assessments and the exposure to certain content in the game. We can map the content in the game to specific questions on our assessments, and we could see that those were well correlated. So it was, as a first glance, to figure out what may be important in this software data, certainly looking at being able to document exposure to certain parts of this intervention seemed to be a fairly powerful way to look at this data. And that really sort of brought about this idea of, and I think this sort of speaks to a lot of different forms of technology, is sort of how to look at this type of data that's generated from technology in the behavior change research space. And I in no way have an answer to that, because it is totally outside of my skill set. But I think it's really important. I think technology holds the promise of, as we said, not only as intervention, but also as a very powerful assessment tool. So in the case of the iPad data, it automatically records the player's experience, and then you can essentially take that and put those into places and look at it. Again, this is not what I do, but it certainly is is interesting to start thinking about what the applications may be. So this is just a very simple figure sort of showing 4 players, and the x-axis is total game time in minutes, and then the y-axis is a total score on a particular one of the mini games. And again, it's just being able to document is that the longer they play, they seem to accomplish a higher score, which is certainly what you want to see: learning, progressing, moving forward. Certainly gets more complicated when you start adding everybody in. And again, this is very much a work in progress. I think my purpose, because we're just generating some of these figures, some of this data, is really just more to start developing hypotheses about how to look at this data and what may be most meaningful. I think for me, the starting point is really to think about game exposure and what parts of the game and what kids are exposed to, can we see how that is associated with how they do on assessments. And we tend to design interventions that many of them are complex and multifaceted, and we get a result at the end and say, yes, it's effective, but we really don't know what's working, what's effective, what part of it has the biggest bang for its buck. So there's some ability, I think, here to be able to look at this type of an intervention and see what exposure really leads to the biggest impact. And to me, that's really important, because maybe we don't need 15 hours of gameplay. Maybe we only need 4 hours of gameplay of this one specific part, and that may really be the way to figure that out. So again, this is just some of our ways of starting to look at that. And if we look at the 4 different mini games we have and sort of try to figure out what exposure to one of those games, how that ultimately impacts on outcomes. Granted, they're self-reported outcomes, but that's, in this study, that's, sort of what we have. We're not collecting biological data. But I think that there's a lot of promise in that, and to be able to really see what is most impactful about our intervention. So again, does the time spent playing the game predict a positive outcome, or is it the score that matters? All these things, is time really a variable we want to look at? Because time can be spent very productively. They're learning, they're practicing, they're getting better, or they're spinning their wheels. And they're not, they're frustrated, they're not understanding, they're not learning. So it's really figuring out what variables are most important. And this figure basically just sort of shows, again, with the x-axis being total hours of gameplay and the y-axis being the stacks beaten. The stacks is as I mentioned, the challenge stacks, the stories, and the number of the score that you can get, the points you can get. And you can kind of see based on this that, at 6 months, we could show some evidence that, if you had, the optimal number of hours and the optimal number of stacks beaten, that was reflected in your knowledge scores on our standardized assessments. So there was a good correlation between knowledge gains based on not only on achievement in the game, but also on time spent playing the game. And this just breaks it down further in terms of sort of looking at the quartiles of the knowledge obtained. And again, just sort of another way to look at this is stacks beaten versus percent change. And we can see, that, and this was at 3 months, that again, the more stacks beaten, the higher level of knowledge acquired based on our assessments. So again, it's sort of very, very simple first steps, looking at this data, looking at the iPad data in conjunction with the standardized data, and trying to figure out how that may add to what we can say about what this game is doing and what kids are learning, or how their behavior is potentially changing. This is just 6 months. We see the trend, again, continuing. So before I go to next steps, I think to think about, for this project, as I mentioned, we were in after-school programs. We were not in clinical settings. But I think in terms of the applications of this type of work could be very important in clinical settings, be it treatment program settings, be it general medical settings. I think this, the use of this type of technology, it may be a little bit more on the fly. It may be an app that they download that they can, they can play when they're in a treatment program or as part of an adjunct to counseling. But I think that there's a lot of clinical application to this because this is really, and we've seen this experience with kids, this is where they are. These teenagers, you give them an iPad, they just go at it. We walk through a tutorial with them, but they really know how to do this. They don't, they're, if you will, hardwired to do this. So I think it can easily translate to them. This game is at this point way too big to be on a phone, but some of the other games that we're developing are, smaller and can be done on cell phones, and I think could really travel with kids, which I think is one of the best ways to give them a dose because it's where they are. So as far as this study, we're completing enrollment actually in the next 2 weeks, and we're currently collecting 12-month data on one cohort and should have 6-month data on the entire sample by October or November. We're further assessing the efficacy of the aspirational avatar and thinking about building that out a little bit more. We're developing systems of evaluating player profile to optimize the targeted outcomes. So in other words, really start looking at, are there certain aspects of a player that they're going to be more likely to respond well to certain parts of a game. And that's complicated and takes sort of a certain level of expertise, and we've actually brought on a postdoc who specifically that's what she does, is look at gamer profiles and figures out what is most effective, in terms of reaching certain types of gamers. And we're also in the process of translating the game to Android platforms, which may expand in terms of our ability to get it out there, as well as also desktops, laptops, PCs, Macs. And then I'm thinking about exploring distribution channels, which was sort of the last part, development, evaluation, and then how to get it out there, which is a challenging but incredibly important step, because you can spend all this time doing this, testing it, say it does this, and then it doesn't reach anybody. So that is something that we're very actively exploring. We also have 2 new projects. We're developing a mobile game called Play It Safe for HIV prevention in young Black women specifically. So that's focusing more on secondary prevention, be it HIV testing, condom use, that type of thing. And then we were very fortunate to receive pilot funding from Dartmouth Center for Technology and Behavioral Health, and we are developing Smokescreen, which is a mobile game for cigarette and marijuana prevention in young teens, and that's actually now on Android phones. So it's got to have the kinks worked out, but it's getting there, so that's very exciting. So that's it. Thank you very much.
Well, three really exciting presentations this morning. Thank you all very much. We're on break now for 15 minutes, until, is it 10:45? Am I in the right hour? Yes. Until 10:45, take a break, relax. And we're going to have time for discussion before lunch. And I know there are going to be a lot of questions and comments. And I'm hoping we can download some of this to fiddle with on various computers. But I'll talk to you with the break. So thank you all.
here, that's fine. Oops. They won't be able to without a user passcode. Yeah, and it's just, I mean, I could give out usernames and stuff. But I'll say to them, email me if you really want to see it. So I want to go on a website. How do I, or I can plug in my computer. When I do I'm doing 11. Hello. How's it going? Looks like you guys are getting a lot of people in. That's good. Have you heard anything about your center, the T32, or is it? What did you hear? Congratulations! Oh, that's wonderful! Congratulations! That's fabulous. Good for you. That is such great news. Wonderful. Right. The downside of actually. So is there room for another postdoc if I could find one? Or are they? I have one guy who's interested and I'll contact him now that I know that funding is possible.
No problem.
Okay, folks, we're going to start up again so we don't get way behind. Okay, please take your seats so we can get started again. Our next speaker is Dr. Alan Budney. Alan's a senior psychologist researcher who came to us just 2 years ago or a year and a half ago now. He's been a colleague of Lisa's and many others for years since they all were at the University of Vermont. And Alan, many of you know, is an expert in marijuana addiction, and he's also an expert in treating adolescents, if that's possible. So I'm happy to introduce Alan Budney.
All right, thank you. It's a pleasure to be here. My talk's on online delivery. It's a little bit of a misnomer in that the treatment that I'm going to talk about, just so I remember to tell you, actually mostly happens in the office. It's online, but in the office. Anyway, what I'm going to do today is go lower tech than our last couple of talks. Those sensor things, et cetera, and the games are great, but I am working in a technology area that's more like what Lisa Marsh was talking about, the TES program, if you remember that from the first talk today. And we're trying to use it to solve a particular problem. So my plan today is to describe a little bit of my historic work in treatments for marijuana dependence, and in particular describe our work on computer-assisted treatments to illustrate how technology-based interventions can promote access. And the access is kind of the key part for efficacious interventions. So unfortunately, like when I get to my screenshots, they don't look anything like Lynn's that are beautiful cartoons, et cetera. Mine are pretty boring. Sometimes boring's not too bad. Anyway, to get you going, I kind of have to bring you up to speed on the status of psychosocial treatments for cannabis use disorders. Oh yeah, and the other nice thing about being here today is that hopefully this doesn't diverge somehow into medical marijuana talk. Everywhere I go now, somehow the conversation shifts to medical marijuana. This has nothing to do with that. This is about treating people who actually are trying to quit or want to quit marijuana, and there are actually a lot of those. Anyway, there are a bunch of effective behavioral treatments that we and others have developed over time and tested in efficacy and effectiveness trials. And the three types of interventions most often cited are motivational enhancement therapy, cognitive behavior therapy, and contingency management, in particular abstinence-based contingency management, which means you provide incentives for somebody who's achieving abstinence. Now, the problem with these efficacious interventions, like the problem with most efficacious interventions in mental health, is getting them to the people, so limited access. In particular, contingency management is always kind of criticized as, oh, it's too costly, we can't do that, even though it works very well. But even MET and CBT are very hard to train up, to get therapists up to speed. There's not that many that do it that well, and to keep good quality going is hard to achieve. So that's been my predicament over my career, is to try to develop these treatments and now see how are we going to get people to do them, and how can we do, even in our trials, how do you get the people to do them well? So to give you a feel for what the data looks like when you treat adult marijuana users, and we're not going to talk about adolescents, that's a whole other line of research, but this is all about adults for the moment. Some of it can be applied elsewhere. But anyway, this is the data from the largest trial, multi-site trial for adult marijuana users. Whoops, I didn't mean to do that. One of these things is okay, there we go. Okay, so this is a multi-site trial. There's 300 to 400 people in this. And basically, this slide is looking for days of use in 3 different conditions. One is just delayed treatment control, so they get no treatment. This is a combination of MET and CBT, the yellow line, and this is MET only. So there's a combination MET, CBT, and MET only. One's 2 sessions, one's 9 sessions. And this is the magnitude of the reduction in marijuana use you get over time. So baseline, everybody's using almost every day, 100%, 90% of the days. You get down to about 40% with a combined treatment. The lesser treatment is also effective, but not as effective. And over time, this is what you get. So the next step is, what about abstinence? How many people actually quit? Well, the quit rates are only down around 20%, even for the best treatment, this MET plus CBT, over time. So this is kind of where my research came into the picture. We were trying to figure out how can we do better than that. Those are the effective treatments, cognitive behavioral things. They work well. Everybody sees those as the treatment of choice. But I was working in the area of contingency management with cocaine, and if you can add incentives or motivational incentives to any type of behavioral treatment, usually you can get better outcomes. So we applied that concept to marijuana quite a while ago. This is a study published in 2006. And what this study is showing you, and it's important for the rest of the talk, is we compared 3 treatments, one of these contingency management alone, the combination of MET, CBT, and contingency management, and then just MET, CBT. And this is at the end of treatment, and the percent of people that are abstinent, the 2 treatments that get CM are doing better than just the MET, CBT. And over time, the key is the combination treatment does best. So if you add this MET, CBT, and CM together, you get the abstinence in the beginning, and the MET, CBT theoretically keeps the abstinence going over time. So that's, in a sense, the gold standard treatment out there, at least in the research world, clinical research world. And then a group from both Yale University, School of Medicine, and a group from UConn have replicated this same type of studies and show that this is basically the best thing we have at the moment. So the problem is nobody delivers this. And everybody complains about, oh, we're not going to give incentives. Nobody will do that at a community clinic. And when you see what people do and they call it MET, CBT, it gets you upset because that's not really very good therapy. Can we do it better? Anyway, there are all kinds of problems with access. So that's the problem that needed to be solved next. And colleagues of mine, Lisa and her ex-mentor, Warren Bickel, started working on this TES program. And it dawned on me in a little while that one of my problems is having to train therapists and keep them around, etc. And MET, CBT, what Lisa called CRA, it's pretty similar, the CBT piece, seemed to work pretty well compared to therapists. And my problem was I needed to somehow be able to pay for my incentive program and not have to deal with all the hassles of training and maintaining high fidelity treatment. And computer-delivered therapies seem to be a possibility. So Lisa put all these up earlier, all the potential benefits of computer-delivered therapies. I highlighted in yellow the ones that are kind of specific to this project, but you get the picture of the things that can possibly accomplish. You can reduce the cost of delivery, you can ease the burden associated with therapist training, ensure integrity and fidelity of the treatment. I mean, if you actually create a good treatment, it's delivered the same way every time, so you're in good shape. Perhaps you could even use some of those learning technologies to do a better job than a person could do because you can get repeated access to it, etc. All these good possibilities. So people have been working in this area long before I started working in this area at the same time, and basically they have computer-assisted or computerized versions of CBT, of motivational enhancement, and some computer-assisted contingency management. And I won't go into that literature, but it's a pretty well-developed literature now, and usually whenever they compare these things, they work pretty well. Not huge studies, but Lisa gave you a feel that they tend to work. And so our problem, as I described, is we have this gold standard. It's not available. Incentives are too costly. Training therapists is hard, especially to get high fidelity and keeping them around. And it's costly. So here's the problems. If the computer can deliver the MET CBT, perhaps the cost savings related to the therapist, what it costs to pay the therapist and to train the therapist and to keep supervision and monitoring going on to get high-level treatment, maybe somehow cost savings with MET CBT via computer can be switched over to pay for the incentives. So that's what we set out to do. That's the problem we tried to solve. And so first we had to develop a computerized version. So pretty much we took this TES system that Lisa told you about, and her husband Mike Grabinski helped develop the software. He's the main man behind the scenes. We got Mike to go ahead and make some innovations and some modifications to the TES system. He tells me now that it's not really a TES system, but it's based off the same framework. But we just wanted to take the manuals that we've used to effectively treat cannabis and kind of translate and make sure they translate well in the TES system. So we created all these modules that were specific to cannabis. We created motivational enhancement modules, which didn't exist at TES in the time. I don't know if they're part of it now, but there wasn't a motivational enhancement piece to it. And we wanted to add that. We wanted to add a few other things that we had in our original treatments, which was a lifestyle goal setting module and some relapse prevention modules. We also wanted to make sure it was web accessible, which back then it wasn't, now it is. So that way, if we did the treatment one in the clinic, they could also work on it from home if they could get into their program. And now I basically just want to tell you what this is about and give you a little bit of a feel for what this system looks like. There are two MET modules. So motivational interviewing. Who knows what motivational interviewing is or motivational enhancement therapy? Most people. Okay, so pretty much it's just a dialogue. Usually you have a personalized feedback report based on your assessment. You do a comprehensive assessment with folks. And then you have a dialogue about their personal goals and how marijuana might be affecting those goals. And there's some social norming built in. There's a bunch of different things. It's a little hard to imagine how the computer would do that. But we tried our best with Mike's help to figure out how the computer would do that. And this is the screenshot from one of the modules that delivers MET. And one of the things you do is first you ask them about their goals in their life. What kind of goals do you have for your life? Once they kind of write those down, the next step is they'll see their goals listed on the left, and they'll say, how does marijuana affect your goals? Positively, negatively? So just gets them thinking about how marijuana affects their lives in the best way we could think. Then it has things like, well, how much money do you spend? And their assessment said, oh, you spend $300 a month, $3,600 a year. And then it says, well, write in what else you might want to spend that money on if you didn't spend so much money on marijuana. So these are all the traditional kind of things that happen in an MET interview. Then you do something like, well, if you did change your use, what would the potential pros be? What would the cons be? And pretty much the computer spits back out what you listed as the costs of changing your marijuana use and the benefits. And you get this little scale. This is the traditional cost-benefit scale for MET. So we tried to make this happen. Then we worked on developing CBT modules. That wasn't so hard because pretty much the TES is a bunch of CBT modules. And so we took what was there, just modified it a little bit, make sure it was specific to marijuana, a couple different exercises, etc. And Lisa gave you a feel for what those look like, but a little bit more. You can't see this very well in the back, sorry, but this is just the menu they see when they call up their own TES program, where they go in and put in their own password. And it just lists all the sessions. And they would just click on session 7, and they would get introduction to problem solving, and it'd take them to another screen. And when they first sign on, when they first get to that screen, first it'll just say welcome back. And they'll have on a pair of headphones, and it's audio eyes, so they can either read it or listen. And this guy with this nice radio voice says, welcome back, you know. And he's okay. Anyway, you get the feel. This is, hopefully there's not audio. This one has audio, but I'm not going to play it. But this is just a screenshot of what happens when you introduce them to the notion of refusal skills. And it takes you through the steps of effective refusal skills. And then part of that module shows you a video of someone doing a bad job of refusing drugs as they walk down the street. And these guys started asking this guy if he wants to get high, and he says, I don't really think so. And they eventually convince him to get high, and then you can play the next vignette, and he effectively refuses marijuana, etc. Then there's all these tests built in. Part of the learning technology behind this is that you're trying to make sure they have actually learned what you're teaching them, these coping skills that you're supposed to learn. And so at the end of the assertiveness training, it'll say assertiveness refers to all the following except. You have to answer it. If you get it wrong, you know, it tells you what the correct answer is. It tells you why. It makes you go back and take it again. So it's kind of trying to guarantee that people are more likely to learn what they're supposed to be learning. And the little piece that's computer assisted about contingency management is when they first log in, they also see a progress graph of how they're doing in terms of earning incentives. This is how much money, this is the end of treatment for this guy. He'd been in treatment for 12 weeks, twice a week urine testing, so there's been 24 times he's been tested for marijuana. Over that time, he's earned $234 incentives because he was staying clean, then he had a lapse. Got a clean test, lapse, clean test, clean test, clean test, lapse, clean test. So that's kind of the way these graphs gives you a visual picture of how you're doing. So that's the MET-CBT, just a nutshell of how this works. And they basically come into our clinic like they come in for a treatment session, but the therapist doesn't have to be scheduled, et cetera. A staff support member can just sit them down and get them started. They do this whole thing on the computer. Anyway, so we set it all up. Took quite a while to figure that out, longer than we had hoped. But anyway, first we conducted a quasi-experimental pilot study. This was published in 2011, so it's been around for a while. But the way this worked was we ended up with 38 people, so it's a small study. But the first 16 just got the therapist treatment. So we're training up our therapists, and while we're waiting for the software package to get developed, they get this. Then the next 10, the software package is developed. They get the software. They get assigned to do the computer-assisted treatment, and the next 12 we randomized, and we threw them all together for a pilot comparative study. So the way it worked is two conditions. You have the therapist-delivered MET, CBT, CM, and the computer-delivered. The difference is the C and the T there. Anyway, it's a 12-week study, 12-week trial. They get twice-weekly urine testing. Everybody gets the incentive system for staying clean from marijuana. We ended up with 22 in the therapist condition and 16 in the computer condition. In the therapist condition, you get 9 MET CBT sessions with a therapist, 45 minutes to an hour each, a traditional kind of model. In the computer-assisted version, you get those same 9 sessions delivered by the computer. And you also get assigned a therapist to see 3 different times. You only see the therapist for like 15 to 30 minutes. They're there to just be supportive. Make sure you understand the computer program. If there's any crises, they'll help you out. They're available if you do want to call and set up an appointment. But pretty much, they're not doing MET, CBT, or anything that's supposed to look like MET, CBT. They're just there for some support. And the computer program, like I said, you can also access from home if you have internet service. So the first study, these are what the patients looked like. They were all seeking treatment for cannabis use disorder. This was down in Little Rock, Arkansas. About half were male, half to 3/4 were white, the rest were African American. Average age about 30. That's the average age for adult trials with cannabis. They used marijuana about 80 to 90% of the days. 3/4 of these met criteria for marijuana dependence. The other quarter met criteria for marijuana abuse. We ran them through the study, and this is what the data looks like. It's pretty straightforward. This is urine test attendance, so twice a week they're supposed to come in and give their test. This is coming to your MET, CBT sessions, either with a therapist or the computer, attending the clinic, and pretty much you see no difference between conditions. It looks like the computer might be doing a little better, but there's no statistical difference. So attendance, acceptability seems to be fine for the computer. Abstinence rates, what you have here is the percent of participants that are abstinent from marijuana for more than 4 weeks or more than 8 weeks, and you see the computer conditions in red, therapist in yellow, no difference between the conditions. So again, it looks like maybe the computer does a little better, but there's no difference statistically. So pretty much this demonstrated that, then we also asked them how they liked the computer software program. I always think these ratings are biased with social desirability, so they're pretty high. The lowest is 7 out of 10 on how useful was it, how relevant to your life. They give it good scores. I'm not convinced they liked it that much, but they certainly didn't complain a lot about it. Some people say, oh, I already know everything, and some say it's God's gift. So it varies quite a bit, but none of them really complain. They usually run through it without any hassle. We were also interested in trying to figure out, are there cost savings? That's the main purpose of this. Are we saving some money? And this first study, we didn't do a cost analysis. We just tried to figure out how much time's being spent where, because time is money. And so over here you see total time with the therapist. And in the therapist condition, it averages about 480 minutes per patient. And for the computer condition, they spend under 50 minutes with a therapist throughout the study. Meantime, they spend in the sessions themselves. So when you see a therapist for MET-CBT, you spend about 45 to 50 minutes. And when you do a CBT module on your own on the computer, you only spend a little bit under 30 minutes. So the patient's saving some time, and you're saving therapist time. So both ways, it's kind of a win-win if it works as well. So this first little study pretty much just showed what you saw, pretty clear. These seem to be equivalent. The computer-assisted treatment was highly evaluated, and potential savings. So the limitations is this isn't a randomized study. It's a small sample. There's no control or comparison group, so really both treatments could be bad. If you never know, they're both not working. They're just equally bad. So you need a control group. And there's no post-treatment follow-up. That's the key piece. Because if you look back to that 2006 study I showed you, we didn't need a therapist of any kind to do as well as the MET-CBT combined with CM. CM alone did just as well during treatment. So during treatment, you can get abstinence rates. You don't need a therapist. It's post-treatment where the MET-CBT had its effect in our earlier studies. So the next study needed to look long-term, how well can the computer maintain these effects? And so this study's done too. This one's under review. Hopefully it'll get published soon. This time we have 3 treatment groups. The control group is an MET 2-session only group, and then we have the same treatments I just talked about. And this time we're going out 9 months post-treatment to see how well the effects maintain if we get them again. And we also have a more formal cost analysis this time around. And a fellow named Mick Tilford down in Arkansas, health economist, helped us with this. The sample population looks pretty similar. It's a little bit over half that are male, a little higher, more than half are African American in the second trial. The average age around 34, 35. Again, they use marijuana on 80 to 90% of the days. They started using when they were 14 or 15 on average. Quickly to the data. This is attendance data again. So the 2 MET-CBT groups, pretty much no difference in session attendance. This time the therapist one slightly higher than the computer one, but no difference at all. When you look at abstinence, this is the amount of abstinence they achieve during treatment. And again, the 2 CM conditions, computer and therapist, do better than the MET, so we do know they're effective or efficacious, and there's no difference between these groups either. It's a little bit different this time. Therapist is slightly better, but it's not statistically significant by a long shot. Here's the slide that really matters, what happens over time. So right here at the end of treatment, we got about 50%, 45-50% of the 2 active groups staying clean, doing much better than the control group. Over time, the red bar is the computerized therapy, and the yellow bar is the therapist-delivered therapy, and the computer-delivered therapy is doing at least as well as the therapist-delivered therapy over time. That's what we wanted to see. These aren't really statistically significant when you collapse over time, but we know they're at least doing as well, if not better. It looks like the computer's doing better, but again, we can't show that clearly. So that's what we're looking for. It looks like the computer can also help maintain the effects we could get with a CM. And how much do you save? We costed this out, and I won't go into the details, but it was a fairly sophisticated cost analysis. You save about $350 per case. So the therapist-delivered one averaged about $600 in cost, and the computer one was about $230, same as what MET cost. And so you get fairly equivalent outcomes, and you save yourself about $350. So the conclusion is pretty straightforward. We're trying to figure out how do we solve this problem? How might we make it more affordable and increase the reach of MET, CBT, CM for cannabis and perhaps other types of drug use disorders. And pretty much we showed what I just presented. And I don't really need to go over this again. I don't think you get the picture. The implications are perhaps, and we haven't tried to do this yet, it's easier to put MET, CBT on a computer and get somebody to do it, save some money. Therapists can be doing something else in your treatment center, or you don't have your therapist, one way or the other. I usually don't hold back from saying maybe this could replace therapists to some degree and they can be doing something else. It is what it is. And you can save your money, and you need those incentives. Those incentives, contingency management is the most powerful treatment we have in our substance use disorder armamentarium. That's what we got. And we know when we try it with cocaine, opiates, et cetera, it can increase our efficacy rates anywhere from 20 to 40%. Got to find some way to put it into the picture. This is one possibility. The limitations of my research, these little studies, they're both fairly small. There's some missing data, so it'd be nice to somebody to replicate it with a bigger trial. In the comparison studies, we only have 2 therapists, so we are comparing 2 therapists to the computer. You know, the 2 therapists, we did some fidelity measures. I'd characterize them as very average, maybe slightly below average. They didn't get super high fidelity scores, so it's possible somebody with higher fidelity, MET, CBT, maybe they could compete with the computer a little better. But by and large, we supervised and monitored them very carefully, and you get what you get. These were some very good therapists for the area, but the quality of the MET CBT is still pretty average. These trials are only testing MET CBT in the context of CM. So it's really not a test of MET CBT with a computer versus a therapist by itself. That said, others have done that. There's a woman, Frances K. Lampkin in Australia. She's done a couple studies kind of just like mine, but there's no CM. She has a little bit different MET CBT program, probably better than mine, and she gets equivalent outcomes, sometimes slightly better using the computer rather than the therapist with cannabis users who also have depression. So it's pretty impressive. How are we doing for time? Okay, all right. What I thought I'd share with you just quickly is where we're going from here. So I haven't followed up on that. I'm not trying to implement it in any way. I'd love to get together with someone who wants to do a large-scale trial or figure out how to get it into a treatment center. But scientifically, what we've moved on to is the issue of cannabis and tobacco co-use. And we're using that same program to go after that. So we're trying to combine our gold standard cannabis treatment, which now is delivered via computer, so it's not too expensive, with the CM, with a tobacco treatment. And for tobacco, the treatments of choice are behavior therapies and medication. And in this case, we're choosing to use nicotine replacement therapy. And so what we've gone ahead and done is created some similar types of tobacco modules using the same platform. And Mike Grabinski, again, has worked on us with this. And so we now have an MET-type platform, which we borrowed from JF Eder. This is an internet treatment that's available to anybody at any time, actually, and it gives you a feedback report. It's more sophisticated than the one we used because they're very expensive. It actually has an email coaching system where once you sign up, if you kept going, you're going to get emails every week that relate to your treatment process. Very cool. And we created some NRT education modules. So if you're going to take NRT, you have to go through these modules online to teach you how to do NRT right. We have modules on the marijuana-tobacco connection to talk about the withdrawal syndromes, how they feed off each other, give you some impetus for maybe why you might want to quit both at the same time. We have reduction modules. So if you're trying to reduce rather than quit, we can try to help you out with that. You get the picture. So that's what we're doing now in my clinic. We have a cannabis tobacco project funded by NIDA, and we're using these procedures. We're not testing the computer at this point. We're just using it as if it's the way to go. And I think there's enough data probably to support that. So in conclusion, these are general conclusions about computer-assisted interventions for any type of SUD. They're basically highly acceptable. Lisa touched on other types of substance use disorders, cocaine, opiates. Whenever they're tried, they're acceptable, and they seem to work pretty well. They can be as effective as comparable interventions in my study and others. They can be more effective than treatment as usual if treatment as usual isn't good. And that's the case many times in our treatment agencies. They can enhance quality and reach, and they can be cost effective. What they haven't been tested with, and Lisa mentioned this, is a standalone treatment. I'm not advocating you say someone that has a cannabis use disorder and is trying to quit, that you just give them our program. We don't have any data to support that they'll really do it and it'll work. It may, but it's not been tested for that, and that's not prime time yet. So I'm going to kind of finish there. This is all the folks that have been working with me on these projects through the years, both faculty members, postdocs that have worked in the past and in the present, and research assistants from the past and the present. And I thank you for your time.
Okay. We'd next like to introduce Dr. Tracy Stecker. She's an assistant professor of community and family medicine here at Dartmouth and at the White River Junction VA Hospital. And Tracy's a national expert in health engagement behavior, trying to help people find their way to treatment who are currently outside of the treatment system. And I think she's going to tell us about one of her current studies at the VA. Is that right? No. Okay. We're going to find out what she's going to tell us about.
Thanks, Bob. So I'm going to talk about an old trial. It actually was done in between 2007 and 2009, and the data was published back in 2010. And I have to admit, I feel like a bit like a goofball if you thought yours was low tech. This trial is, my technology is the telephone. So I'll just do the best I can to hang with this crowd here today. But I'm going to talk about the trial that we did. That the goal of this study was to get individuals with alcohol use disorders who were struggling with their alcohol use, who had never gone to treatment, into treatment through a CBT delivered over the phone. Everybody in this room knows why we would try and get individuals with alcohol use disorders into treatment. Most do not get any sort of care, so we were trying to get them in. There were two theories that we used to, that were the conceptual models for this work. It was a theory of planned behavior, which is a theory that talks about beliefs, how beliefs can predict whether or not somebody engages in a particular behavior, and of course cognitive behavioral theory, which is a theory on how beliefs, feelings, and behaviors are all interrelated. Thus, if you change beliefs, you can change behavior, and in this case, it was treatment-seeking behavior. The goal of this study was to see if we could do an RCT to assess whether this cognitive behavioral intervention delivered by phone would result in increased treatment seeking. The sample were 200 individuals who screened positive for an alcohol use disorder using the audit. They were randomly assigned to either the intervention or the control groups. Participants in the control group were just read a pamphlet over the phone about the dangers of alcohol misuse. Participants in the intervention group had a one-time brief CBT session delivered by phone. And then all participants did baseline and follow-up interviews 3 months after their participation to assess them on their beliefs about treatment and treatment utilization. I just said the measures, but we assessed them on their beliefs about treatment. That's the impasse scale. Readiness to change questionnaire, and the treatment services review was used to assess treatment utilization. The intervention is, it takes about 50 minutes to go through a session with someone on the phone. The session is really designed to talk about where that person is right now in terms of their alcohol use, what their thoughts are about getting treatment, and taking them through some of those thoughts in more detail so that they're thinking differently about treatment use. The final step is to make a plan with them. An example, if somebody said during a session that they were struggling with their alcohol use, but they didn't feel like their problem was bad enough that they needed to go to treatment, they might alter that thought to, for example, it would be good to talk to somebody before things get worse, or it's just really hard to admit that I'm having a problem. And that's more the issue than it's not bad enough to seek treatment. Our hypotheses were that people who received the intervention would have more positive attitudes toward treatment and would be more likely to attend treatment. The sample ended up being 198 individuals. Half were male, 3/4 were Caucasian, about half had insurance. The mean age was 40, and they had pretty high scores on the audit. They were compensated for participating in the trial. Results, individuals who received the intervention had more positive, well, the scale here is backwards, but they indicated they were more likely to attend treatment than people in the control group. They had more positive attitudes toward treatment, although the scale here, it doesn't look like it's significant, but it's minor. It went from like 5.2 to 5.5, so that it doesn't mean much. They had positive attitudes about treatment at baseline, and they just went a little bit higher, but it ended up being significant. Subjective norm, this is back to that theory of planned behavior. These are the idea that important others in your life would be supportive of you seeking treatment. That's not a significant result. People indicated that their family members and friends tended to support them getting help. And perceived behavioral control measures their perception of barriers or facilitators to them getting treatment, and individuals in the intervention group tended to, at follow-up, thought that their scores went higher, so they felt like they had more control over going to treatment than the control group. In terms of treatment engagement, participants in the intervention group were 3 times as likely to attend treatment at the 3-month follow-up than individuals in the control group, but I always point to this, it's 30 versus 10 essentially, so most individuals in the group still did not seek treatment. I have this slide twice, sorry. The most common themes that were talked about during intervention sessions among individuals with alcohol use disorders had to do with the discomfort of seeking treatment. For example, getting help would be hard, it wouldn't be a vacation, it's hard to be intimate and close with people, it's hard to admit to someone I have a problem, and I worry I won't survive detox, it would be uncomfortable. That was the primary theme, a barrier for them for going to treatment, and in the intervention session we would talk through that fear. The second most common theme was they didn't need help, they like drinking, drinking makes them happy. And the other themes that came up were they can control it on their own, there's a stigma against having an alcohol use disorder, and the idea that alcohol is their primary coping skill. Without it, they don't know how they would cope. An example of a session, this is just one example, is a 59-year-old Caucasian female, and in her session she said, if drinking made me unhappy, I would stop drinking. Drinking makes her happy. Drinking helps her fall asleep, and she just didn't know how else she would relax. And during the session, she modified those thoughts to, well, actually drinking does make me feel unhappy. It makes me feel out of control and less sensible. My mind races when I get exhausted. I could learn other ways to unwind, and other things do relax me. She realized she did have more coping skills than just alcohol. She was not looking forward to going to treatment, but by the end of the session she decided that she would do it, and she was going to do it for both herself and her daughter, and her plan was to actually go to counseling and not attend AA. So in summary, I hope I made up some time here whipping through this. Participants receiving this type of intervention were more likely to enter treatment. More research is needed, and more work should be done to find a home for this type of intervention. I do want to say to any clinicians in the room, a lot of work might be done by one individual by the time they I think it's important in a first session to acknowledge maybe the years of work that individual went through to finally get to that first session. Just take a moment to acknowledge that. And that's it.
Thanks, Tracy. So our next speaker is Dr. Mary Brunette, who's an associate professor in psychiatry here at the Geisel Medical School. And Mary's been a pioneer in considering the last holdout group, really, for tobacco cessation. As many of you know, the rate of tobacco use has gone way down in the general public, but has not gone down at all among people who have serious mental illness. And Mary has done a serious job of tackling this problem and trying to figure out how to get these folks into evidence-based treatments. So, join me in welcoming Mary.
All right, now you're going to see how technology challenged I am. There we go. Up here. There you go. Thanks.
And then just to remind you, you know what? Just click on
Okay.
there.
So I escape and then I do that.
Yep.
Okay. Okay. Can people hear me okay? All right, great. All right, so as Bob said, I'm gonna talk about this online motivational decision support system that we developed at Dartmouth. Joelle Farron was the lead who initiated this work, and I joined her, and a whole host of people have helped us. You can see this long list, and there are many others. The work that I'm going to present today has been supported by the West Family Foundation, Bristol Myers Squibb Foundation, National Cancer Institute, Lisa's NIDA Center, and I think that's it. Okay, so my goal today is to identify advantages for using technology in smoking cessation treatment efforts and to talk about strategies of adapting technology to be useful for disadvantaged populations. So not everybody is attending college at Dartmouth. There's other people out there who may be a little different, and I'll expand on that. So I'm going to talk about tobacco. The picture on the left is a Persian woman who's smoking tobacco from a hookah about 2,000 years ago. So tobacco's been around for a long time, and people figured out how to enjoy it a long time ago. The picture on the right is familiar to everyone, I'm sure. It's the Marlboro Man from an advertisement. I think that was in the 80s. He looks fairly contemporary. Smoking or tobacco in the Western world was actually used through chew and cigars until the 20th century when smoking cigarettes became popular. And this is data that shows the use of cigarettes. Let's see if I can work this thing. So there's 1910. Here's white men. Smoking peaked around 1950. Guess what happened in 1950? Anybody know? Yes? Yes. And what did the Surgeon General's report say? Smoking causes cancer. So a massive public health campaign began, and look what happened to the prevalence of smoking among educated white men. Went down. Educated white women, down. What about uneducated people? Not so much. Uneducated women, it keeps going up. That's the women's movement. So it turns out the public health campaign worked for privileged educated people, but it didn't work for those who have disadvantages of low income, low educational level, okay? And it didn't work for another very large group of people, people who have mental illness and or people who have addictions to alcohol and drugs. So here's data from a national survey that happened in the US in the 90s. At that time, among people, there we go, without mental illness, about 40% said they had smoked at some time in their life, and almost half, the darker blue bar, said they had quit smoking. That left a current prevalence of smoking around 25% at that time. But what if you have depression? What if you have anxiety disorder? The rates of ever having smoked are a lot higher, and the rates of quitting are lower. What if you have a severe mental illness? What if you have schizophrenia or bipolar disorder? Or what if you're addicted to cocaine? The rates are even higher, and the quit rates are even lower, okay? So you can see this is another really important disparity group. These are people who are still smoking. In a more recent national survey, those without mental illness, 18% were smoking. Those with mental illness, 30 to 60%, with the same kind of range here. If you have a severe mental illness, you're around 60%. Otherwise, you're around 30%. That's a lot of people. A recent report said that they did a calculation and felt that people with mental illness or addiction smoked almost half of the cigarettes that are consumed in our country. And we're just, as a treatment community and as a public health organization, we're not making inroads. We're not helping this group quit. Here's people with schizophrenia from 99 to 2011. The rates are flat. People aren't quitting. The prevalence of smoking is staying the same. Here's bipolar disorder. In this study, it looks like it's actually going up. That's not good. Here's the general population, people without mental illness. It's actually going down. So even up to the current time, this is happening. We're not making progress as we should be. So why do we care? Well, for me, this is kind of personal. So this is a picture of a guy called Ted, who I worked with. I worked at Manchester Mental Health for many years in the 90s, and I worked with a lot of people who had severe mental illness. And during that time, we asked people about smoking, and we talked with them, but we didn't necessarily do much. So this was a guy who was probably in his late 30s. He had gotten ill when he was a teenager, really struggled with schizophrenia for a while, was in and out of the hospital, smoked a lot of pot, did drugs, but he got his illnesses under control. So by the time I met with him, when he was about 38, he was doing pretty well. He was volunteering, saw his mother every week who lived in town. He had a girlfriend that he enjoyed being with, but he still smoked cigarettes, a couple packs a day. So I asked him about it. I advised him to quit. I offered him cessation treatment. He said, "No, thank you, ma'am," and I let it go, which is what we did at that time. Since that time, reports like this have come out showing increased early mortality in this group by 30 years. So all of you can expect to live to about 80. If you're in this group of people with severe mental illness, you can expect to live to about 50. Well, okay, those are statistics. Fine. Back to Ted. So I worked with him for about 5 years, and then I left that job. I took a job working at the Department of Health and Human Services in New Hampshire. So I'm the medical director for the Bureau of Behavioral Health, and one of the pieces of my job is that I review all the deaths that happen in our mental health system. And about 5 years ago, among one of the papers shoveling across my desk was Ted. Hadn't showed up for an appointment. Case manager called, no answer. Mother doesn't know where he is. They go to the home, knock on the door, no answer. They finally call the police to do a wellness check. They break into the apartment, and Ted is found dead on the floor. Died of a heart attack, age 51. So, smoking causes heart disease, and that is the major killer of this group of people. This is something that's preventable. Smoking is the most common cause of death that's preventable in the US, and it's killing the the people that we know and love. So we need to do something about this. So we've been thinking, well, what could we do about this? There's a variety of strategies we could take in working on smoking. You can take the overall view and look at the environment and policy. We tax tobacco, we raise the price, and that inhibits young people from starting to smoke. It's effective. We could train clinicians how to do a better job of treating people. We can work on our treatments. We actually have pretty good treatments that are effective for helping people quit smoking, but you could argue that they could be made better. Or you can work with the patient or the person who smokes. And this is the strategy we decided to take. At Dartmouth, we're really working on developing patient decision support systems to help people be more involved in their treatment, to help them be engaged in their treatment. So this is the track we wanted to take. We wanted to build on that experience at Dartmouth. Because we do have good treatments, this is just an example of some data for smoking cessation in people who have schizophrenia. Whoopsie. You can see here, people who use treatment, over half of them were able to quit smoking. That's a very substantial outcome, much better than the control treatment. So treatments dramatically improve people's ability to quit, but they just don't use treatment. We've done a lot of qualitative work. Generally, people with mental illness and or addiction just have a lot of misinformation about cessation treatment, a lot of attitudes that inhibit their ability to participate in that. So what do you do? Well, there's a kind of counseling called motivational interviewing. That's a style of counseling designed to engage people in a health behavior change, in this case, smoking cessation or using cessation treatment. That's been studied for people with mental illness. Some of my colleagues have done this and shown, yeah, you can get people engaged with a single session, kind of like Tracy's work that you just saw. The problem is that our mental health clinics, our addiction clinics, people are super busy, they don't know how to do this style of counseling, and it just doesn't happen. So rather than embarking on, working on clinicians, we decided to take the patient-focused approach, and we thought, can we use technology? Can we use technology as a tool to help us deliver this kind of intervention? Lisa Marsh talked early this morning about how technology can really expand the reach of an intervention. Here's some data that exemplifies that. This is data from Minnesota, where they had a statewide tobacco control program that included some in-person treatments, a telephone treatment, and a web-based treatment. And you can see that this website is the purple line. This is how many people were reached by the intervention. 10 times more people were able to use treatment by using the website compared to these in-person interventions. So it dramatically expands the reach. And in doing so, reduces the cost. Look at the cost per quit here. It's just minuscule compared to in-person treatment. And it delivers treatment the same way every time. Lisa mentioned that. You can ensure quality of treatment by delivering it with electronic tools. So we saw this, and I went into Joelle's office one day and I said, wow, maybe there's a website we can use. So we got out the laptop, she typed in to Google, quit smoking. And these are the 4 websites that came up first. BecomeAnX.org is a website made by a private foundation that wants to help people quit. PM USA, that's Philip Morris's website. Phyllis Morris is a tobacco company. They have a website to help people quit. Isn't that nice? They, as part of the settlement agreement, they were required by law to help people quit smoking, which I have to say I still find quite ironic. They're selling the tobacco to get you addicted, and then they're going to help you quit. Anyway, so that's one of the other websites. Smokefree.gov is the National Cancer Institute's website, designed to help people quit, and Why Quit is another private foundation website. We thought, this is a nice array of websites. Let's test them out. Let's see if they're good. Let's see if they could work for people with schizophrenia, people with addictions. So we got a panel of experts. We developed a comprehensive checklist that looked for content and usability based on recommendations for people with disabilities. And we had experts go through these 4 websites. Which one do you think was the winner? Somebody says Philip Morris. I'm happy to say that's not true, although they were not bad. What other one do you think won? National Cancer Institute. They really had the best website. It still wasn't scored super high, but it scored the highest. Philip Morris was okay with usability, but that website contained misinformation. So it flunked because it was providing misinformation. Okay? So we felt, based on our assessment, that none of these was really that great from the expert review point, but we thought, let's have our user group test them. So we invited people with severe mental illness to try these websites out. We gave them 2 specific tasks to try. One was find information that will help you cope while you're quitting. Number 2 was find information about Chantix, a quit medication. We had them sit down with these programs and try them, and here's what we found. Philip Morris's website was the easiest to use. National Cancer Institute website, people could not use it. So based on that, we felt there isn't something out there that's really going to work well for people with severe mental illness. We think we need to develop our own. So that's what we did. We wanted our website to motivate people to quit smoking and to motivate them to use effective cessation treatment and to give them information about cessation treatment. We wanted the website to be welcoming to all racial and ethnic groups, and we wanted the website to be usable by disadvantaged populations who may have cognitive impairments, may have low reading ability, maybe they can't even read at all, and so on. And people who don't really know how to use a computer, we wanted it to be usable really by everyone, all smokers anyway. So Joelle Farron took the lead on building this out and doing a lot of user testing. So many people this morning have said it. I'm going to say it again. It's really important, whatever technology-based tool you're developing, you want to make sure your end users are involved in the development along the way. That's the only way to ensure that your tool is going to be appealing to them and usable by them. So you can see here's a picture of one of our users giving us feedback on these tools. So what we ended up doing was building in some instructions for how to use the tool in it. So if you aren't very familiar with a computer and you get on this, you can click and get information on how to use a computer mouse. There are a lot of explicit instructions within it telling you what to do. We also settled on a very simple linear design. So in this website you get on, and it's like you're getting on a train, you're going to go forward to the end. It's as opposed to being at a central hub and being able to go in any direction. You're going to start and go in one direction. And that keeps people from getting lost. It's also only 2 layers deep, also to prevent people from getting lost. If you want more information, you can go deeper and get more information, and then it always brings you back to where you started, so you don't get lost. We use large buttons and font. This group may have dexterity problems, may have difficulty reading and seeing. We use a lot of explicit instructions. We don't rely on abstraction. We don't rely on working memory. We try to make everything really explicit. You look at the page and it tells you what to do. We also keep the language at 5th grade level, and we use text-to-speech software, so the program is read to you if you choose to have it read to you. So you don't need to read it all to use this program. The content from the program is based on the theory of planned behavior. The idea here is we address attitudes about smoking and cessation treatment, social norms, and perceived behavioral control, as those all impact change in smoking behavior. We use video hosts of people like me, so we have a person with mental illness engaging the user in the program and guiding them through the program. We have quit stories, people who have mental illness who quit, talking about using treatment and how it worked for them. All of this was guided by focus groups and user testing. We also use functionality to enhance engagement for people who have difficulty concentrating, paying attention, difficulty remembering. The more you can keep them engaged in every single page, the more they're able to pay attention and then remember what they're learning in the program. So it's interactive. People put in information and get information back that's synthesized, and they get reports about what they put in. So we use this kind of process to develop this web-based decision support system that's designed to engage people in evidence-based treatment. We also found that there's a lack of access and ability to find good behavioral treatment once you want to quit. So we've started building out a cessation treatment website, and we're working on a cell phone app that's designed to be with a person and provide in-the-moment support for cessation. And the design is all really simple. So this is an example of a page from our website. Looks kind of boring, doesn't it? Well, anytime you make it more complicated, people would get confused. So if you see here, there's our logo, and there's no other confusing information being presented. There's no ads, there's no blinking lights, there's no moving parts. We're talking about one simple concept on this page. We're not trying to do 2 or 3 or 4 concepts. We're keeping it to one. And there's one function to the page. We're not trying to do multiple functions. Look at how big the buttons are. That's so you can get that arrow on there to click. Look at the explicit instruction of what that button is about. You're going to click if you want to know more. Okay. So how are we doing for time? I think I have time. I think what I'm going to do is actually get on the website and show you a little bit about how it looks, because I think we have enough time. So let's see if I can make it happen. Escape. All right, so this is our landing page. There's explicit instructions on the site explaining what it is and what to do, and there's 3 big buttons of the 3 different sections for the site, and there's automatic text-to-speech, and let's see if I can make it work. We muted this, and I don't know if I'm unmuting it. Let's see what happens here. So you're seeing an administrative version of this so that I can jump through it. So normally a user wouldn't see this, but this allows me to scroll through the website and jump around. And I can see that it's in the middle of it. So in this section, I'm just going to go back to the first section. Bear with me for a minute here. I'm looking for my tech guy to see if I can get sound. How do I turn the sound back on? Lower right corner. All right.
Scroll to the bottom to see all of your choices. Click on the dog.
So just let me turn it down the other end, and you can.
Okay, and then I click this button? Okay, sorry. So I'll just explain this section of the program to you. So the user would see this. In parts of the section, if people want more information, they can get information from a doctor. It allows them to choose a doctor. We try to provide a variety of people that they could hear from. So if you click on one of these, you'll get information from them later when you say you want more information. If I show you a video later, you'll see the video we actually stream through this is fairly low quality, and we do that so that at a mental health center or an addiction treatment center or a federally qualified health clinic where we're using this, they don't have good quality computers. They don't have high quality internet connection. So if you try to stream really high quality stuff, it gets mucked up. They don't have the capacity for that. So we use lower quality stuff that will go through. So here's some basic information. The person has it. Let's see if it's gonna don't know if I got the right. I'm trying to get you the audio, but I'm not. I'm sorry. I'm going to make this guy come up again. Anyway, so you click next, and of course I'm clicking and it's not working on this computer. A little more information.
Nicotine addiction and withdrawal. When you cut down or stop smoking, you feel grumpy or nervous and you crave tobacco. This is called withdrawal. Counseling, nicotine replacement therapy, and other medications can reduce withdrawal. You can watch a video of a doctor talking about tobacco if you want to know more. Click on one of the answer boxes below. Want to know?
So I want to know more. And the doctor's supposed to show. This is great. This is why nobody shows you their live thing, because it won't work when you actually show it. And it's taking a long time to load here with the internet connection here. All right. Well, you get a sense of what it looks like. And so you can see the importance of your content and making it work with the internet that your user site has. So we designed this program to be, we talked earlier today about standalone that are going to be direct to consumer. We talked about tools that could be used in a clinic that might be a clinician extender, or a tool that could be used in a clinic that might be a clinician replacer. We designed this to replace a clinician to do a motivational intervention and to provide decision support, but for it to happen within a clinic where you could have it be on a computer in that office, in a room where a doctor or clinician could prescribe this and invite all smokers to get education about smoking and to use it in that setting. All right. So I'm going to go back to the program here and my slides. Oh, I'm a Mac user and this is not. And now where is slideshow? There it is. F5. Now I gotta get you there. Okay. So, just want to remind you, this is what a standard website looks like. Look how different that is. How much cognitive effort it's going to take to navigate this and read this compared to that. So for a disadvantaged population, this is a lot more accessible, okay? So just another example. So this is the page that's talking about triggers on this standard website. Here's a page talking about triggers on our website. Really simple, really clear, large buttons, one concept, okay? So we studied it, we've piloted our website. We've taken it to several different mental health clinics. This was our first pilot. You can see overall, those who used the website, over 40% initiated evidence-based cessation treatment, compared to about 15% of our control group who were given a public health pamphlet. We did another larger pilot study in 140 people. We replicated our finding. About 36% of our folks initiated cessation treatment. Among the group, almost a third actually got at least a week of abstinence, which was great. We did an analysis where we tried to predict what helped people get abstinent. We wanted to know, did our program work for just people who had depression over those with schizophrenia? Did it matter how addicted you were to cigarettes? Did it matter what level of psychiatric symptoms you had or what your level of impairment was? And the only thing that
my name is Dr. Eric Hudson.
That was the doctor we were waiting for. I'm never showing my website at a talk again. Oh, God. So we wanted to know what predicted whether people could actually get abstinent. We wanted to know if the website worked for all comers. And what we found was that the only thing that predicted abstinence was using cessation treatment. So whether or not whether you were old or young, whether you had schizophrenia or a different mental illness, whether you had high symptoms or low symptoms, whatever your reading ability, none of that predicted abstinence. So we interpreted that to mean this seems to be usable and effective for a range of people with serious mental illness, disability. Okay, so that was helpful. The one thing that did predict whether you got abstinent was after you got through the program, if you said, "Yeah, I want to try to quit," that predicted whether you got abstinent. We did find that people who had schizophrenia, people who were older, and people who had lower cognition took more time in the program. So they compensated by just taking more time to go through the material and connect with the material. We thought, well, this seems to look pretty good in mental health clinics. What about federally qualified health clinics where a lot of disadvantaged people get care, and a lot of those people are smokers? We replicated our finding there. It seemed to look very similar. Among the user of the program here, almost 50% initiated cessation treatment. We also tried it out in a small group of pregnant women. We built out some content focused on pregnant smokers to see if we could engage them. We didn't have as good of luck with our pregnant smokers, 11% engaged in treatment. But why do you think that is? What is evidence-based treatment for smoking cessation for pregnant women? There's not a lot of options. It's basically counseling. Medication options don't work for pregnant women, or they're not safe. So there's not as many options to choose from. These were our abstinence outcomes in this federally qualified clinic. We did see that, oh, by the way, the green this is our control group. That's the number of people who use cessation treatment in our control group. Among the people who used the program, those who got abstinent were a lot higher than our control group as well. So it looks promising for a variety of disadvantaged smokers. And we're studying it in a randomized controlled trial right now. All right, so in summary, people with mental illness and other disadvantaged groups are at high risk for smoking, and consequently they have disparate health outcomes. Technology seems to be an effective way to deliver tobacco treatments to them, but we really need to adapt and modify the structure of these treatments when we're serving disadvantaged groups. Thanks very much.
Please come up.
Lynn, Alan, Tracy,
We have time for about 15 minutes of questions and discussion. Anybody have a question? Yes, ma'am.
What the
fund the best treatments or just the things that kind of work but not necessarily perfectly? Like, should we be getting the best care available? I guess that's a larger question in healthcare. You know, I don't know the answer to that. I've been trying to just find ways to improve our outcomes, because our outcomes, in a sense, are so poor generally that we're always leaving over half the people behind in almost any of our most effective treatments. So I think they're pretty cheap treatments. Even our best ones are pretty cheap. So I more get up on my end. You know, when I was reading something the other day where someone called $157 for stopping smoking a lot of money. It was prohibitive, and it was like, huh? You know, it was in pregnant women or something. But anyway, so it's like, it gets kind of crazy what healthcare costs outside the addiction world and the mental health world. It's crazy. And then we have these treatments that you can do for well under, you know, $1,000 half the time, and they're, so I don't know the answer to the question, but that's how I feel about it. But someone else that thinks more about healthcare, like Lisa, might have a better answer.
So I don't know that the question has to be a comparison of are we paying for clinicians or are we paying for technology. I think it's, yeah, okay. Well, I think that one of the issues, and we chatted about it earlier, Bob brought it up in the very beginning, is that we don't have enough service capacity. We don't have enough clinicians to offer this. And so these are just really just tools, right, that can enhance reach and service capacity. And I think in terms of reimbursement models, what we've been seeing is that for many years before ACA, before the Affordable Care Act, there was a lot of discussion at the Center for Medicaid and Medicare around should we activate reimbursement codes for these self-management tools or for specific apps. So telemedicine was reimbursed in a lot of states, but these other types of tools were not. And that discussion has really gone away now, we've seen, with the Affordable Care Act, because in a lot of these sort of capitated reimbursement models, the idea is you spend a fixed number of dollars to take care of someone's health, right? And so if that means investment in these types of technologies, that's an upfront cost, but the savings you could realize from that investment could be tremendous if they actually work and make a difference. So a lot of the discussion has shifted to that. So you could include a combination of different types of interventions, which surely could include, you know, more traditional models as well, but these can sort of enhance that within these reimbursement structures we're seeing.
Other questions? Over and, okay.
So the questions for people on the internet are whether the smoking website is available publicly, is it available in community mental health centers, is it available in addiction treatment centers, and I can't remember what the last one was. Right now, we're using it across New Hampshire in a community mental health Medicaid-funded project that's an incentive program for health behavior change. So it's available to Medicaid recipients across New Hampshire. We're testing it in several other mental health centers in this randomized controlled trial. I'm really interested in piloting it in clinics that want to try it. So, you know, if you know of a clinic that's interested, let me know. I'm really wanting to think about models for how can clinics use these kinds of tools, integrate it into their workflow, benefit from it. I think we just have a lot to learn about that right now. We don't know a whole lot about that yet. So come find me if you know of somebody who wants to try it.
Go ahead.
I have a question.
Yeah.
One of the priorities, I think, in this state and probably across the country is integration of treatment services with primary care. So I'm wondering if each of you can think about ways that your technologies could be integrated into general healthcare systems to help people with substance use disorders. I saw, Tracy, that yours would be really excellent if screening were done and somebody was identified with high-risk alcohol use, that perhaps then they could ask a counselor to do a motivational call. That was one thing that came up, but I wanted to think about the other technologies and how can they help expand capacity through general healthcare systems.
A program like mine is pretty straightforward. The quote support staff in a primary care office, a nice nurse or whatever else you call the folks that are working, they're your therapist in a sense in the program that we've developed. So right now it's my research assistant who has no experience in this. He's just a nice guy that's helping you and answering your questions for you and sets you up on your computer and collects your urine sample and gets your incentives going. And so it's, you know, it's ideal for those kind of settings. And then if you need specialty care, you can access the therapist in specialty care as an add-on rather than as starting it from that angle and going the other direction. That's kind of how
Is it actually available now?
No. Well, no, mine isn't necessarily available. The TES system is getting close to production, I think. I don't know, at least might know.
How close?
But can people access it from the public? Oh, yes, and it's pretty similar kind of thing.
I'm thinking the program that I showed you is really designed to be used in connection with an expert clinician who, in the case of the programs I'm developing, would be a tobacco specialist, either in a mental health clinic, a primary care clinic, or an addiction clinic. The program can do the work of the evidence-based treatment, but what we found when we've implemented tools like this is that people still want you, the clinician. They really still want to touch base with a human being to help them navigate their path to recovery. They really like using technology-based tools, but in no way do most people, they still want the human being as well. So I see these in the future working in conjunction with treatment experts. I've tried to design my tool so that it can be facilitated by a non-expert who can at least know how to access the web and deal with streaming problems like I just had. But also in conjunction with a tobacco expert who is going to answer questions and help steer people where they need to go in the program and process it with them. Especially for people with cognitive impairments or disadvantaged populations, I think that's going to be needed. There may be a subgroup of people who can really do self-guided treatment or completely self-directed treatment and access this kind of thing on the web and completely do a recovery path on their own. I believe there's probably a large group of people who can do that. But there's also a large group of people, I think, we're going to want to use technology tools in conjunction with a clinician.
And those are probably the people who are already in the treatment system, but we always have to keep in mind the great majority of people are not in the treatment system and probably don't want to be. It seems like to me one of the consequences of the technology revolution is that it's going to move things increasingly in the direction of people taking control of their own health care, and I believe these tools will be sold outside of the health system, and there will be more and more people who feel like they want to direct their own health care. One question I have for all of you is, every longitudinal study following people for 10, 20 years or more of recovery shows that lots of the people in recovery have never gotten treatment but have had lots of involvement with AA and NA. And I'm wondering, which are wonderful resources in so many ways, I'm wondering how the technology tools have been developed and used in order to enhance people's connection with various self-help and peer support strategies.
So Bob, before we jump to that, I just wanted to add one additional follow-up point to Seddon's question. I think it's a really important topic that we should be discussing around how to, integrate addiction treatment, screening and interventions for addiction into primary care. And I think we're seeing growing demand for that, in part because of ACA and sort of integrated models. We have one national study we're doing now where we're embedding a technology-based system for addiction treatment into federally qualified health centers, and it's a multi-state sort of implementation. And the heavy focus is not just on patient outcomes, but on all the organizational factors that are important to consider, right? Not does it work with patients, which is an important question, but what impacts adoption? How does it fit into workflow? How does it fit into sort of reimbursement models? And how is it perceived by all the relevant stakeholders, right? Not just the payers, but the administrators, the clinicians, the patients, the systems in which they exist, et cetera. So there's a lot of research opportunity around that. And you asked specifically about New Hampshire, and we're very hopeful. We're in hopefully the final stages of planning a similar kind of project in New Hampshire and Vermont. And Sarah Lord will be talking later this afternoon about implementation research in this space and how do you promote adoption, sustained use, and bring value to systems and all the relevant stakeholders when you implement these types of tools. And so this project, if it launches, would start with a pretty involved sort of formative development phase of really understanding what are the barriers and facilitators to adoption in primary care, what would be the best models of adoption, and then to, based on that experience, actually do some demonstration projects in New Hampshire and or Vermont. So if folks here are in treatment systems in Vermont or New Hampshire and you have some interest in being part of that, please give us your contact info because we hope to launch this in the next month or so. It'd be terrific to have you involved. Yeah.
That's great. Why don't you also say something about how these tools might be used in conjunction with peer support, which we know is an important part of recovery.
I think these tools are ideal to be used in peer support in a setting where, there's peers around who know what you're going through and can help you use the program and talk it through and process it. I think it's really, technology-based tools are ideal to work in that setting. However, I'm not aware of any demonstration projects or actual studies where technology has been implemented in peer support. Sarah, do you know? Can you comment on that at all? No, I can't. Yeah.
There is a lot of AANA chat lines. You can do it online for quite a while now. You go online, you can get into a group and do your thing. Lisa, I remember we went at that conference where people talked a lot about developing social media, Facebook kind of tryouts, and I thought a few of them were.
Well, first of all, it's interesting, this question, because what we've seen in a lot of our projects with lots of different populations is that people want that. People want this. They value sort of personalized tools that can be relevant to their experience, but they also want some connection with a group like them, right? So we've seen this with, aging chronic pain patients. We've seen it with vets with trauma and substance use. We've seen it with children. We see it with lots of populations. There is some growing work that suggests that this could be really useful. One example that comes to mind is a colleague of ours, Dave Gustafson, who some of you probably know at the University of Wisconsin-Madison, has a mobile recovery support tool called HS. And it has a lot of features on it. It includes a lot of sensing. It includes a lot of input that individuals put in about their cravings and sort of when they're feeling at risk, they can sort of access in the moment interventions. It has features like the GPS in the phone will will notify someone when they're nearing a location where they used to use substances and a high-risk location for them, and help them strategize about how they won't be at risk for relapse in that context. But one of the features it has is this social support piece. So it connects you to a network of other people in recovery from substance use. And as I've understood it, he hasn't isolated that piece in terms of evaluating it, but he's gotten a lot of positive response from the users of that tool, that's a piece of it they really value.
Great. Kathy?
Yeah, I just wanted to travel back to what Lisa was saying about screening and brief intervention, SBIRT type of initiatives. At the addiction treatment program at Dartmouth, we're working now in conjunction with OB to roll out very small pilot of SBIRT in the OB clinics and are really interested. It's great to hear that Sarah may be presenting something to that effect, really interested in any kind of technological help. In terms of, we kind of built out our treatment aspect first, a perinatal addiction treatment program. So we built the T first, and now we're kind of working backwards to implement the screening and brief intervention in the OB clinics. And just with SBIRT, as part of the Affordable Health Care Act, I imagine that there's going to be, as treatment providers, we want to be working on the continuum, and we want to get out of our traditional treatment models and really see that screening and brief intervention going on in medical arenas and be a part of that initiative. And just curious what we can be expecting, if there's any brief intervention technologies. I'm a person that trains folks, but it would really be a lot more effective to have some computerized brief intervention models and things like that. So, didn't know if anyone wanted to comment on that.
So I would strongly encourage you to talk to Sarah Lord. I think she may have just stepped out for a minute. So she's done a lot of screening and brief intervention work with substance use in lots of different settings, mostly with young adults, but there's some really it's a growing area of research. There's some interesting work that has come out of Steve Ondersma's lab. We can connect you with him if that's of interest. He's done some really interesting work with postpartum and pregnant women and really trying to use that approach to help those women who are pregnant or just recently delivered who are involved in substance use to increase motivation to change that use. There's some work out of the VA at NYU with vets around this. There's examples of it, but Sarah Lord has done a lot of work in that, and she probably would be a great resource to you.
Great. Andrew, I think that the work you're doing is really critical because the availability of sensors and of phones with multiple capacities is going to streak way ahead of the slow scientific health care delivery process. I hope you're thinking about how these things might translate into helping people who have behavioral problems to modify their behavior. Could you tell us what's in the offing?
Well, first of all, it's great to be on this panel. I think I'm above my pay grade or below it being here. So, what interests me is, how can we, you brought this up, Bob, people who don't step into the healthcare system, how can we develop, technologies that may help them, whatever their situation is? I'm been fortunate enough to work in a project with Dror Benzi, who couldn't be here today. I think Rachel's going to chat about the project in the afternoon, so I won't steal her thunder. But we're working with a group of schizophrenic patients down at Long Island Hospital with the idea of actually taking this background technology on sensing that can automatically compute things like the things I discussed this morning, sleep duration, looking at sociability, looking at activity, and try to build models that can find trigger points in relapse and therefore then engage in intervention. So I'm really excited about this new Eureka project that Dror put together that we're working on over the next couple of years with 150 people down at that hospital. So for me, that's exciting because I'm very much interested in what Lisa brought up, which is we can develop these technologies that can, in an automated way, infer our behavior, but we all walk differently. We all talk differently. And so therefore, it's really important that these algorithms, computer scientists like myself and others are developing, can be personalized. Somehow, we put an application on the phone and it tunes itself to your specific environment, your context. And I think when we can do that, and there are many hard problems there, then we can think about developing really well-tuned automated interventions that could help somebody who's out in the community and not necessarily engaged in the healthcare system. I think that concept could radically change the way that people get help.
Great. Thank you. Other questions? And do we have a little more time? Okay, great.
7 more.
Other questions? Yeah, Don.
I don't have a question.
Oh.
I think the recovery community is really out there and doing a lot of things with folks that are maybe not in academia, but some of them are, and some of them are in books. And there are these one that's happening now where 20,000 people are involved. It's going on for a whole week. You know, the people that they present, questions are asked, and then people respond to that. And that seems like, you know, it's within the recovery community. And that's happening at this very moment.
Mm-hmm.
And in fact, it's the second wave of a week-long thing, because based on the first week, they, you know, months later, they said, whoa, we could get people's response to it. It was just like all automatic, you know. They made themselves, they created themselves and then put it out, and then what was really responsive, then they repeated it. And now more people, it's like 20,000 people around the world.
Online?
Yeah, online, but you can see it online. You can hear and talk to. So somehow they created, you know, this whole network that just is grown up.
Yeah, I think these what Don Wade has been talking about are all the online networks that have been created for peer support and education and help among people who have specific kinds of problems. And it does seem like to me that movement and the technology movement and the movement for people to take control of their own health care is going to change dramatically what happens in the healthcare sphere, and that those of us in healthcare need to be thinking about how to connect with and help all of those systems to work, rather than continue our narrow path of thinking about, okay, how can we improve the care for the 5% of people who come in and get evidence-based care? You know, it's the 95% who have no access to evidence-based care that we should be worried about, and hopefully that the NIH would worry about too, although we're far from that. Yes, ma'am.
I would just say in that light, I think it would be wise for the people who are developing these things to touch base with faces and voices of recovery at the national level.
Yeah.
That would be a good way to find out where there are sites or situations or web programs or whatever that could connect. Because that's really I would say the national model for reaching people across the whole spectrum of recovery, regardless of how they found it.
Mm-hmm. Great. Could everyone hear that? Yeah, okay. Any thoughts from our panelists about, any further thoughts about how we connect with this huge recovery community, and with, you know, part of that really made me think about Lynn's presentation. And, you know, we know a lot about which kids and which adolescents are vulnerable, and we do a very poor job of providing targeted prevention interventions for those people. And, you know, as the DNA and other tests evolve, you know, we're going to know way ahead of time people that are very, very vulnerable for these illnesses. Any thoughts about what should we be doing on either front? The recovery community or the pre-recovery community that's so vulnerable with technology? Okay.
Games. I think you connected that with Lynn a lot in her presentation on games, and that seems like such a low-hanging fruit.
Yeah.
Why are our games just fun? You can build merit and growth into games pretty easily. So I think that's an exciting opportunity. Good.
I think the other thing is that there are opportunities where people are just, you know, and I think this is one of the sort of powers of devices, especially mobile devices and technology, is that people are on them constantly, right? I mean, it's actually really sort of distressing, but you'll look around a restaurant and like literally everybody is on something, right? So it feels like, you know, instead of, and you know, a lot of the work I've done in addiction treatment and a lot of, you know, sort of all those conversations is that, you know, this has to be a discussion that's ongoing all the time during every part of life. It can't just sort of be when you come in and see your, you know, your treatment provider, or, you're in a group or you're in a meeting. I mean, it really has to like infiltrate every aspect of your life. So I think the point you're making about, kids, and I think in terms of the recovery community, I mean, it kind of has to just be there ever present all the time, so that with kids, let them play while they're sitting to wait, waiting to meet with a pediatrician, right? We all know pediatricians can make you wait a long time. Kids can be playing games that can like accomplish something. In recovery, I mean, it doesn't have to be at that, that discussion in the treatment center. It can be happening all the time, like 24/7. And I think it actually could be in a very effective way of sort of continuing that discussion, not in substitution of a therapist or a treatment provider, but in addition and more, more ongoing. So
I think it's lunchtime.
Okay.
Okay.
So we'll take a break for lunch, and when
Yep.
do you want everyone back?
1:15 is when we're starting again.
1:15.
I hope that, first of all, thank you all for wonderful presentations this morning. Really terrific. And I'm hoping we weren't able to set up tables with toys to play with, but I'm hoping that those of you who have technologies, Lynn and Mary, maybe Alan, Lisa, I don't know, but can, if people want to see their technologies, maybe they can use their own computers or iPads to show you after they've eaten. So towards the end of lunch, if you want to pester people. Yeah, I'm going to.
Great job. Thanks again. got sick. Yeah, she was feeling terrible. So I probably won't, depending on how she's doing. And I'm definitely going to go to that meeting with Alan. I think that's I think so. Okay. I couldn't either. Oh. And the reason I couldn't do it Tuesday is because I'm not going to have a meeting. I thought it was a meeting. Oh. But anyway, can you do Elizabeth? Is it so I'll just write him back and say, please send it back? I can on Monday. Monday, fine. Yeah. I'll write back and say, I'll talk to you. Let me just check, but I'm pretty sure I remember that. Oh. Oh, it's such a pleasure to be here. I wish I could be here this afternoon. Oh, my pleasure. We should all thank you for putting this together. You know, it's almost like we should do this every year and have it be a big deal, a Dartmouth thing. Yeah. We should have an annual meeting on technology and behavioral health, and yeah, Dartmouth, and invite top people to brainstorm. Okay. Sorry. Hello. Friday. So our administrative meeting got canceled. Yeah. So I have down that you and I are talking to Larry, but that got canceled too. Yeah. So I'm fine all Monday morning. Okay. So I'll write back and suggest that you can join. Basically, they want us to talk to the folks at Cambridge. I wonder if I should see Jack and do it. Yeah. Okay. Yeah. I don't know that we need the whole case. No. Maybe just use Jack. I'll talk to you about this. Okay. Yeah. Thank you. Thank you. She was so stupid yesterday to come into work twice. I couldn't. She didn't listen to me at all. She was stubborn. Yeah. Okay. I hope. Yeah. Yeah. I'm going to try to push ahead. Yeah. Nice to see you. Oh, I didn't know you were here. Oh yeah. I mean, I knew you were speaking this afternoon, but I didn't see you. Oh, good. Great. Yeah, it's been really good so far. Yeah, table full. Yeah, we're going to try to roll out more things at Westford. Yeah. That's great. Yeah, that's great. My wife is homesick, so I'm going to walk home. Only a little mile from here, see how she's doing, and then maybe we'll come back. Yeah. Oh, I like that. I thought the morning was very exciting. There are lots of good things going on there. And, is one of the best. The computer science guy was just saying they just hired a new guy on machine learning, and they're hoping to recruit another one. It'll all be part of how this stuff works. Yeah. So you better get home. Yeah. Okay. Nice to see you, though. Okay. Hopefully I'll be back shortly. We got to do this every year at Dartmouth. Yeah. Do you know Seven Savage? She's somebody you should meet. Seven, this is Jeff Schumann Olivier. Nice to meet you. Yeah. I started to say Dror. That was why I looked at you. I started to say Dror Benzel. They both have Zels in their name. Yeah.
It means he's my son. That's what his name means. His name means that he's my son. Oh, does it? His son is
Yeah.
Benzel.
Yeah.
Oh, Benzel?
Yeah, sure.
Son of Seth.
So, Seddon's the head of the DCare program here at
and draws together a lot of these neat things. Well, you're not going to be small. You know, you should put this conference on in a big way and make some big bucks for yourself.
We never took money, I just don't care. You should not even charge for this, we decided to charge for the process.
Okay.
You tell me how to do it, I'll do it.
Okay, well,
We do a conference every spring, and we play.
yeah. You see.
They're always content.
Yeah. Well, this is really good. I'm so
Yeah,
glad
no, it's
we
great.
all appreciate it.
Thank you. I didn't test the video streaming. They have no
program at Yale ever? That's the in-home health services for the disadvantaged.
No. ICACS?
Yeah.
No.
It's a Yale program that goes into the homes of kids that need extra mental health, people with advanced kids and stuff. So we work with them a lot.
Is it run through ADS?
It's run through the mental health department.
Okay.
The Department of Psychiatry.
ICACS. I'll look at
ICAPS, ICAPS.
Yeah.
And it's good to know about. Okay. Thank you. They do a lot of work.
To bring kids specific needs in, or just
Yeah, basically it's kids that look like they've either been in the hospital, they're close to hospitalization or crisis, and it's in-home services to prevent hospitalization and emergency room use.
and for sort of medical conditions as well as things like, I consider substance use medical, but I mean, is it more just sort of medical? It is mental health. Huh. And what's the age range of the kids?
You know, that's a good question. I think it's all the way from 4 to 18.
Really?
Age 18 years.
Huh. Part of the child study program.
Yes, yeah.
Interesting. Oh no, I'll have to look at it. The populations we've been working with in my project, which is, obviously ambulatory, after school programs. I mean, those kids are sort of, it's a range, but, a lot of them are dealing with some pretty serious, mental health, substance use, domestic violence, suicide. We collect a lot of data on violence. It's really scary. Just to see what their exposure is.
I met your mayor last week.
The new mayor?
Yeah, I just started this job. I'm from New Hampshire.
Oh, really?
I still own a home in Exeter, New
Oh.
Hampshire. And I'm going down there after this meeting. There was the Governor's Council on peer support. She's very big.
Well, she's a big, one of her huge priority areas is like youth violence and services for kids in, difficult households.
One of the first things I learned when I got to Connecticut was how much she's missed in the legislature. She was walking encyclopedia of a lot of the culture and history and accomplishments.
Yeah. Oh, yeah. And hopefully that'll translate to city government. I think the city could definitely use that.
I think it can't hurt.
Right. Exactly.
Anyway, I don't want to interrupt you.
Yeah.
I just wanted to say hello. Yeah.
Thank you. And I'll look at ICAP. That's great. A project in Connecticut is ICAP, which basically goes into sort of homes of disadvantaged youth and provides services like linkage to care. And years now, he was from New Hampshire, and now he's moved down to Connecticut.
You gave such a nice talk. I really enjoyed it. I haven't seen all of the latest results that you talked about. When you came to CTPH, you talked a lot about the development process, which was so exciting.
Right.
And you had some results, but you have a lot more.
I know. I was trying to think, I was like, I wonder how far along I was when I gave that talk. And then it's like, like all of a sudden now we're like basically done enrolling.
I know.
We've got,
I know, it was great. It's really exciting.
No, it is. I mean, we had a team meeting last week, and one of my biostatisticians was here, because our goal is 330, and we're up to 325. I know, and she was like, this is such a good study. I'm like, isn't it nice? Like in 14 months we enrolled like 330 kids.
That's neat.
That is a nice
That's
study.
neat. You can excite your biostatisticians
Oh,
about
I
it.
know, right?
That's terrific. How did you recruit so fast?
We just clamor.
Yeah.
I mean, like we basically have we do these waves of recruitment. So we sort of have like our fall wave, our winter wave, and then spring was longer, so we had like spring 1 and spring 2. And literally, spring 1 was like 80 kids. It's just like they just, wow, yeah, they just all want to play. So
that's great.
That is great. It's great. It's really nice. I feel like voluntarily. So, yeah, so why not use it? You know?
Exactly. You know, there's a researcher here. You know Madeline Carroll? She had the Hood Center, where she and another researcher that works with her just got a grant from NIH to use a kids' television show to teach skills. It's not interactive, I'm saying. To teach skills about eating behavior in little kids. Do you know this animated series called Peep? Peep in the Big Wide World? It's like this duck. It's very simple animation. It's very funny dialogue, my kids and it. But it's about science. It's all about science. So the producer of Peep has agreed to work with this research team to create episodes that focus on understanding more about eating and childhood, you know, they all really said childhood obesity and activity levels and such. So they're going to evaluate it in a study. I would love to introduce you guys at some point because I don't think she came to your talk when you were here.
And it's the idea of just, you know, kind of taking them where they are and just doing what you want them to be exposed to in that setting, as opposed to like, you know, just the amount of sort of energy it takes to get people to come and do something like when, you know, one, they may not really want to do it, and two, they really don't want to come and do it. Like, actually move to get there.
Right. So give them something they'll engage them. Yeah, it's exciting to see what you're doing. So how did the pilot go with the? I know you've got a version that sounds like this was largely developed. That's true. The tobacco and
So,
alcohol, right?
tobacco and marijuana.
That's right.
So,
That's right. I remember.
so far, we sort of put together kind of like literally a very, we've done like 2 focus groups, literally just with kids about, you know, sort of attitudes, ideas, sort of, you know, their perceptions of smoking, just to sort of start collecting that data. And then we've been working and actually trying to get, you know, sort of an app, we're sort of targeting an Android phone, an app on the Android that will be far enough along that we can then take it to kids, and then they can start giving feedback on just that. But we, you know, it's a similar process. We just sort of drafted pages and pages of spreadsheets with, you know, with data, you know, it's just, but it really felt like we needed to sort of start getting something in their hands so that we could simultaneously sort of have them give us feedback about the functionality as well as speaking about the content.
That's great.
Yeah. Well,
That's great. Thank you for suggesting that this meeting. This is all. She's responsible for creating all of this.
you're responsible for all the speakers. It came out great. It's a great mix. It's really an interesting.
And I think exactly. Look, it's really people are communicators, and that's one of the things I was going to talk to you about. The state of New Hampshire is gearing up for all these new Medicaid expansion. I think all states are Medicaid in particular. Now that there's a parity step paper,
technologist at Dartmouth Health Service, working. My primary role is just regular therapeutic intervention, but then secondary role, which keeps getting bigger, is
The billing issue.
I see all the
They
mandated
can't bill for it,
patients
and the reason
for
is because
high-risk
federal
drinking.
CMS does not
So,
create any
but
reimbursement for any.
questions abound about how you started your path to creating a technology. Like, I don't know if you were a tech-based person before,
Still I'm not.
and I feel the same way, but I've always been interested in implementation of it into the therapeutic practice. So, you know, here you are with this sweet game.
Yeah, and and I think sometimes they're on block grants. I think it's sort of alluded to it is the team.
Yeah, right, yeah.
Like, so I mean, you kind of end up realizing that, particularly the increased service capacity, to a lot of things, but I have a very specific skill system. Like, I know what I'm good at. One of the things I'm really good at is like organizing and coding tasks.
Sure.
So as long as I put together all the brains that I need in all these different areas, I believe I can be successful because I can coordinate them. And that's really kind of the approach I took. I mean, that's why really the first like 6 to 8 months was just.
Is it funded by grant?
Oh yeah, so this is a large NIH grant.
Okay.
When I got funding, I sort of had to be like, sort of, I sort of created a team, but it wasn't really clear that it was exactly the team that would do this. And so the next step was really taking like 6 to 8 months and just talking to everyone and finding out like, who's a good person for this, who's a good person, who does this kind of work, who'd be interested in, and really putting
Which
together.
is nice when you're in a community like Yale, a community like Dartmouth. I mean, people local to me have skill sets I don't have, but may be interested in what I would really love to implement.
And it's really, and that part of it is actually really interesting because, they're kind of people you never really meet otherwise, and you never really necessarily have anything to work with them on, but in this setting it was like, and some of them, a lot of this wasn't a team, like some of it, like, Yale does not have a 50-50 percent, so don't tell them, but, so, I had to go outside of it, and the game developer, we hired a game developer who is a commercial game developer, and so managed the start, and they're affiliated with Carnegie Mellon, and they do commercial games, that's what they do, and we went through a whole process of getting proposals from game developers all over the country, and it was sort of
I texted my sister about your game. I said she's a community resource officer for all the high schools in Carson City, Nevada.
Oh, wow.
And I was like, she could totally implement this game with students and be like, hey, play this, because she's already seen firsthand the beginning of the risk.
Oh yeah.
But yeah.
No, and it's always been our target audience is 11 to 14 years old. We don't screen. We have the power to study for discussion. We wouldn't have to screen kids thinking about what the risk behaviors were. We basically think just enroll as long as they're in the age range and willing to play the game and all that. So one of the girls we enrolled, she was 12 years old. Turns out she was like, at the time we enrolled, she was like 7 months pregnant.
Oh wow.
And it was just like, oh my god. This is why we're doing this. So it's all worth it.
But I like that idea of the team.
Absolutely.
What was it like? I've never written a grant, but I'm interested now. What's it like to write a grant? The process to go about doing it.
It sort of depends on the focus of, again, with this grant. A big part of it was, since it was it had to be so multidisciplinary, a lot of it was really, kind of providing the
I know.
description of the team, who the team members were, what they,
I guess I have written a grant once for my dissertation, which wasn't published, but it was still a little grant.
You gotta start somewhere.
Lisa, I'm Adam. I'm one of the clinicians, the psychologists at Dick's House on campus, and I also see all the mandated students after so many violations of substance use on campus.
You're so busy.
So I do, and then when I can't see them all the other clinicians see them and they don't like it. But
These are college students?
yeah. But I'm listening to your presentation, Lynn's presentation, Andrew's presentation made me think about how to get those students something that they use technology-wise while drinking that utilizes his behavioral technologies with immediate feedback during drinking behaviors to reduce risk in the moment, and even could reduce risks such as sexual assaults that come from that if they add in things like, so for Andrew's data, right, what are my safe locations? Where's my home? When I'm not in my home, it's going to send a text message at a certain time. Why aren't you at home? Like monitoring drinks and stuff, but just an idea, and I don't even know if that's out there. Yeah, disrupting the drinking too.
Raise awareness of things they're not doing.
Yeah.
It's an interesting idea. I don't know anything like that. In addition to the patient Sarah Moore is sitting right here. She's done a lot of intervention research with technology through college students and young
Is
adults.
Sarah part of your team?
Yeah.
Okay.
She'll talk later about it. She's
Cool.
going to talk about that.
Yeah.
She's going to talk about implementation.
Well,
but she's really interested in all those things. Now she's been talking about trying to take this into the field with Dartmouth.
I may pop up into your guys' email boxes here very soon to suggest this, because I think it would be really fun to implement and see where we could go with it. And important. Yeah, yeah.
There's another thing that's great. So I watch Shark Tank. You guys know Shark Tank? Taking this like addicted to Shark Tank. Shark Tank is basically these very, very wealthy Disney entrepreneurs come in and present their ideas, and then if the businessmen think it's a good idea, they'll like potentially give them money to build the idea. This one guy came in, I'll look it up, but it's basically a phone app. It's a breathalyzer.
Right.
And it's like, literally, he got funding from Shark Tank, and it just took off. Like, it's now, the company's worth like $10, $15 million or something. And that would be something that would really to think about as part of sort of a multi-faceted intervention with GPS, with a mobile app for breathalyzing. Part of it is just my sister-in-law is now potentially working with Dartmouth on these investigations into the sexual assault.
Oh, really?
Yeah, and it's like, you hear it, and there's so much gray zone. The minute you introduce everyone being intoxicated, I mean, I listen to the stories, I'm like, I couldn't tell you what happened. I mean, it's really, and so you only think about it, if kids can have that kind of feedback, as they're leaving one party and going to the next, and breathalyze and immediately get feedback that like, wow, you were getting so close to being out of control. Just another idea to sort of think about how it is with that kind of intervention.
And staying safe. Just stay there, stay safe. Don't go somewhere.
Right. You're ready to, tips or whatever. Don't, you guys stop me.
So this is Sarah.
Hi, Sarah. Nice to meet you. Adam Dickey from Dick's House. One of the psychologists there. Good.
Sitting with Gene Brown.
Oh, yeah.
So he was
But just kind of ideas about implementing some kind of in-the-moment app for the students to manage, reduce, monitor.
Good afternoon, everyone. I think we'll get started. It was a great morning, and I am looking forward to this afternoon. We should have plenty of time for discussion at the end of the day. So like this morning, we'll have speakers who will probably fill their time, and then we'll move on and then bring everybody up for some more discussion at the end of the day. A couple of housekeeping things again. CEUs and CMEs, I got those straightened out. CEUs, if you want for LATEX and others who can use those, there are 2 forms that you have to fill out and turn in before you leave today. If you're looking for CMEs, there is 1 form you need to fill out and then an instruction sheet about going online and doing some follow-up work after the meeting. One comment for speakers, there were a lot of acronyms this morning that many of us knew, but there were some that stumped people who aren't directly in the field. They're probably obvious to many of you. What's an EMA? What? Ecologic. Oh, good. Okay, we're going to hear about it in a minute. So, okay, and interestingly, CM was another one. I know that that's contingency management, and I know it means paying people or otherwise reimbursing them, but a lot of people didn't. So, once upon a time when I was leading an organization, I made people put money in a pot every time they used an acronym without, without explaining it, and we made lots of money. So please explain your acronyms. And finally, I just wanted to say a big thank you. Ellen Henderson at the back of the room did all the organizing of this and did a fabulous job. So thank you, Ellen, very much. Yes, and Susan Wells as well has helped with this. And I also wanted to say a thank you, though the provost is not here. I need to thank the provost for many years of support for DCare that's really allowed us to bring people together time and time again. And I hope it's resulted in good networking and some synergy that's moved people into new places. So, with that, it is my pleasure to introduce Dr. Mark McGovern. Many of you know Mark. He will be moderating this afternoon's session. It's really particularly exciting for me because it was 10 years ago this month, 2004, that I came to the first Dartmouth Symposium on Substance Use. Mark was the first director of the Dartmouth Center on Addiction Recovery and Education and convened the first symposium on substance use to bring people together. So I remember that well, and it was a great start. So thank you, Mark. Mark is a psychologist and a researcher in the field of evidence-based treatment for co-occurring disorders. He is a researcher. He's also active in clinical care. He's probably known, perhaps indirectly to many of you here, as being the lead developer of a series of organizational measures that assesses the capacity of organizations to do dual diagnosis treatment. These are used widely across the United States, and I suspect some of your clinics have assessed yourselves using the tools. The DDCAT, which is the dual diagnosis, help me, Mark, capability in addiction treatment, and a similar one for mental health and dual diagnosis, and for dual diagnosis in healthcare settings as well. Very valuable tools that I think have improved quality of care. Excuse my glasses. His clinical research has focused on translating evidence-based treatments for co-occurring disorders into clinical settings. He's been funded by NIDA, R01 NIH funds, and a variety of other sources, Robert Wood Johnson and others. He's also the editor-in-chief of the Journal of Substance Abuse Treatment, which I'm sure you know is a very respected journal, really leading science and research in the field of addiction treatment, and he's held that position for 5 years. Mark has always been a great support to DCare, though he left many, many years ago. He serves on our executive committee, and he is always a source of really focused and good ideas and support to our work. So, welcome, Mark, and thank you for moderating this afternoon.
Good afternoon, everyone. It was 10 years ago, actually. It was May 21st, 2004, that we held the first Dartmouth Symposium on substance use. And I think our goal was to address the culture of substance use here at Dartmouth and in the community. So I guess we can check that off. We did that. No need for the president to convene a panel of any kind. But I was also remembering that the plenary for that session was delivered by someone referenced earlier in Dr. Burnett's talk, C. Everett Koop. And for those of you that don't know, C. Everett Koop was a Dartmouth College man, graduated in 1937. And when he presented at the plenary, he told the story that this room was actually the dining hall for all the students at that point. And I don't know if this is a great story, but he said that they had the practice of tossing their forks while they were at the dining table up to the ceiling and to see if the fork would stick in the ceiling. And some of them would, and they'd slowly fall down on the unsuspecting other diners. So that's what used to go on in this very sacred room by our former Surgeon General, who was And I think that side of him actually helped him in his future work challenging the tobacco industry, challenging the authority of tobacco industry and really public health at the time. And I think we are all the beneficiaries of that. I'm an old enough fellow to think about technology with some suspicion, even though I think Lynn talked this morning about how everyone is on their smartphones pretty compulsively, and I certainly would fall into that category. But one of the things that I've often heard people say is that addiction is a process of increasing isolation, and recovery is a process of increasing connection. So, isolation, connection. So I think as I listen to the speakers who are going to be presenting this afternoon, I would hope that they would address that kind of dynamic. To what extent will technology foster a connection, or will it kind of perpetuate isolation and avoidance? So I think that's a really critical dynamic. And of course, as audience, you draw your own conclusions. I think our first presenter, I left my batting lineup over there, but I believe our first presenter is Rachel Bryan, who's a Master's in Public Health Project Coordinator for the Dartmouth CTBH, the Center for Technology and Behavioral Health. She's relatively new, right? Not even a year yet. So she works with Dror Ben-Zev. Dror's picture's here. It's going to be projected up there shortly. Dror is a really good friend in that he's now in Israel supporting a friend of his who has a very sick child. Rachel comes from the Midwest, comes to us from the Midwest, University of Michigan, Michigan State University. In my understanding of her work, she's demonstrated a clear commitment to the disadvantaged, the poor, sexual minorities, people with serious mental illness, pretty much the Ellis Island of healthcare. She's going to talk about FOCUS, which is an acronym that I don't know where to put the money. I guess it's an acronym. It's not an acronym. Okay, so I'm not being penalized. Okay, good. I don't have to sit in that chair over there. I've been wondering who sits in that chair. It's a gestalt kind of thing. So FOCUS is a smartphone application to help people with serious mental illness learn to take care of themselves better. And I think we're interested in how it might work with people with mental illness and substance use disorders, which would be a kind of a new or offline, off-label application for it. So Rachel, we're glad you're here. The other thing that's really important to know is that Rachel found out that she would be doing this presentation on Tuesday? Wednesday, okay, so thank you for showing up.
Thank you, Mark, for the warm welcome. What a good-looking crowd we have out here. Like Mark said, I'm presenting instead of Dror, and I'm wondering if maybe we could take a picture of the crowd for him. If you don't mind waving. It's an old phone. Hold on. All right. Hi, Dror. Excellent. Thank you. So I am going to talk a little bit about FOCUS. It's our smartphone application that's housed directly on the smartphone. Talk a little bit about its development, and then possibly modifying an application like this for use with substance abuse treatment. So the world is going mobile. We can see that there have been incredible growth rates with mobile phone adoption among the developed world developing countries, as well as developed countries. And it's just a trend that's going to continue. But do people with schizophrenia use mobile phones? We will answer that in a second. So a little bit about the development of focus. It was a 3-stage development process. Started with a needs assessment, continued with intervention development, and then usability testing. Let's see. So as part of the stage 1, the needs assessment, this was conducted with 904 participants based out of Chicago. 63% of this group owned a mobile device. 58% used the device daily. So yes, people with schizophrenia do use mobile phones and own mobile phones. And there was an expressed interest in using mobile devices for mobile health services. Also part of the needs assessment was a group, conversation that was conducted with practitioners. There were 8 practitioners in this group, also based out of Chicago, and just trying to assess what they think, the mobile device adoption, what people with schizophrenia would use it, if they would use it, if they would have difficulties using it. And there were kind of mixed results. There were 6 out of 8 who believed that people with schizophrenia would be more than able to use a device. However, there were 6 out of 8 that felt that they would have difficulty using the mobile device. So there's a little confusion. 5 people said that they thought that they would sell the device, which has not yet happened throughout all the studies. 2 said that they would more than likely break the device, and 1 said it would have an iatrogenic effect, so that the device itself would cause illness expression. The 5 treatment areas that they decided upon that were most pertinent to people with schizophrenia was medication use, social functioning, mood, sleep, and psychotic symptoms. So as part of stage 2, there was the conceptual framework was established, so using the stress vulnerability model, and then also the cognitive model of psychosis. And then they decided on what device to use. Should we use pagers? Super cool. PDAs, which are a lot like smartphones, but they don't have the interactivity, they don't have the connectivity to be able to upload information. So there are certain barriers there that you have to download and connect the device in order to get the information. Should we use basic phones? They're cheap, they're readily available. We could use text messaging, but people with schizophrenia might have issues with receiving text messages and sending text messages, and that this is kind of extra burden that might be too much. So in the end, the smartphone, a device that has a lot of possibilities, as we've seen from Andrew's presentation. It was decided that this would be a great device to use. It's able to send the data directly once it has connectivity, and that was what was decided upon. It's important to have consideration of design when developing programs for people with schizophrenia. Rotondi has looked at this with web-based web pages, websites with people with schizophrenia to make sure that design elements are clear, clean, and straightforward. These are several kind of considerations that need to be taken when designing or developing whether that's web-based or mobile-based applications for people with schizophrenia, to make sure that minimal steps are necessary. Mary talked a little bit about this, having a clean design, that people are not getting lost in the navigation. So these were all taken into consideration with the development of focus. So stage 3, once the program was developed, we conducted a usability test, 2 stages. this was conducted using 2 research facilitators, one that administered the Think Aloud, which is basically sitting down with a participant, having them go through the program or on the device and to talk out loud what they're thinking, what they're doing, if something's confusing. And this kind of gives better insight into, in the moment, what's happening. So this was done in kind of 2 stages. We did it again with 1 participant. These were 2-hour-long sessions. We did it with 7 people, and there was a lot of feedback that was very helpful. The program was modified based on the feedback received. And by the second cycle, a lot of the issues that were presenting themselves in the first cycle were reduced greatly. So these are some of the feedback points that were, I guess, that were brought up during these usability, in-lab usability tests. And as a result, the several modifications at the bottom of the page were made. One thing that I found particularly interesting was, people didn't understand meds. When we use the term meds, that was not interchangeable for folks. That meant medication. So using, longer terms, not using abbreviations. The touch screen sensitivity was also something that was modified based on this usability phase. So let's talk a little bit about focus. What does this application look like? Well, focus can be prompted one of 2 ways. It can be system prompted. This is set up on an automated, timing where the system will check in with people. You can see on the left, they have the option to respond. It says, can you check with focus right now? They can respond yes or no based on, what they want. And then you can see on the right that it can be participant launched. So this can be launched by the participant. They can go in, they can check out the application, and this is the first screen that they'll see. So let's see. In this instance, we'll check that voices are bothering us. So next comes a clinical assessment. So basically, how intense are the symptoms right now? Everything, again, these are considerations that Rotondi brought up. We created the program at a 6th grade reading level, used simple geometry, it had low working memory. So if they expressed not at all, they would receive a sign-off, something like, thank you for checking in with focus. If you need us, come back, check in again. If they expressed a little to extremely, then they would receive the following content. Well, let's say we are moderately bothered by our voices. The system then gives encouragement. It says the focus system can give you some suggestions. Let's move to the next screen and try some helpful tips. This can be used 24/7, anytime that the symptoms present themselves. This could be 2 a.m., whatever. And next, there's a problem assessment. So this is looking at, I guess, their beliefs about their voices. These are based on common dysfunctional beliefs. The question and then the responses vary. So we will have, different wording, but it's assessing basically the same construct so that it doesn't get repetitive, that they're being asked the same questions every time. In this case, let's just say that our voices are all knowing. So then the cognitive intervention, the intervention is then displayed. The images, we have a huge library of images that we use. And then this piece also is worded differently. We have different groupings, but again, it's assessing the same tailoring points, the same constructs. But they have different, of course, pieces, health management strategies. In this case, it says, voices may sound like they know everything, but they don't. Can you think of a time where voices made a mistake? How about when voices were sure something would happen, but it didn't? So what Focus also is able to do, so all this data that's going, respondents are not able to see a dashboard. They don't see, how their responses have been. There's no tracking or anything that's directly accessible on the device. But participants can allow their practitioners or their clinicians to view their responses or view, their program activity on a dashboard that then the clinician can log into, look at it, and they can incorporate this into their care. Focus then, we conducted a 30-day trial, again based out of Chicago, with 33 participants. We gave participants the phones to use plus the application. The results were amazing. I mean, we had people respond to Focus. They used Focus 86.5% of the days that they had it. The first week to the last week, there was very little tapering. They used it the majority of the days of the week, and 5 times a day towards the last week, and it was user prompted over half of the time. So they were using this on their own. So after the 30-day trial, we also did a usability, we assessed usability, and again, the results were wonderful. We had people, they felt that the system was easy to use. They would recommend it to a friend. They were confident while using the program. And you can see the PANS was assessed. So there were reductions in the PANS, both the positive scale and psychopathology, and then as well as depression, pre-post. And they were all statistically significant. Another study that was conducted by Dror before Focus, doesn't have anything to do with Focus, this was done a while ago in California. He conducted basically this 7-day EMA, which is Ecological Momentary Assessments. EMAs are essentially frequent questionnaires that are given at typically timing that it's associated with times throughout the day. And what this does is it gives you a real-time understanding of what's happening. This is a wonderful tool to use to measure, pre and post substance use. What's happening to people's moods, psychotic symptoms, before actual substance use, and what's happening after substance use, the substances have been used. So out of this study, one of the inclusion criteria was not that they use substances. This was just for people with schizophrenia or schizoaffective disorder. almost 27% reported a lifetime substance use disorder. Out of the 2,737 valid observations for that 7-day period, 189 substance use reports were observed. And about 14% of the time, this involved more than one substance. It's interesting to know. Several of the predictors varied based on substances that were used. They kind of broke this up into 3 groups: alcohol, cannabis, and then other illicit substances. So this included cocaine and meth and other non-prescribed drugs. And what they found were there were some differences between, what motivated and what were predictors for substance use based on the substance that was used. And we can also see some common overlap. And not only overlap between the substances, but overlap with just treatment of schizophrenia in general. Here we have mood, we have sadness, we have anxiety, we have psychotic symptoms. These are all things that are currently actually in the Focus system. So how could a system like Focus be adapted or used, modified to look and treat substance use disorders? We could have a participant-launched system, very similar to what was constructed for the original design of Focus. But we might have a system prompt, maybe not. There was a study conducted by Friedman looking at homeless cocaine and heroin users. They had a sample size of 30. All they did was just the EMAs, just these questionnaires, No sort of feedback, nothing else. It was just the questionnaires. And it was 10 out of 30 expressed that just by answering the questions alone, that they were more aware of the feelings they had before they used and after they used, and that helped with their decision on whether to abstain or not. 2, however, out of the 30 expressed that maybe having a system prompt might be triggering, especially for those either early in their recovery or not really solid in their recovery. So the use of system prompts, needs to be looked at. Maybe it's a tailoring point that somewhere along, the clinician can then say, okay, this person's ready for the system prompt, or after a period of time, the system then can prompt respondents. But that's certainly a consideration that needs to, be thought about. Let's select cravings. So craving intensity, we go through, again, similar to how the system's already constructed. How intense are your cravings right now? Let's say they're moderately intense. So again, the system can provide encouragement and prompt to continue. They can use it 24/7 when the cravings are most intense. And then assess the reasons to use. So this would help influence what a content would then fire. So reduce cravings, dealing with symptoms from my illness, and emotions. And for this case, let's pick I'm sad. So then an added, layer that could be added is what type of strategy they would like to receive. Would they like a relaxation video? So they have some control over what treatment is most pertinent or most effective for themselves. So whether that's a relaxation video, a craving coach, kind of giving that motivational, inspirational piece, advice from someone like me, so getting a peer support, whether that's a video or text from peers who have gone through this, or that they need to talk to somebody, and this could directly link with their clinician or with some other resource where they're able to talk over the phone or FaceTime or get services right then and there. For this case, let's pick craving coach. So here's one example. This is a GIF that I found online of a coach, I guess. This could be tailored if you wanted to, based on whatever demographic variable you want to tailor on. I would caution about the tailoring of images to a certain extent because not everybody resonates with the images that are selected. There are different subgroups of people. White woman in their 30s, they're not all the same. So, I think tailoring of images should be used wisely. So here's an example of content that could be displayed. You may not be feeling hopeful right now, but you know what? That's okay. You can feel one way today and another way tomorrow. Keep in mind, this feeling will pass and you will have better days. Keep your chin up. You got this, champ. So again, a coach, it could be a female, it could be whatever image you want. You don't necessarily have to have a face to the program. This could just be a pretty image if you wanted to. Again, on the back end, clinicians could have a dashboard that they could go to and see how the cravings have been. This is, again, if they respond to this system frequently, you'll get a pretty accurate assessment of their real-time cravings and how they're feeling. This, of course, reduces the bias of retrospective reports of how have you been feeling this week? Okay. So in summary, people with schizophrenia use mobile phones. Many want mobile interventions focused on health and mental health. Mobile health approaches need to absolutely take into consideration the needs of their end users. This is their cognitive ability. This is, so many different variables that need to be considered, and that's with any target population. Focus has been acceptable, usable, and engaging, and it provides promising clinical utility that could easily be translated into substance abuse treatment. we want to send out a thank you to all these fine folks who have contributed to developing Focus. My email's at the bottom, but more importantly, Drawer's email is on the bottom. So if you have any questions, that's how you can contact us. Thank you.
Thanks, Rachel. Our next presenter is Dr. Zev Schumann-Olivier. He's on the faculty of Dartmouth and Harvard. He'll have to tell us how he pulls that off. He's also the medical director of Westbridge Community Services in Cambridge. Zev is an addiction psychiatrist with a background in engineering and meditation and mindfulness, so he's a pretty complicated guy, I would say. How he pulls that together, we'll be hearing, I suppose. He's going to talk about integrated mobile platforms to support and monitor medication adherence in buprenorphine treatment. Buprenorphine, as many of you know, is a FDA-approved medication for opioid use disorders. It's effective. It's not widely available, but holds a lot of promise for the care of people with opioid use disorders. However, I think if all of us were to walk down Main Street to the Hanover Police Department and ask them what they thought of buprenorphine, well, they would probably first say, what's buprenorphine? But we would say, well, it's Suboxone. And they would say, we don't like Suboxone. Suboxone's dangerous. People are addicted to it. They're selling it. It's the scourge of our existence. So as promising as buprenorphine is, I think it has also brought a certain amount of trouble to people in the community, law enforcement, medical care providers, a few of whom are in the audience today. Nice to see you folks. And I think Zev's approach is really an attempt to try to continue to make this powerful, effective medication, not a silver bullet medication, but effective medication available to the people with opioid use disorders who can benefit from it, but also to really kind of take into account issues around compliance, diversion, misuse, et cetera, so that it continue to be made available, but better monitoring system. So I'm really excited to hear your presentation, Zev, and glad you're here.
That was a great introduction. I probably can skip the whole first half of my talk now. Thank you. It's always nice when someone does that for you. I'm sorry that I didn't have it ready to load before, so just need a second. Okay, it's encrypted for HIPAA compliance, right? Don't look at my password. Thank you for the invitation to come, first of all. This has been just so excited to be able to be associated with the Center for Technology and Behavioral Health and to be able to work on exciting projects like this. As he said, I am affiliated with a bunch of different places. So I guess just to start, and I think Mark make this point, is that prescription opiate abuse and heroin use, opiate dependence, which includes both of those, is a major, serious public health issue right now. Over the past decade, opiate analgesics, prescription painkillers, actually surpassed all other drugs as the primary cause of drug poisoning deaths. As people have started to do all these prevention measures in order to decrease prescription pain medication abuse, actually we've just seen this transition to heroin and IV use has increased in the exact same time, and with that we've seen a 70% increase in the last year here in the Northeast in Hep C rates among 20 to 29-year-olds, and obviously the risk for HIV as well. So what is buprenorphine? Just some facts, because I think, as Mark said, people know about Suboxone, but don't. I want to make sure everyone, as we start this conversation, understand how it works. So it is a very special and unique medicine in the way that it works. It's a partial opioid mu receptor agonist that prevents opiate withdrawal. So unlike methadone, which is a full agonist and can cause euphoria in certain cases as well, buprenorphine has this. It prevents opiate withdrawal, but it's only a partial mu opioid agonist. So therefore, there's a ceiling effect on respiratory depression. It's often co-formulated in the U.S. with naloxone, which is a reversal opioid antagonist, and that's a deterrent. That's not absorbed in the body when you take it the correct way. If you take it, which is underneath the tongue, sublingually, if you were to take it IV or snorting it, then the naloxone can be absorbed, and people will experience withdrawal if they already have opioid dependence. Buprenorphine binds more tightly to the mu opioid receptors than any other opioid out there, and it holds on longer than almost any other opioid. So what that means is that if you take buprenorphine once a day, it will last 24 to 36 hours, and it will block your opioid receptors, the receptors that are responsible for the risk to respiratory depression. It will block those for the entire day. So if you do take buprenorphine, both you're out of withdrawal and it also is a blocking medication. So where is buprenorphine being prescribed? It sounds like, from Mark's perspective, maybe not very much around here. Interestingly, there were 9.3 million buprenorphine prescriptions dispensed in the U.S. in 2012. So if you assume that everyone maybe is taking it a prescription once a month over the course of the year, then that means that there's close to 1 million people, 750,000 people, probably a little more than 1 million actually, because not everyone goes for the whole year, maybe more like 1.2 people. 1.2 million people that are being tried with buprenorphine in a year. And yet, if you look at the statistics here, in 2013, if you look at the national SAMHSA surveys, actually there are only 31,000 people in substance abuse treatment programs receiving buprenorphine, and in opiate treatment programs, only 7,409, and that's nationwide. So actually, where is all this buprenorphine being prescribed? And it's generally being prescribed in office-based opioid treatment, or OBOT, which is the abbreviation I'm going to use a lot. And and I should say that the OBOT system was developed by what we call Data 2000, and that was a bill that was supposed to bring addiction treatment out of the shadows in the corners and bring it right into the center of medical practice, so that someone's primary care physician could treat their opiate dependence. And it wouldn't have to be something that people would have to necessarily always go to a treatment facility for. And that's what it has expanded access to care. So I just mentioned this briefly. I'm not going to get into the study, but Roger Weiss, who was one of my mentors at Harvard, was the director for the CTN trial, which is the Prescription Opiate Addiction Treatment Study, CTN 30. And this is important because what they did was a two-phase trial where they tried to detox people quickly off of Suboxone, or buprenorphine, and look at the effects. And then for those that were unsuccessful, they would put them on for 3 months, which was at that time seemed to be a long period of time. And then they would again taper them off and see how they did. And what's interesting is that actually in that very first phase, only 6% remained successful after the taper from buprenorphine. And so if you look at 12 weeks, though, of that 12-week stabilization period, you have 50% of people remaining successful in opioid treatment. But as they taper over the next few weeks, at the end of the taper, they're down to 28%, and by 8 weeks post-taper, basically 90% of people have relapsed. So this paper really made the case for buprenorphine maintenance, and helping people get inducted on buprenorphine as a maintenance medication for opioid dependence, and then finding a way to help manage that. The problem is that Data 2000 waivers only allow us to treat 30 patients in your first year and then 100 patients after that. And so there's a limited number of physicians that are willing to prescribe, and that is the scarcity issue that Mark was talking about. The scarcity creates more diversion because people can't get it, so they try to get it in illicit ways. So retention in buprenorphine treatment is important, because if people drop out, they generally relapse. And actually, when they relapse, their overdose risk will go up. So going into opioid maintenance treatment reduces the risk of overdose by 50%. And then as soon as people leave, it can be up to 26 times greater risk of overdose in the month after leaving opiate maintenance treatment. So why am I talking about medication adherence and all this? Well, this is a study that really got my attention. It was actually part of a CTN trial of young adults who were on buprenorphine for opioid dependence. And what they found was that young adults who took their medicine greater than 5 days a week had a strong inverse relationship with attrition from the study. So if they didn't drop out of the study if they took their medicine. It's just one predictor of many, but it was a very strong relationship, and that caught my attention. The other thing is that medication adherence in a recent study actually is a predictor for increased costs. So if people are non-adherent with their buprenorphine over the course of the year, then there are much higher healthcare costs than the folks that do remain adherent on their medication. So medication adherence is I don't know how, good, you guys, can you all see this? No, okay. So I'm just going to point out where the arrows are, and so we can think about some of the reasons why people might not be adherent to their medication. One reason is people actually discontinue their medication intentionally, and maybe they might tell you, which would be overt, or they might not tell you, and that would be covert discontinuation. And with regards to buprenorphine, we call that diversion, or often is diversion. The other way that people might not be taking all their medicine, maybe missing doses, and that might happen because of external barriers, it might happen because of internal barriers, or it might be a covert partial adherence. So just to nail this down, because I think it's important, is that people don't take their buprenorphine either because they lose their medicine, because there are financial difficulties, often insurance won't cover it, or there'll be gaps in insurance because you have to give in prior authorizations almost every 3 months with insurers in order to cover this medicine, but you don't with oxycodone, I should mention. There are adherence lapses, which are internal reasons, things like oversleeping or forgetting or loss of daily recovery focus. But it's these covert reasons we actually think are most important in buprenorphine treatment because we're working with people who are in recovery, early recovery from opiate dependence. And that is the covert discontinuation or partial adherence. That's selling or sharing some or all of it with others. And actually, most people in this situation, there's a study that shows, actually feel like it's a compassionate thing to do, to share your buprenorphine medication with someone else you care about. And covert partial adherence, which is basically generally ambivalence about recovery. So someone is thinking about getting high that day, and they want to avoid the blocking effect of buprenorphine on opiate euphoria, because most people, when they start buprenorphine, they try to use again, and then they realize that they don't get anything out of it, and so they don't want to waste their money. But they know that if they stop their medicine, at least that day, then they might be able to use. So those are the things that we really are trying to help with. There are several different types of based interventions, clinician-based interventions like motivational interviewing, cognitive behavioral therapy. You can use incentives and contingency management. There are telephonic reminders, such as the thing that I get whenever a pharmacy is calling me about a refill I might have, or you might as well. There are all sorts of electronic devices, texting, electronic reminders, and pagers. All of these are helpful for adherence lapses. But when it comes to the covert reasons for non-adherence, they're not particularly helpful. And that gets me to this buprenorphine diversion, which is what started talking about. As you can see here, as buprenorphine has been prescribed more over the last 10 years, seizures from illicit buprenorphine or diverted buprenorphine have increased, actually, especially in our northeastern area. Oh, sorry, backwards. And this diversion is starting to threaten the regulatory framework that buprenorphine is being prescribed under. I'm not sure if people are aware, but I've been dealing with this a lot in Massachusetts. in that over the last year there have been actually 2 different bills, and one just came out, the one on the bottom there, 2133, just came out yesterday to try to regulate buprenorphine through the Department of Public Health and take it out of the ability of doctors to be able to decide how to prescribe. So this has been kind of an ongoing process, and I don't think it's just Massachusetts. So it's very important to figure out how to protect this medicine that is so helpful to people so that it can remain available and not have the lack of access issues that I think are possible. So here are some different diversion prevention interventions that are out there that are recommended. Urine tox testing, random pill counts, having short prescriptions, requiring a lockbox, doing in-office inductions with lowest possible dosing, mandatory psychosocial treatment, repeated inquiries about diversion and treatment, and making sure to check the prescription monitoring program. So people are doing these things, but unfortunately, if you're an office-based opiate treatment provider, let's say in rural Vermont, let's say you're part of the hub and spoke program, I imagine someone out here might be, it might take a lot to be able to do all these things, and we're doing them. In other states, I think a lot of people aren't doing them because they don't have enough support from their state or enough organization in order to be able to do those kinds of things. So these are the diversion prevention interventions that are out there right now, and even all these things, they're always after the fact. They're not actually preventing diversion. Last thing about this and how I got to this intervention is that there's a clinical opportunity here too, because buprenorphine patients generally come to the appointments with their doctors. If you ask them to go to psychosocial treatment, often it can be something that they will miss about half the time. It doesn't feel as important to them for some reason. So when people are coming to take that medicine, that actually, if you can tie medicine to treatment, in buprenorphine treatment, actually you get more attentiveness and more engagement. And I would say that moment when someone takes a medication during the day is the moment when they're deciding, I'm not going to relapse today, and I'm not going to overdose today. So what's needed? We came up with this idea for an integrated platform that could simultaneously ensure someone takes their meds, so they're adherent to their medicine, prevent diversion, prevent overdose, and enhance the potency of clinical treatment and recovery support. We were looking to try to come up with some idea that could be a remote platform that could be delivered at a low cost to a high volume of patients with a minimal burden on community clinicians and treatment programs. So this is what we came up with. And that is that at the center of it is the client or the participant, and that person is taking their medicine and they take it every day, once a day. We came up with the idea that they could use an electronic, secure pill dispenser that can't be tampered with in order to store that medicine. And when that medicine dispenser opens, we could do directly observed treatment and supervised self-administration by video conferencing. And this is similar to what happens in methadone. People have to come into the clinic and they get dosed every day, and we want to make sure they take their medication. So for the higher risk patients who are taking buprenorphine, which is actually about 50% that aren't retained at a year, so 50% of people it's not working for in the current structure, those folks, I think that something like this could be very helpful for. So the way that it works is that the hub clinician would be the person who is doing these video outreaches, video check-ins every day, providing recovery support, like a daily recovery coach, making sure someone's taking their medication, and if they don't or anything comes up, they can give that information back to their local site clinician, who is their prescriber. And this is actually what the electronic pill organizer looks like that we have, and I do have one here if people want to see it. And the idea was, and we came with this idea of 4 R's, that the hub clinician would remind the participant to take the medication. They would establish a video connection and then record that the participant had taken the medication. If there was any kind of ambivalence about the medicine, then this is where instead of providing MI, motivational interviewing, at the very beginning of treatment, 1 or 2 times, you could do it every day at the moment when someone is ambivalent about taking their medicine, at the moment when they're ambivalent about recovery, and help them to, MI doesn't always resolve the ambivalence someone has, but it gives you the best chance perhaps that you'd have. So help them to potentially resolve the ambivalence and take their medication. And if it doesn't work, well then we can connect them back with the relationship with their local treatment provider and let them know that they're struggling and they're having a hard time and could use some extra support. So we had primary aims. I'm not going to read each one of these, but we focused on feasibility, usability. We looked at some types of preliminary efficacy around adherence, diversion, and resource conservation, as well as acceptability in this proof of concept study. And what the study is that we did is we had a 2-week lead-in baseline period with 2 days of training people to use this platform, to use the video conferencing, to understand how the pill organizer worked before we left them alone at home with their medication. And then we had a 4-week initial platform testing period, and this is the data I'm going to show you today. And we asked them to complete weekly diversion, adherence, and acceptability surveys. We also had this 360 data collection strategy. So we had the hub clinicians who were doing the video conferences also speak about their satisfaction and record the adherence from what they saw each day, as well as asking the local site clinicians who were associated with the local treatment center how they felt about it, whether it was acceptable or not. Just a quick word about the site. One of my affiliations, I work for Westbridge, which is a national nonprofit private co-occurring disorders treatment program with sites in Manchester, in Florida, and in Boston. And we implement the IDDT ACT teams, which I imagine most people here are familiar with, assertive community treatment teams. And we provide daily medication delivery. So at this site, we had 3 participants who were willing to participate in this proof of concept study who had co-occurring disorders and were receiving controlled substances. In this case, one of them had buprenorphine as the controlled substance and 2 were using stimulants. So the first primary aim, feasibility. We wanted to look at could we achieve at least 90% reliability in the function of these key components of the MySafeRx platform during the daily use for this 4-week period. And what we found was that we were able to establish video connection in 43.9% of the days during the study, of person days in the study. We were able to get visual confirmation that someone had taken their medication via video on 91.5% of the days. And if you actually looked at the days that there was video connection made, then we were able to have visual confirmation of medication adherence on 98% of the days. So if you can make connection by video, I think that was one of the things that people doubted, like would you be able by video conference to be able to see someone taking their medicine and feel confident that they had? And in fact, we are able to do that. There were 2 days when things didn't work. One was that someone had actually tried to tamper with the device, which is always one of the questions, are they going to do that? But then it didn't open, so we had to go out and help them to open it and reset it and get their medication and coach them on not tampering with it. The other thing is that on one case, we did have an issue with video conferencing quality that made it impossible to be able to be confident that someone took their medication. So usability. There are many ways to measure usability, and we do have system usability scales at the very end of the study, but we don't have that quite yet for this initial part. But what we did want to look at was how long would it take to train people, and could participants with dual diagnosis, co-occurring disorders, be able to learn this complex system and be able to carry it out. So we had an idea that we would train people, and as soon as they got to 2 consecutive days when they got at least 90% right on the checklist that we had of everything they had to do, then they would be able to get started. And we hoped that it wouldn't be too long, because if it really took a long time, then that would make it very hard to be able to implement this. What we found is that the first day, on average, it was about 31 minutes of training time. Second day, about 23 minutes of training time. And overall, people only required about 55 minutes on average of training time. We did the first day of training in the office with them, and the second day of training, we would go to their home with them and do that there, while the hub clinician would be in the office. And all 3 of the subjects that we did in this proof of concept study were able to do it in the first 2 days. So that was a very, I think, positive thing, that it is doable and participants are able to learn this. Around preliminary efficacy. So looking at adherence, we wanted to see, again, looking back at this Warden study, that in all weeks that we could guarantee with this intervention, that people would take their medicine on more than 5 out of 7 days, since that's so strongly linked to clinical outcomes. We also wanted to make sure that there were no reports of diversion during this trial. And we wanted to show, so Westbridge, as I said, it's an assertive community treatment team. So we do this daily outpatient medication delivery. And that's very time intensive. And when we talk about our program, when I've gone to different conferences and talked about our outcomes, people always say, yeah, but how do you afford that? Or how is that going to be applicable to the rest of the world? And so that's really, I think, one of the other motivators here was how do we take this model that seems to really help people to get into recovery and be able to make it something that everyone could be able to benefit from. And so we wanted to see, can we reduce the amount of resources that are necessary and the staff time and costs that are necessary if we do it this way. And this is actually, if you look at, on the left, the first 14 days is the baseline phase, and then we have a training days. And then as soon as a hub clinician takes over and is doing these medication adherence visits via video, what you see is a very substantial drop in the amount of staff time that is used, down from an average of about 30 minutes a day in order to guarantee medication adherence and diversion prevention to about 7 minutes a day. So the last thing is acceptability. And what you see here, 7 is completely agree and 1 is completely disagree. And clinicians, who are the hub clinicians who are doing this over video, generally actually felt pretty satisfied with the whole integrated platform. And if you look at the participants and the subjects, they felt pretty comfortable with the electronic organizer, they felt comfortable with the video conferencing, and they felt comfortable with the text messaging. So all these components we were putting together, they felt comfortable with. In this particular small study, however, it was about neutral, and maybe even a little below neutral for their satisfaction with the actual organizers, with the whole platform. So I've been trying to understand that, and we went back to the qualitative data to try to understand, well, why did that seem to come up? And there were some positive comments, and there also were some issues. So on the positive side, people really felt like the daily outreaches helped them to get up and get started in the morning. They were able to set goals every day with their recovery coach and meet their goals the next day and check on them and have that continuity. And I think that, from a recovery standpoint, is really important. Where the issues came up, I think, in this specific proof of concept study was that people felt like this program was a step back for them, that they had, they had access to their controlled substance before this at more extended periods of time, and now suddenly they're moving down to a daily medication dosing. They also, the organizer only opened at a very specific time of the day, so that was problematic, because if they couldn't be available, then they would miss their meds. So the platform felt like it was a step backwards, and that is partly because this is designed, or the way we imagine this is for induction treatment with buprenorphine, and in this context we were giving it to people who had been on maintenance buprenorphine or a stimulant for an extended period of time. So they had already demonstrated the ability to be able to maintain it, and now here they were feeling maybe that it wasn't as helpful. So in the next study that we are planning, we hope to do this during the induction phase, when this will be for people who have either failed previous treatment or are coming in at high risk. So we believe that they will actually find it more beneficial from a satisfaction standpoint. And as far as the rigid time schedule, we have been looking to improve or use a medication dispenser that won't have the same time constraints that this ePill Secure pill dispenser that we've been using have done, but still be able to guarantee and ensure adherence. And you may have noticed that one of our 4 R's was our relationships, and one of the things we had hoped to do was, if people didn't take their medications, they would maybe have a social support, like a sponsor or a family member they live with, be able to know and be able to go and help them. But people were kind of avoidant of that, and so, at least in this stage, we've left it out for further studies. So the future plans for this MySafeRx project, we're hoping to submit a R34 application to be able to support PCPs in a community office-based opiate treatment program within a public hospital system across a region actually in the Metro North Boston area, to be able to support them in being able to ensure adherence and prevent diversion and improve clinical treatment for their higher risk patients. at Westbridge, we're hoping to use this to enhance our services and reduce the cost of medication supervised self-administration. And we're thinking about ways of potentially using this technology to be able to provide the kind of assertive community treatment, supervised self-administration work that we're doing, potentially to multiple other regions as well, and provide long-distance care. And ideally, I think where I think this could be really helpful is in larger community, in the larger community, especially in rural areas, where there's a lot of distance between where community providers are providing buprenorphine and where, may I say, a hub of with a lot of substance abuse treatment is located, so that it can be hard for people to maybe get access to all the additional support they need because of the distance. And so a remote, mobile platform like this might be able to really be able to offer an added benefit to ensure adherence, support recovery, and prevent diversion. Mark McGovern and I have actually discussed about how the Vermont Hub and Spoke program in some ways could be a perfect fit for this kind of opportunity. Similarly, in Western Massachusetts, a similar issue of difficulty with access to providers and difficulty with access to substance abuse treatment and this whole integrated treatment approach. So I just want to express my gratitude to the Westbridge participants who are willing to participate in this proof of concept study, to our leadership board and our leadership team and the Westbridge board, to Lisa Marsh and Bob Drake and Mary Burnett, all who helped me to think about how to put this together, to our Westbridge technology team, which has put up with us and helped us with the video conferencing, to Jesse Schramm, who's out there, who did a lot of the clinical outreaches in the morning and was a hub clinician for us, and Rick Thornton, who was as well, and Jacob Bordowski in the back, who has been our research coordinator extraordinaire and dedicated the last year of his life to getting this whole project going. And he's in green because he's coming to Dartmouth and will be a grad student here. So you guys are lucky. Okay, so that's it. I'm not sure how to get this out. Huh. Okay, you'll figure it out. Just, yeah. Okay. Thank you very much.
Dr. Brent Moore is an associate research scientist at Yale School of Medicine. He's also a VA research psychologist at the Pain Research, Informatics, Multimorbidity, and Education Center, which I'll use the acronym PRIME. But those sound like some very difficult patients, I would have to say. He's an experimental psychologist by background, received his PhD at University of New Mexico. I think if I interpret his CV, he transitioned to the dark side about 10 years ago during a postdoc at UVM with our colleagues Al Budney and Steve Higgins up the road at UVM. Brent's going to be talking about an automated telephone cognitive behavioral therapy that supports recovery in methadone maintenance patients. So many of you also know, like buprenorphine, methadone is a very effective medication. I think recent systematic reviews, Cochrane reviews, highlight its effectiveness, particularly for opioid use problems and reduction in criminal activity. It also seems like a great opportunity because people are receiving medication on a near daily basis to try to impact other outcomes, such as other substance use, other psychiatric types of problems, HIV risk, Hep C, and so forth. We really haven't done a great job of capitalizing on the treatment opportunity for people in methadone treatment. So I think it's really important work that Brent and his colleagues are doing to really kind of bridge that gap between the need for and really access to good care. So we're really excited that you're here, Brent. Thanks for coming up 91 to join us. And I'll get that review to you just in a couple days. Okay.
Thanks, everyone. It's a real honor to come up here, and I've told a couple folks that I lived at Yale here for the past 10 years. I was at UVM. I was going back and forth, and right in the middle of it is this really cool place that I had never found before, and I feel embarrassed to even admit, but I'm very pleased that I've had the opportunity to come see it now. So I want to talk with you, and I'm going to take a little bit of a step back. A lot of my work has been as a statistician for different projects I've been involved in. And as you probably know, statisticians tend to be maybe a little cynical, a little conservative about a lot of things, and sort of have to be convinced over and over and over again that something is really true or really significant. So part of that influences how I've looked at this field sort of in general. I've been very excited about the prospects, but I've also been a little concerned. And one of the other things that's made me concerned is that as I've looked at a number of recent trials, both in JSAT as well as other places, I've noticed a number of findings, negative findings, about computer-based treatments or computer-based interventions with substance abuse that have had negative or null findings. And I've been concerned about that. When you go back and look at a lot of the original trials that Lisa and a number of folks have done, there's some very important distinctions between those. A lot of them are the contingencies that are placed on individuals to make sure that they actually adhere to using and engaging in the system. But other systems that are web-based systems that people can kind of use, what you find is that a lot of times people don't really get very engaged. And of all the people that are offered those interventions, a whole lot of them never use them at all. So there's some concerns that I have about that, and it also leads to some of the areas that I'm interested in looking more research at. So one of the things I'm concerned about is that at some point somebody will make a policy decision based upon some null findings, and they'll say this stuff doesn't work. And I certainly don't want that to happen, but you know, let's try to keep an eye on a number of different things. So I appreciate too the discussion previously about substance abuse or about opioid dependence particularly. Obviously I'm going to say many of the same things. Dramatic increase in the past 20 years, a lot of first-time use that's increased, dependence has tripled since 2000, and a lot of that is prescription opioids and then transition to heroin and injection, etc. We've been interested as a group at Yale. I've worked with Lynn on other projects and David Filene, Richard Schottenfeld on a number of different things. Some of those are finding out how we can make buprenorphine effective in different settings, finding out if counseling works with buprenorphine, if it's helpful, if it improves treatment, and also expanding treatment, so expanding those to other types of settings. So we talked about the office-based settings. That's a great place to expand treatment. And there's lots of potential positives, and there's the other potential negatives. So in addition, I mentioned improving behavioral interventions, looking at subpopulations, including chronic pain and others, to find out if those individuals may require increased care. And then also my interest in developing and evaluating automated treatments. So there are a lot of approaches you can take for looking at alternative models for those behavioral treatments. The telephone therapy, a model of distance counseling, the individual that's on the other side observing the medication, that's also sort of a distance approach, involves another person on the other end. There's also traditional self-helps. We could hand people books. We could hand them pamphlets. There's actually a relatively nice history of, particularly around alcohol, of bibliotherapy, of it being effective. So we don't only have to use technology. It may have some other characteristics that we like, but it may not be the only approach we need to use. As far as automated treatments, as Lisa's mentioned, there's not only standalone, there's web-based, there's multi-component and multi-method and multi-platform approaches too. Of the mobile type approaches, we've heard a number of discussions of those, of smartphones. mobile internet, there's text systems being looked at a lot, particularly for HIV prevention and for tobacco cessation, not only here, but in other countries as well. I've been interested in looking at trying to make a decision about what type of system to use. And so we did a survey a few years ago. We also looked at video games. This was the one Lynn and I did many years ago. So I guess it's many years ago now. So as part of a buprenorphine naloxone screening, and we had a whole bunch of screens that we evaluated, and we found that of those folks, about 64% had regular internet access, and 79% had regular cell phone access. So even though a lot of people, like as other folks have noted, a lot of people do have access to internet and have access to mobile internet, that number was actually quite a bit lower at that time. It was, I think, below 50%. We were wanting to have something that would be available to everybody. So I wanted it to be where there wasn't going to be somebody that would come in and say, oh, I can't do that study because I don't have a phone. We have to give them one, and then you know, the practicality of that, of scaling that up, gets harder. So we wanted something everybody can use. So we went to an old technology, interactive voice response, okay? IVR system. And therapeutic IVR system has a lot of the same benefits that Lisa's brought up before. Low cost, mobile, you can use it anytime you want, whenever you want to, from either your cell phone or from another phone. It's highly accessible. You can use it anywhere, rural, remote. Also places that don't have access, cell access, and that sort of thing often tend to have ability to have access to those as well. It's what I like to call low high tech. It doesn't feel like it's high tech at all. It's the system that everybody reaches when they dial any company anywhere. It's the phone tree system. So it's not intimidating, it's not scary, but it actually can have a lot behind it. So it can have a lot of capabilities of any computer-based program. So it's also easy to adapt and change the content based upon the feedback and updates in the science, which we've actually found very useful. So, as a number of folks have mentioned, the development process is very important. One of the reasons I was concerned about the issue of lots of studies that might not show effectiveness, sort of two things kind of come out of that. The first is that the development is important. And the second thing I'll talk about in a bit is that it's also important to evaluate factors that influence how much people get engaged with systems. So the development procedure, other folks have sort of talked about their development procedure being very systematic, very consistent in that approach, and also doing a number of things that you can't do because you're not doing something face-to-face with a client to figure out what their response is at that moment. When you're developing a behavioral treatment as a psychotherapy, you're getting constant feedback from that person. So you're constantly writing notes about how they're responding to something and how they're changing. We don't have that. So we have to do it different. So we need to set some very clear approaches and be very systematic about it. And I think the other thing we have to do is we have to set some a priori expectations or guidelines. And so a lot of that is the criteria that we set. And there's no magic to that. As I was saying, the 90% for acceptability and for those different criteria for his, that sounds perfectly reasonable. So, but there's no magic number that we have to choose. We just need to be reasonable and consistent about what we're saying. So I'm going to walk you through the process we did. And the reason that there's two little paths there is that we did this both for buprenorphine and that context and setting, and then we also did it for methadone. And the reason we followed the same process instead of just sort of combining them all together and saying they're all opioid agonists, we should just do them together, is because the contexts actually have some differences. So the systems ended up being different. And I think that process for me has made me think more later about, well, what are the other factors that may influence whether it would work in another setting, and how we might need to tailor or customize not just for the individuals, but for the organizations as well. So the approach we did was we started with generation and editing, and this is, it should be theoretically based. So that's, everyone here has been talking about that. You have a theoretical base, you generate, you create the system. We've done a process like many folks of saying it's going to be reviewed and it's going to be acceptable or going to be at a particular reading level, or in this case it's a listening level because it's all just audio, which is actually, you can get away a little higher with listening level than you can with reading level. So people understand and hear slightly differently. So you start with that, and then what we did in our process is we did counselor acceptability and feasibility testing and recommendations, and then we did a series of modifications based on that. We did both qualitative and quantitative approaches for those. Then we evaluated experienced patients, similar to other folks who've sort of, finding out from the folks that have that experience of period of abstinence under their belt, that are experienced within recovery, what do they think of it? And what is their feedback that they have? And then we had criteria for both of those. For us, our criteria that we used was that twofold, acceptability and feasibility. So the acceptability was that 50% of the ratings would be 4 or 5 on our rating scale up to 5. And that's for interest, helpfulness, and ease of use. And then we set a feasibility criteria, which was, we were saying that we would expect it to be used daily basis, so we wanted to see that it would be used more than half of the days. So that was how we set that. And that over a time period that they would use it for at least, over a 2-week time period, they would use it for at least an hour of total time. And then we did a randomized pilot after that with patients that were new to the system, make additional modifications and edits as we saw we needed after that. So, not surprisingly, this is a little bit more about the acceptability and feasibility. The acceptability of 4 or 5, 50% of 4 or 5 ratings of interest, helpfulness, and ease of use, and then over a 7-day period that the majority of patients would have greater than 30 minutes of system contact time, and that the majority of patients would call the system on more than 50% of the days. I didn't have a magic, idea of what that criteria should be. Felt it should be something. After we did our initial period, we did a number of modifications. For us, everybody hated the machine-generated voice. They just despised it. If there was nothing else that they said don't do the machine voice. We hated it. Now, it was not as good as the one with the smoking, so yours was a lot better than ours, but I still think they had a very tight ear and they didn't like that at all. So, and I think it is different because it's, if it's just the only thing you've got, you're just listening to it, and it's not the same as something you're reading while you listen to. For us, we needed very brief modules. We kept getting feedback. It wasn't one of those where they would sit down and they would do a session. It just didn't fit. The phone system was a very different approach with that. They wanted them to be 5 to 10 minutes. And they also wanted to be able to have them access at any point in time, and they wanted it more specific to their needs at that time period, which I also think is interesting because that relates to the EMA type things where, people are using it at the time that they need it. So the function of treatment, the function of these systems is different than it is with the traditional me thinking of the therapy sort of approach. They wanted to decide where to go. So we didn't say, you're going to do this, then you're going to learn this, then you're going to do this, then you're going to do this. They didn't like that. You do this module, then you do this module, then you do this module. They just wanted to go where they wanted to go. So that's the approach that we took. I'll talk a little bit more later about sort of how you might combine that a little bit more. We have activities and skills practice. I'll tell you a little bit more about that. We like the language simple. The key was simple and having somebody who knew what simple was and not a PhD's idea of what simple is. They don't like dumbed down. That's not good. I'm pretty good plain language speaker, but there were some doozies I had, so I'm very glad that I had support with that. And they wanted it interactive and engaging, so we actually added some other components to sort of make that more engaging for folks. And part of that was encouragement section, which was sort of an extra bit of things, which I think some folks have talked about things like it, sort of, and we're sort of looking more at things like stories of people who've been doing this a long time, that sort of thing. But we had speeches, we had little songs, we had jokes, we had bad jokes, a lot of bad jokes, and other stuff that, yes, you can get them anywhere, but they were here. So, so this was the structure of the system that we looked at initially. And they all have a secure login. I'm very concerned about security for my patients. They don't want someone else picking this up and pressing it and finding out what they're doing. So we've had a lot of sort of paranoia about apps and how they can make that work. So for us, what we did was they have a secure login, and then they can go to an introduction for first-time callers, explains what to expect of the system. And then they get 3 daily questions, which are like a lot of, I think like Alan's, did you use since the last time you called? For us, it's did you take your methadone or buprenorphine? And how you doing? So we just have, that one seems like it's always a good one to start with. And then beyond that, we have a bunch of things that were specific to the organization over on the left-hand side. Folks found that very helpful and useful to have sort of one place they know they could get at least a number forwarded or a phone number or contact information or just some general information. So we embedded that within that for this organization. And then we had, we broke it up into what we call learning and activity sections. And let me give you a little bit more detail of that. It was based on the learning modules. There were different ways they were done. They were started with didactic presentations, which was just a description of what what is urge surfing. So just a description of what urge surfing is. And then we had these different layers, and we had these role-played type presented scenarios in 3 layers of increasing interactivity, and we called these the learn, choose, do, because I'm within a medical school and I'm following the C1, C1 do one, teach one. So that got me thinking that way. So we had the learn modules, which were individuals would get feedback about making the correct choice of the different options to make sure that they were actually learning it. So we're following like other folks have done as well. To choose the best option among multiple choice options. And then to do, where they actually record their own voice. If it's looking at something like drug refusal, they record themselves and then they rate themselves on it afterwards. And folks seem to like that. It's a slightly different thing. They're in charge of deciding whether they think, they did a good job. Individuals for the learn and choose, they get positive feedback for the correct responses, and they get corrective feedback. It's not punishing, but it's corrective for the other creative responses. And I think, like all of us, sometimes you press the other one just to kind of hear what it has to say. And you learn something with that too. So that's good. For the activities, those were direct guidance in using the coping skills. So if it's urge surfing, sit in a quiet place, comfortable place, and it walks you through the urge surfing. If it's relaxation, it walks you through relaxation. You can get a CD at the bookstore and you can follow, there's lots of those around, but this one is just right there for them. So there's relaxation exercises, mindfulness. Distraction activities gives you, here's some ideas of things you can do to distract yourself or other things. And also, you can do it right now. You can stretch. Here's a stretching activity you can do. And I don't have yoga yet, but maybe we'll get there. Physical exercise. and the encouragement modules, which I mentioned. Feasibility that we did with both buprenorphine and methadone patients was high. We did get greater than 30 minutes of contact time over that 1 week, 7-day period. In fact, it was more than, I had thought, 76 minutes for the one condition, 82 for the other, not conditions, those individuals, populations. And a lot of the calls were more than 50% of the individuals called and more than 50% of days, but the mean call length is about that 10 to 12 minute range, and that's pretty consistent over all these. This is something I found very interesting. When they call is all over the map. It's all different times. So I apologize that the time period there is sort of crazy to see, but the time of day is on the left there, and the 12 that's noon, and at the top is midnight, and the bottom is the middle of the morning. So as you can see, the little box just sort of gives you that idea of when our clinic was open. And there's all the calls that they make at all the other times. So a lot of calls on the weekend, a lot of calls in the middle of the night, a lot of calls late in the day. So they're using it a lot of different time periods. We did a brief 4-week trial. We evaluated whether individuals received recovery line access plus treatment as usual. In other words, they were receiving their methadone services as per usual. They were supposed to receive groups on regular occasion. They had to have at least one group per month, and then they had other services that they could attend. Or they just received treatment as usual. All individuals were currently prescribed methadone. They had used illicit drugs in the past 30 days, and or had evidence of a urine screen toxicology or self-report. So this is, I think, interesting because it's not just purely opioid dependence. It is the polysubstance use. It's the additional substance use on top of the opioid dependence. So in New Haven, a lot of cocaine, still very common. They also needed to understand and read English. I know a number of folks are looking at Spanish versions. I had a great Spanish speaker research assistant who told me, no, we're not going to do that because it's too many things change. So I wasn't ready to jump in there. We excluded folks who suicidal or homicidal, met diagnosis for bipolar or psychotic disorder, had any medication complication that precluded participation. People used the system. They used it pretty well. 14 calls out of 28 on about 10 days. We told them to use it every day. They didn't. Not even quite every other day. And then the variability of that is, as you can see those standard deviations, it's pretty wide. So some people used it hardly at all. Others used it a lot. The total minutes, mean for total minutes, 121, that's about double what it was for the 1 week. So there's a bit of a drop off over time. The calls are still brief, 9 or 10 minutes here. And a lot of them still outside the clinic hours, 58% of them outside the clinic hours. They did access a whole range of our different things, so we didn't have certain areas that they never accessed at all. They accessed each of those different areas that we sort of were thinking, and we put them on there, right? So we sort of hoped that they would access them. And they provided ratings of the system or of the components within it, and those were generally pretty good. Do they really use it? Okay, so 83% reported drug use on 1 or more calls. They're calling into the system and they're reporting that they're using drugs. They don't have to report this at all. There's nothing that says it. So for me, that's actually kind of a good thing, that they're actually reporting it. It means that maybe they're going to use the system for what we were hoping it would be for, that it would be a way for them to help move away from that use. 50% of them reported use on 4 or more calls. So, okay, well then, boy, we ought to start moving that, right? So the drug use was reported on 32% of the calls, and then comparing the calls when patients denied drug use. So this is messy kind of way to do a follow-up of, but if you compare the calls in which patients denied drug use to those in which the patients reported use, those that they used it for longer period of time for the call. They're also more likely to occur during hours that the methadone clinic was closed, suggesting that maybe they're using it when they need it. And they didn't differ on the time since the last time that they had called. On calls that they reported drug use, callers were more likely to access modules related to understanding drug use patterns and dealing with withdrawal and craving. That, for me, is exactly what we were hoping. They'll actually use the parts of the system that seems like they would be most useful. Findings summary over the 4 weeks are that we had high treatment retention and satisfaction, no significant differences in urine screens. 4 weeks, hard to kind of get that, not a large sample. We had similar utilization of other treatment services and no significant differences in retention. Where we did see some differences are on self-reported days of cocaine use. Recovery line condition had fewer days of self-reported cocaine use. They had a greater ratings of effectiveness of coping behaviors. So they were saying that their coping behaviors had improved, which I was totally surprised with. And they were more likely to report abstinence on days that they used the recovery line. Ratings of acceptability were high for the system itself. So I'm interested now, I've got a system where they used it pretty good, but it seems like if they were to use it more, or if they were to use it for a longer period of time, could be better. So one of the things I'm very interested in is what are the factors that are really influencing the extent to which people are engaged? And can we influence those? And are there ones that are embedded within the systems themselves? So what about personalization and customization? I absolutely believe in my heart that this is a great thing and that this is appropriate and a way to go. But I'd like to see the data on it. So we're going to do a very simple trial, and we're going to find out if at the beginning of the use of the system, if you provide them with an assessment, and then you tailor a suggestion for where they should go based upon that assessment, whether they're going to be more likely to go there, first of all, and are they going to use the system more over the time period that you specify? That seems like a reasonable test to me to find out if that type of customization improves engagement. The second thing is system reminders. System reminders, again, seem like a great idea. Use the system. How many of you get emails every day suggesting that you use some system? Right? We get fatigue. So where that sweet spot is, it may vary substantially. So we're going to try a couple different systems or a couple different conditions, looking at whether you have a little bit later reminder and an earlier reminder, or if you just have the system call them all the time. Does it just bug them too much, they don't want to do it, or does it actually improve? Which of those conditions might actually improve people, their engagement? And then the other thing we're going to look at is the content of message reminders. And that just falls back on the gain frame and loss frame messages. If I tell you how this is going to be bad for you in the future, are you likely to be engaged more, or is it more that if I tell you, here's the potential benefits? The other thing I'm just hinting at, because I know, Sarah, you're going to jump into this, these are the other things that are really interesting me too. Issues of, what are the other factors that affect engagement and whether it works? Can a system work if everybody within the primary care office you want to put it into thinks it's stupid or hates the substance abusers? Those are going to happen. And it's probably better that we find out ahead of time what factors are going to influence that rather than just assume that we can make it all work just by making it available. That's it. Oh, my two things. I do have, if you want access to our recovery line, the phone line is just right on top there. Actually, you can put any numbers you want in there for the passcode, and there's 2 questions that ask you. You can put in whatever you want, and you'll get access. And then we have a little mobile version of that, My Recovery Help, which has a few of these same modules with that info too. Those will be available for a while, and if you want them extended, you could just email me. And my thank yous.
So we're scheduled to take a 15-minute break. Perhaps you've noticed that on the schedule. But we're actually going to try to take a break, but get everyone back here a little more quickly so we can make the most of our time together. I also think a lot of questions that I've been hearing are, well, how do we get this stuff? When is it ready for us to actually implement? What are the, and Brent's point about what does it take for the for the consumers to use it? What does it take for the providers to support it? What does it take for the organizations to adopt it? What does it take for the people who pay the bills to decide they're gonna cover it as part of an insurance benefit, or even just a way to deal with the economics of these exciting interventions? So Sarah Lord, our final presenter, is going to address many of those concrete implementation issues and tell you where you can buy all of these great... No, she's not going to tell you about that. That's a different issue, but not an insignificant one. So let's take a 5-minute break. Come back at 3 o'clock if you're walking in and out of the hallways. There's coffee, and we'll see you back here shortly.
And then I'm going to want to download all the talks because we're going to want to put them on our website. So,
just give me back your
I will. Yeah, that's fine. I'm assuming this will be this one.
because we had a little bit, sometimes
Did you have a problem with it before?
Well, I'm also not familiar with the, I don't use it, so I don't know how it advances. It's not the same as the Mac. Switch slide or what am I doing?
You want to go up to view show, and then there's something that's not filling the.
It's a presentation. It gives you a timer if you had any notes
Oh,
associated.
do you want it in that mode?
I would like to see the whole thing.
Yeah,
I want to
maybe
see
just
how I,
do slide.
how I created it.
First. Oh, I'm sorry. I just knew what you wanted.
I know I fixed it.
Yeah.
There we go.
Thank you.
The display is muted right now. I will unmute the projector in a moment.
Thank you so much. Yeah, who is this? Technology guy.
Yeah.
Him all day. He's really been great.
Oh.
I don't know why
Why
snaps
he's-
me.
No.
You know, because I'm a Syracuse mother or something.
Yeah, it's got to be. Yeah, he's definitely he was.
Does this switch on?
Yep.
Good. This is the conversation I've been having all day. I'm so excited because we're thinking. I mean, I know I've been working with a lot of people at the state about how to expand capacity because we're going to have everything covered in July. Everything for Medicaid patients and
How do you
the
expand
exchange.
capacity?
And
Right.
how do we get the capacity? Because we lose federal laws if our capacity doesn't match what we say we're going to do.
Yeah.
And so
This
how do
is
do
what we
this?
got to figure out. Well, yeah, but I mean, We'll have to catch up. Every time I've seen you, we've both been in a little bit of. I really want to stay after your.
Marijuana. Oh, it was marijuana. So it's real opioids. Yeah, do marijuana.
Yeah.
So.
Catch up after this.
Okay. I'll let you catch your breath.
Let's try to reconvene. Feel okay? So this is the best part of our conference, in that people who work in the field, who do research, who do community service, who are members of the recovery community, kind of get together and network, I guess that's the term for it, and actually make connections in a way that unfortunately we don't always have as much opportunity to do. So we're really grateful for the opportunity to create this opportunity for everyone. And I think that's one of the original purposes of DCARE back in the day, to kind of serve as to use Zev's term, a hub for all that's happening in the greater Upper Valley and states of Vermont and New Hampshire and beyond. So we're really grateful that you all are here. Afternoon on a Friday's tough, right? To hold energy, to hold attention, and I know people start to fade right after food, and then at this time of the day, some of us who are a little older start to fade, period. So I think I'm really excited that the schedule included Dr. Sarah Lord at the end, because Sarah brings an incredible amount of energy to the table. She's an assistant professor of psychiatry and pediatrics here at Dartmouth. She's the director of the implementation core of the Center for Technology and Behavioral Health. She's a clinical and developmental psychologist by training, with really, it's actually been a theme of the four presenters this afternoon, a strong commitment to reaching the hard to reach, the marginalized members of our society. In Sarah's case, youth, people with HIV, and of course people with drug use disorders. Sarah is one of the few people who can actually say she's from here. She grew up in Norwich and is a Hanover High School graduate, Middlebury College undergraduate, so you don't have to... But I did leave. Right. That enhances your credibility, actually. So, implementation science, actually a short acronym, IS, is a relatively new discipline, still in its infancy. Has a whole host of new other acronyms that those of us doing work in implementation research have come to learn and to just roll out of our tongues without really consideration of others. But some of the things that implementation researchers talk about, I think the three previous presenters addressed, like what is it going to take for consumers to actually use these devices, to use the phones and the tools that we develop? What is it going to take, and what kind of providers are going to be necessary to support the delivery of these things? So I think Zev had a little workforce, workflow aspect to the intervention. What kind of people are going to have to do that? How much of their time is going to be involved? And then, again, the organizations that are presumably going to be the places where a lot of these things are used, and there's going to be leaders, and what are the leaders going to think, and what are the supervisors of the clinicians going to think, and what are the doctors and the nurses and the office managers? How are they all going to work together within the context of a team and an organization and a healthcare neighborhood to make these things actually work? And then lastly, and I think this is huge, what are the economics? Who's going to pay for this? And is it going to be affordable? And do we give people phones, or do they use their phones? Do we say, okay, you can have that app for $19.95 and it's good for 6 months? Or does your Cigna Healthcare cover that cost for you? So the workforce, the workflow, the leadership, the economics of implementing these tools are huge. And I think that today you've heard a lot about development, efficacy, and effectiveness research. What Sarah is really dedicated to is implementation research. So Sarah, we're really excited that you're here and are going to drive us home.
Thanks, everyone. Wow, this is a diehard crowd on a Friday afternoon at 3:10. Thanks, Mark. You really laid the groundwork for what I was hoping to just present as the to seed the conversation, because I think at this point we've had a lot of presentations and a lot of things to think about. So really what my goal is to think about, well, you can build these things and you can test them and you can get really, really good results in pretty controlled situations. And it can work, and then you can say, okay, we're ready, you know. But unfortunately, it's not that easy, and you can't just build it and they come flocking to it. So I was hoping to just present a bit today about, so what are the factors that influence readiness for and successful implementation of technologies. To provide a little bit of a conceptual framework for this, I want to take us back to the diffusion of innovations model with Rogers, and Rogers was a rural sociologist, and he really did the seminal work on diffusion and adoption of innovations from he started looking at farming and using different innovations of different farming equipment and different kinds of seeds and plantings, and then he looked at innovations in medicine and engineering and business. So he really is the founder of sort of this conceptual model that we'll be describing today. He also coined the terms around sort of early adopters to innovations, and then sort of folks that kind of then go along the bandwagon and start using things, as well as then late adopters. Sometimes they talk about laggards, and those are the folks that you really have to work hard to bring them on board. But that's okay, because it's all part of a process. A number of people have sort of built upon the diffusion of innovations model. The one that I'm going to present today is Laura Damschroeder's, which is the Consolidated Framework for Implementation Research. She sort of built her model around health services, which is why I will talk about that one in particular. And all of these models really think about implementation, adoption and implementation from a place of thinking about characteristics of the innovation itself, thinking about characteristics of the contexts within which we actually are trying to use in this case, these technologies, both the organizational context, but also the policy and political context that what factors in those contexts influence our use. How do potential end users, consumers, how do they feel about technologies? And also when we talk about potential end users, of course, it's not just consumers, it's providers and it's any other stakeholders in an organization. And then the implementation process. So what do we think about in terms of innovation characteristics? The model really presents things like, characteristics of innovations that tend to promote implementation are whether you can demonstrate really, is there a clear advantage, a relative advantage? So is there a clear advantage of this solution over other alternative solutions or current practice? Is the technology, in this case as the innovation, is it compatible? Does it fit
with the audience, the end user audiences, and the needs of an organization. Is it adaptable? Can you readily sort of make a fix-it and tailor it to meet local needs? How easy is it to use? Ease of use is a very important characteristic. Can you try it? How easy is it to actually use it in particular settings? And related to that is how easy is it to observe the outcomes from these trials? So technology solutions really, just by virtue of being technology, really can inherently meet many of these criteria. And we've talked about that here throughout the day in terms of the relative advantage of delivery, fidelity, reach, standardization, data collection, the different kinds of, I think it's important to think about the different kinds of technologies that were presented here today and how they fit with the end user audiences. So there may be certain audiences for whom serious games hit the sweet spot. There are certain audiences for whom IVR is the best simple phone is the best methodology. And I think one point that has been sort of alluded to, but I wanted to emphasize is that really the technology should fill the need, as opposed to, there's a lot of sexy technology out there, and so we're kind of driven to be like, okay, what more could I add to make this even cooler? But simple is often the best. And so I just caution folks to not, to really let needs drive technology and how you use it. Technologies are also really easy to trial. You can take some apps and you can put it in your system and try it and look at the outcomes. So I think an important part of the innovation characteristics of these technology innovations, which has also been alluded to here, is really the user-centered design approach, so that you're involving your end users. And that means your clients, that means clients and providers and leadership folks and payment decision makers right from the outset in terms of identifying a need and then figuring out how technology can actually address that need. That's going to help with engagement and implementation in the long haul. So what are the characteristics of organizations or settings that we think about in terms of optimizing implementation, or that we want to study? I mean, I think going back here, for each of in each of these domains, they present tremendous opportunity for research, for how we can study these technologies, but also in terms of implementation, in terms of the messages that we create to convince our stakeholders around relative advantage, and this is how this technology can fit in your particular agency, and why don't you give this a try? And here are the results here are some results that show that it works. So what are characteristics of the inner setting we should think about? One is the social networks and sort of the communication network that you might want to engage as you're trying to build some awareness around technologies. Are there inherent networks within organizations that you can sort of use to seed information about technologies and to build a buzz, if you will, about them? What's the implementation climate of a given organization? What really their capacity for change? And is there a shared vision among stakeholders about the need for this technology and how it might be used? And if there's
If there's not a capacity for change, then that's a target then for implementation or intervention. So when we think about implementation climate, we think about, is there internal tension or motivation for change? Are clients saying we need something different? Are staff saying, you know, we could improve processes here? Is there a history of innovation? So questions around how has change been introduced into organizations in the past, and how has that gone? How has it been measured? Are people using other kinds of technologies within a system, like telemedicine or video conferencing? Just something that you could sort of grab onto to sort of build a narrative around introducing other technologies into the system. Again, compatibility or fit with the norms and the workflows, so really having a good sense of, you know, what is the current workflow in an organization, and how could technologies actually be worked into this workflow, if you will. So strategies around that. How do you build a shared perception of importance of implementation around the innovation? Are there incentives? If you want to try to implement an innovation within a primary care setting, are there incentives for providers to actually promote the technology with their clients, either in terms of tangible kinds of things like awards or promotions, or intangible sorts of things like stature or respect? And another sort of internal climate metric is the extent to which goals are clearly communicated, so and acted upon and fed back to stakeholders. So you may have somebody in a leadership position, for example, at your organization who says you must use this technology. That might go over initially with providers, but probably won't be as so effective in the long run. So really thinking about ways to promote a shared sense of goals and communication, and a learning environment around which to teach stakeholders, build awareness and knowledge among stakeholders. And then another sort of characteristic is how ready is the setting for implementation. Is leadership engaged? What's it going to take to get leadership engaged in using a technology? Are there available resources to support whatever your technology might be, and how information is transferred, and how easy is access to information and knowledge about the innovation? So is training available? Is there ready technical assistance? Things we think about from the external context, when you're thinking about implementing a technology, is what kind of policy things or regulations are going on that might influence a decision to adopt and implement. So in that way, we think about, are there networks? How embedded is a given organization within a network of organizations, so that you might use that broadened, diverse network to promote a technology? Is there sort of competitive pressure between agencies or between organizations around, that group down in Concord is using this technology, maybe we should be using it up here in Lebanon. Is there any press around that? For technologies in particular, there are some, and we've talked about this throughout the day, external policies and incentives. The Affordable Care Act provides lots of motivation and maybe some stress or tension around being able to, how do we provide services to meet the demand? The High Tech Act provides technology incentives to FQHCs to build their technology infrastructure and use technology. The Parity Act really drives some emphasis on parity of medical care and behavioral health care. So we think about sort of what are the regs coming down, or are there external boards that are providing some press to change and to implement a technology in this case. What about individual end user characteristics? What are important factors that would influence implementation? In that way, we think about knowledge that folks have about technologies and using technologies, the beliefs they have about technologies. Will technology sort of get in the way of traditional care? Do they have a belief around technology being, boundaryless and sort of impairing sort of the boundaries between clinicians and clients? Do folks have self-efficacy? Are they confident about using these different technologies? So when you have present somebody with a mobile app, is the training done in such a way that you can build confidence about using it? Are folks just in general, that the folks that you're trying to kind of introduce technologies to, are they open to change? How flexible are they around changing process? The fifth dimension of this consolidated framework really speaks to the process of implementation. And so I'll go through just a bit of these four areas. One is around planning and preparation for an implementation. So thinking about, as Mark sort of described the groundwork, thinking about, well, if you want to introduce a technology into your primary care setting or your outpatient treatment setting, how might this technology influence workforce? And how might you need to sort of prepare workforce, change workforce, train workforce for the introduction of this technology? How about in terms of workflow? How does workflow, ideally you want to introduce these technologies in such a way that they are streamlined with workflow. If you ask folks if there's any sort of perception that it's going to create more work for providers or anybody in the organization, that is likely not going to be helpful for adoption and implementation. What kinds of resources are necessary within to support this the integration of technology? Another sort of really important factor is really understanding from the get-go, from the beginning, having some sort of plan around how are you going to measure success of the introduction or use of a technology within a system. And how are you going to provide feedback to your different stakeholders about that in terms of in order to build buy-in, you need to be able to convince people that what you're introducing is actually going to make their job better or make things better. So that could be by making their job easier. That could be by improving client outcomes. That could be by reducing costs. What's important to different stakeholders may vary depending on who the stakeholders are. So for leadership kinds of folks, the messages around metrics of success might be around the cost efficiencies. For provider folks, messages about success might be around workflow, being able to focus skills on the highest level of expertise, being able to focus on sort of more difficult caseload, difficult aspects of cases. and for improving client outcome. The other important part of this process is really engaging everyone and building buy-in within the organization. So that means really identifying folks that can kind of help cheerlead this effort through a system. And there are different kinds of sort of cheerleaders in this way. There are the opinion leaders, and they tend to be sort of the folks, they may not be driving the change, but they are folks that have, that people look to sort of, they're kind of maybe trendsetters. So if they decide not to use the technology, if the sort of people with a lot of sort of opinion power decide not to use your technology, that's probably not a good thing. So identifying sort of who are your opinion leaders and really being able to then bring them into the process of implementation is really important. Identifying folks in a environment that can actually lead the change and lead implementation and integration of this technology within a system. These can be the champions also that are sort of cheerleading. They may not have the logistic responsibilities of making the change, but they're the champions and they're the cheerleaders, and they can sort of be your main marketers for getting a technology integrated within a system. And then really another important element of this process of integrating technology and related to successful integration and implementation is really identifying external change agents that can really help to provide technical assistance and consultation around integrating a technology into a system. So in our case, we think about those partnerships between the developers and the researchers, and that can really provide the training and the consultation and expertise to help address some questions as they come up. So then we think about executing, you're planning and engaging and then actually implementing. And then the fourth point, reflecting and evaluating as part of this process, really reiterates what I mentioned around the planning, is actually collecting the data around your implementation success. So when we think about that, maybe the penetration, how many people you reached, how acceptable, did they like the technology, and being able to then provide that feedback, as I mentioned, back to your stakeholders. It's so quiet. I really want to ask questions as we're going, but we'll keep going. So I'll keep going, and then we'll get to that place. But I just I thought I'd present just some of the work that we've done in terms of it's the end of the day, and it's Friday, and some of the work we've done in terms of looking at readiness to implement technologies. The first I'll describe is we partnered with the National Council for Behavioral Health, and this is a network of community behavioral health care agencies across the country. And we created an online survey that we distributed to their clinical decision-making leadership, really with an idea to just get a pulse on, how ready are folks to use technology-based solutions to care. We created this survey based on the Organizational Readiness for Change out of the Texas Christian University. And it included things like organizational flexibility, pressures for change, attitudes about technology, the things I really based on the characteristics I described from the CFR model as well. So we were looking at technology readiness in terms of supporting it, how much do you perceive a value to using technology, and how committed are you to using it. Not surprisingly, these are just, the things that we thought would be associated with readiness, like a flexible organization was. Both internal and external pressures for change were both positively related to readiness. Not surprisingly, concerns about privacy. The more people had concerns about privacy, the less ready they were the less they endorsed readiness. We asked just how, in a single item, how ready are you to meet the service demands of the healthcare reform? And that's actually that single item, which is not good psychometrics, doing that, but that single item was actually quite strongly related to their readiness for technology, as was current technology use. Interestingly, not a lot of folks, we had about 450 organizations that we had data from. About just shy of about a third of them use some form of telehealth or video conferencing, but nobody was using anything for, like we're talking about in terms of web-based programs or apps or anything like that. The most likely uses of technology I indicate here. They were more likely. So we gave them this was from a list, and they just checked off, how would you be likely to use technology approaches. So you'll see in the green, they were more likely to endorse using technology for training purposes, for reminders, scheduling and appointment reminders, illness education and wellness interventions, somewhat around ongoing symptom tracking. What was interesting is they were least likely to endorse the things that we've actually been talking about here, such as brief interventions and treatment and some crisis intervention work. So I just think that means we have a lot of work to do to let our audiences know the potential of these kind of technology-based tools that folks have been describing here today. We also gathered at the end of this survey just an open-ended question around what do you see as the perceived barriers to using technologies? And so just to summarize, how am I doing for time? Okay, just to summarize a bit, not surprisingly, funding came up, which was actually the greatest barrier. Privacy issues of privacy and security were quite, or something we definitely need to address before folks are going to hop on the bandwagon with a lot of these technologies. The need for knowledge and skill building and awareness about what kind of programs are out there, we have no idea. And how do we get them? So while I don't have any suggestions, I don't have solutions for that, beyond just like we need to get the word out about these programs. And sadly, probably not just in academic journals, which is the academic journals are really important in terms of disseminating among researchers and policy folks about results, but we need to put those results in digestible language that people can understand, so that we can build awareness in that way, and use other forms of dissemination as well as journals. Concerns about equipment and infrastructure, just attitudes about using technologies, that it's going to build a mistrust. We can't use it. It's going to get in the way of our relationship. It's going to create unhealthy boundaries. Providers, for these on-demand, reach your clinician at any point in time, Clinicians are not so excited about that because that actually can create a liability, as well as nobody wants to be on call all the time. So thinking about strategies around that. Accessibility, and while we've talked about the growth of technology, I think we need to also acknowledge that accessibility for many, and particularly for smartphones, is still a bit of a challenge. And so while that 5 years down the road things may be different, right now, there's a substantial minority, I would say, that don't have smartphones, and it may be more a majority. It's more a majority for some subpopulations. Connectivity, I don't know if anybody's tried to connect here in Hanover or Lebanon, but we don't even have connectivity here at Dartmouth College all the time. So really there's a lot of infrastructure work that needs to be done about building connectivity and really dealing with these issues around billing and reimbursement. These policy issues, they need to be addressed in order for folks to really feel like they can embrace these kinds of models in care. So I imagine I'm not going to go through how we're going to, the potential solutions, because I think potentially that's a good conversation that we can all have together in our discussion, if that's okay. Okay. And that's how you can reach me.
Well, this is the moment you've all been waiting for. You can leave now. No, this is the moment where we can ask questions of the presenters. I think there's an unfortunate situation where you couldn't ask as people had presented their work at that time, but I think hopefully you've stored up some questions and we'll do the best we can to answer them all. Everyone has supplied some contact information, so you should be able to reach people after we're through today. But let's open it up.
I'll start.
Seddon.
I have a feeling that something that is in the back of people's minds, if not in the front of it, and it's certainly in mine, is that as a clinician, which is what I am, as prevention providers, I perceive that people have heard so many things that they'd like to implement tomorrow. We are in the healthcare transition as of July 1st, I believe, in New Hampshire. We are going to have many, many more insured patients who have the right to substance use treatment. And we think reflexively we could fill those gaps with all these wonderful technologies that we heard today. The treatment capacity that isn't quite there to match the need, and now the insurance coverage. So how do we identify currently available programs that we can begin to integrate into our practices?
Well, I just wanted to, yes, I think everybody has that question, and I wanted to just mention a resource that we're developing on our CTBH website, which is a program review. So you'll find at c4tbh.org under Technology and Action. It's a program review where we're actually going through the empirical literature and providing a summary of the evidence base for some of these tools that are out there. Now, whether they are all in a commercial format, I can't say that. I can say they definitely are not all in a commercial format, but some are. And they certainly could be likely used in a convincing way in research projects, capacities that may help to meet some needs and collect some data at the same time. So that's one response, but it's a really good question. Anybody else?
I guess I'd just say, based on the reviews that I've seen in the past few years, I'm also a little concerned that we're maybe not ready, that maybe we don't have the level of efficacy that we have for other behavioral interventions that it's appropriate. I mean, there may be a few that there's some, a single or a couple very good trials, but even the most well-studied ones, there's really not that level of background.
I just want to say that one of the principles that our MySafeRx program was designed around was the idea that that people do need a clinician, and they do need people they can connect with, and yet technology can help augment that and make that clinician more effective and extend the reach of what we can do as providers, not get rid of the providers. And so I think that there are certain technologies that can be good adjuncts to that clinical practice that you're talking about, but I don't think that you can just kind of say, well, all these new people are coming on, let's just give them a technology. I don't think that's what you're saying exactly, but so, I think partnering and adding some of these things that can extend and make some of the work easier is the way to go.
Okay.
Joe.
Actually, yesterday, I sent a text to one of my kids, and my other 3 kids wrote, "Dad sent a text." It's like a new era. And so, what I mean by that is I'm a digital immigrant, and they are all digital natives. They live in this world, and so one sort of thought that I would have about this is to engage them, is to educate them as consumers into this world, and to work with schools and kids, on, in your future of trying to stay healthy, you can use your smartphone. You can use the stuff you know how to use, better than your parents do anyhow. And that might be a place to work. The other thought I had about this is I would suggest you look at it as a disruptive technology, not as, an adjunct or anything like that, This is like doing coronary bypasses and all of a sudden discovering that angioplasty works better. It's disruptive too, And so I look at a lot at Christensen's stuff, and also maybe try and partner with Tuck, with the business community about how do you get a disruptive technology into the world. And it may not be actually systems that are on fee-for-service models that want to adopt this. It may be CVS, or it may be, I don't know, some other places that might be good partners that we're not thinking about right now. And maybe Tuck would have some ideas about that, about getting this stuff that works as well as the clinicians, it looks like, in a lot of things, into the world. And somehow not embarrassing the clinicians, but sort of having them, how they embraced angioplasty and how they embrace, the disruptive technologies that have taken over medicine. And all of a sudden the wave is coming, and the kids know how to do it, and maybe even medical students would be good to try and teach about it, so that the future has more of this in it than, they're the early adopters and the early majority and stuff, not the laggards. It's, a lot of the older people that are laggards. So
the first thing I'll say is that's why these two are up on the stage instead of just all the older folks. So we have our younger colleagues to assist us that are digital natives and grew up in that world. So the other thing about the idea of disruptive is actually some potential very positive effects too, is if you put empirically based treatments, you force clinicians and other treatment providers to have to know that stuff. And there's a pretty substantial history or set of research that suggests that in lots of settings, there's more chatting going on than actual treatment. And so if it's more vital that when you see your clinician, you're getting something valuable, then maybe that'll prompt that. If the patient is able to say, well, I did, the triggers and I did the da-da-da-da-da, so tell me how I can deal with this situation, the provider has to know something.
Well, just to add to that, I mean, I think and to echo what you said, Zev, that there's always the need for, you still need buy-in from providers, because even if it's a standalone kind of tool, you need, they really can be your champions in terms of recommending these things as well, but also to sort of promote that consumers can also be at the forefront of informing providers about how they're working. There's some anecdotal data, that actually, with somebody even from our shop that uses these apps, just these commercial apps, in her, around keeping track of, her emotions and all that. She uses it and she brings it right into her therapy office. And her therapist is like, oh my God, what do you, how can we integrate and use this? So that's a great example.
And they'll say, whether it's diabetes or whatever, they'll say, how do I give you this data? So that the therapist then has potentially multiple things.
There's a statistic that says that it takes 17 years to get 14% of innovations into the hand of the public in terms of healthcare innovations. And on the surface, that sounds abysmal, like deplorable, like a broken pipeline of some sorts. But on the other hand, it might not be such a bad thing, because it might ensure that the kind of things that do ultimately make it through are effective and safe and so forth. And I was thinking about your comment, Brent, that are these technologies, are they effective enough? Or is it a case where demand is outpacing development and testing, if you will? And I guess I wanted to get your perspectives. As developers, how do you sort of balance, what you know about these interventions and then kind of getting them out to the field? How do you manage that?
I mean, that's why I'm still developing. So, but I think that we do have some models that are absolutely further along and are moving, towards true effectiveness evaluation. And I think that that's part of the reason that the integration with the implementation, I think, is important, so that we know which factors will ultimately be important as far as how we can get something to be out there and be effective. I think that the actual effectiveness of even our best interventions, whether it's CM or CBT, are really good compared to nothing. But we've got a lot of room that we can still improve on. These may be a way technologies may be a way of increasing it in some areas to push that envelope. But we need to work with things that we know are truly effective to begin with, I think.
A comment, I think this is on, a comment from a guy who's even older than Joe, an old physician. I really appreciate the discussion or the comments about evaluation, because so many times in medicine we've seen innovation that everybody jumps on the bandwagon for and thinks it's just fantastic, and then you find out after a little while that it's really no better than what you had before, and you've wasted a lot of resources, and we have limited resources. And there's so much survey bias. You know, I listened to the talks this afternoon about where you had evaluation by participants in studies as well. And I really have to compliment the presenters in how careful you were about those evaluations and not saying, oh, gee, they thought it was fantastic, because anytime you try something new with people, anytime you make any intervention, anytime you ask questions, we know about push polls in politics, you know, how you get the results that you're looking for just by asking certain questions. And since resources are so limited, I think it's really important that people adhere to the kind of principles that you have. I really applaud you for that.
Thank you. Kathy.
Thanks. Just reflect on what Mark mentioned earlier about isolation and connection. And a few times in our IOP group, it's come up from patients when another patient wasn't there. Let's text them. Can we FaceTime them now? You know, we've had patients say, do you mind if I Skype, because I'm not going to be in group, but can I Skype into group? And, you know, here I'm like, geez, I don't know about all that. You know, I know, obviously I FaceTime and I Skype, but we're walking into a whole new territory here. Can we put that one on hold? But they're coming up with their own ways. But the point is, they're not looking to they're looking to stay connected to the group of people in the room. And so I think, you know, I like the idea of adjuncting a lot of this, because they're already really doing it. They're, you know, so-and-so isn't here. Well, let's try to get them on FaceTime and see where they are, you know. Maybe not, but they want to stay connected. So just ways that patients can stay connected to one another in a way that feels good for them outside of this setting as well. I don't know if there's thoughts around that.
Well, I would just echo just some of the privacy security issues with some of the technologies. And
obviously, we're not doing it.
Yeah, and I think that's where we could do a better job at sort of disseminating. You know, there's work being done around that sort of stuff, but really disseminating and providing information about how to protect yourself with technologies is really important.
What you're saying just made me think a little bit about how, you know, in recovery people talk about the people, places, and things can be triggers for relapse or for use. And I think it goes the same way, that when you develop a recovery community, those people become triggers for that day to remind you about, you know, your recovery orientation. And that's why this idea of kind of daily face-to-face contact, I do think that when you start to associate people with recovery, and you're having that connection with them, that really gets someone in that mindset for that day of having that day be about recovery. So I think that connection is important.
I'll put out one other thing, which is actually the relationship with the technology itself. So, and people, we all have it. We have some connection, a feel for our phone or whatever the technology is, and there's some. We have emotions with everything, so we have relationships with our technology too. And I think that when we think of all the little bits that we put to make a system what it is, and the way it looks, and the qualities, we're trying to highlight an opportunity for there to be a positive relationship with that. It may be that we're at a stage where we can start actually measuring the extent to which people feel like they have developed a relationship with something they know, and there actually have been some research on that, of developing that evaluation of that, just like it is with a therapist. So I think it's only one relationship, but it can be an important relationship as well.
I actually had one question when you were doing your presentation that I wanted to ask, if that's okay.
I do. Actually, about integrating a social aspect into programs, whether that's web-based or mobile-based, I would caution about building out something like that, because you need, a moderator. You're not able to control what's said, whether it's like a chat room where people can collect, that you're going to have to monitor what's being said, or whether that's, you know, conversations that are happening through the program. So that's something that should definitely be a consideration.
So if I may, so one of the things that came up for me when you were talking was that a large proportion of the people who used your service with their phone, they used it when they were using or had just used. And you were talking about using cocaine users, and I was thinking about how when people use cocaine, often the cues that are associated with that actually kind of become part of things that can then lead to trigger use again. And I was thinking then about how a lot of the patients I've worked with actually are very connected to their phone because their phone has all the numbers of all their dealers in it. And then I was thinking about how in a residential program we often limit people's phone use for a while to be able to try to disconnect that. And so I guess I was just wondering about these devices are so integrated. They both are integrated in a positive way, but they also very much have the same triggering potential or cue potential to go to the other way. And so how do we deal with that? And do people have like their, you know, their blue phone and they also have their red phone, which is like their bad phone or something, and they just kind of pull them out when they want to do their good thing versus their bad thing? And you know, how do we think about that?
And they have a relationship with each. Yeah. I unfortunately I didn't ask to find out. That would have been interesting to find out how recently it was that they had used, if it was just past, you know, just minutes ago, or whether this, you know, when it was. But the, you know, time since the last call you made, have you used, I think does represent that too much time. And more specification would be a way of starting to get some idea. Are people, you know, using because we're calling and using some system because they don't want to use again, or are they, you know, are they using this as a protective technique, or are they, you know, oh, it'd be funny to call the, you know, that thing, or to do that after they're already high.
And I guess it also just made me think about how people also can start to develop. Oh, time to go? Oh, sorry. Okay. I think people can develop kind of obsessive-compulsive tendencies, and I wonder to what extent people that become frequent users are kind of substituting their addiction.
Questions? Al?
I'm a science guy. Question of implementation and integration. When are we ready for integration to implementation? How stated do you need? You know, that is quite a quandary, a paradox. It's like we have no criteria for that. And in most medicine, there's no criteria. How many field studies do you need? Empirical based on this thing, empirical principles, and you know that's the way it's given the state of treatment as usual, the addiction where half the things being delivered don't have that usual choice, they're taking time. How far do we have to go before you can bring it to the agency and say, yes, this has enough data to come? I don't know the answer to that, but it's kind of, sometimes I say, you're rolling that out, you didn't know anything about it. And the other hand, I think, like, it's got to be better than that. And so it's quite a dilemma.
I think that's a great question, and I wonder if it means that we need to change our research paradigm a bit, and maybe think more, draw from sort of industry models a bit around, so that maybe we should be implementing earlier, so that we're actually optimizing implementation of what we think is, you know, here's what we've got, and let's implement it and optimize implementation, and maybe then we move to the, you know, the larger trials. And I think the technology is great for that, just being able to do demonstrations. And really, if a well planned out demonstration with really good metrics behind it, you can get a lot of information.
And they hear something that somebody teaches somebody, they think it's reasonable, and they come back, and now their groups are all built. Data, no data, that's kind of the way the clinical field works. And then all these folks are all creating empirically-based treatments, do a bunch of tests, and then still have to come up with some barriers. It really doesn't exist in the clinical world, except it's almost self-imposed.
But that almost, I mean, that really emphasizes the point of that, you know, providers want to be involved in developing the intervention. So if we can get folks involved early in developing these things, it really can help maybe build buy-in so they have ownership. They feel ownership.
So I was thinking just on a different point, because I don't think Alan's question is answerable at this point. But I was thinking about iTunes. iTunes has rock music, jazz music, and country music. And so a lot of the interventions that you were talking about were fairly diagnosis specific, right? And I was thinking about Peter and Greg King, that are primary care physicians that are thinking about ways to integrate behavioral health, you know, as a kind of a peculiar subspecialty within the context of their workforce, their workflow, improve the care, comprehensive care of patients. So I was wondering if you give much thought as developers to more kind of broad spectrum, transdiagnostic approaches, because your medication tool could conceivably be used for antipsychotic medications, antidepressant medications, mood stabilizers, what have you. CBT is, you know, wildly effective with everything from sleep to sexual dysfunction and drug use. You know, the kind of things that you were talking about, Rachel, also kind of broad spectrum approach. So I wonder if you all were thinking about things on those lines.
Certainly having a holistic approach to treating the whole person, I think, would be wonderful to have. And starting off with kind of a general health risk assessment, looking at various aspects of one's life, and building a program that looks at kind of all the areas that are problematic, and building a program to improve generally your life, I think would be wonderful.
Related, I think we can actually use the systems we have and find out what people tell us they use it for. I mean, a lot of the people that used my system, I don't know if they'd say it was always used for drug abuse. It was used because they were stressed. It was used because they, you know, felt X or Y, couldn't sleep.
I think I want to respect people's times. It's a little past the top of the hour. Is there any burning desire? Final question?
It's probably a good place to end, Mark.
Okay, thank you.
Thank you all so much for coming. It's been a great day. Speakers, please take your plants before you leave. They are for you. I'm not carrying them back. So, yeah, you're welcome. Thank you for your time, and thank you for your wonderful presentations. You too. You too. Take your plant.